हैं? हाँ, लोग आ गए हैं। लोग आए हैं। डॉक्टर प्रमोद आ गए हैं। डॉक्टर प्रमोद आ गए हैं। आई थिंक स्टार्ट करा दो। स्टार्ट करा दो। मैं आऊंगा ऑनलाइन अभी। आवाज नहीं आएगी वहां की।
Check, 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 check.
Good morning, everyone. On behalf of SGI and the organizing committee, I extend a very warm welcome to all of you for Endocon 2024. I now invite Professor Pramod Garg, President SGEI, to set the ball rolling and begin the conference.
Thank you, Savan, and a very warm welcome and good morning to all the faculty and delegates. It's my real pleasure to start the proceedings of this year's annual conference of SGEI. I can tell you that this is perhaps the largest conference being organized in Delhi, and we have more than 1,600 registrations. And this is all because of the hard work put in by Dr. Rajesh Puri, the secretary and the organizing chairman. We have a galaxy of faculty, both from India and abroad, and over 1,300 registrations from delegates. So this is, to my mind, unprecedented. And you will see that we have drawn a very exciting academic program, which is a mix of both live demonstrations and lectures. And we have given adequate time for discussion in between sessions. I would like to thank all the faculty from India and abroad who have come in from far distances and giving a lot of their time for this academic activity. Also, my thanks to the supporters and partners from industry who have given adequate support to organize this mega event. I would request all the speakers to stick to their time because the program is really very tightly scheduled, and please make sure that you stop whenever the buzzer rings that your time is up. With these few words, I will hand over the mic to Dr. Rajesh Puri, who is ready from Medanta, along with Dr. Randhir Sood. They will take over the proceedings to start the first session in Hall A, and simultaneously there will be second parallel session in Hall B. Thank you very much, and over to Rajesh. Thank you.
Are we visible in the hall? Are we visible? So good morning, everyone. Warm welcome to New Delhi and to Endocon 2024. I'm sorry I'm unable to be there in the auditorium with you in person since we are starting the live endoscopic session from the Medanta, the Medicity soon. We have several programs created, some of which are conducted for the first time here by our society, that is SGI. I will elaborate all these details in the evening, my speech. I would like to thank Dr. Pramod Garg, our president and the member of Society of Gastrointestinal Endoscopy of India, has given me an opportunity to host this meeting. Our theme of this meeting is innovation, insight, and intervention in endoscopy. I hope you will have a great time over the next 3 days. Without any further delay, we are going to start the live. I will request Dr. Sood to have few words, and then Jubin will take care and Jubin will start with the first case. Dr. Sood, please.
Good morning, dear friends. I think I'm the happiest man today because I see what Rajesh has produced. And when you see your own colleague, whom you have seen growing in front of you, create something wonderful like Endocon 2024, nothing gives you makes you more proud and gives you sense of fulfillment. And I'm sure, as I'm feeling very elated over next 3 days, you will definitely enjoy this meeting because this is an Endocon like no other Endocon before. I can assure you that. He will set a benchmark which others will have to, raise the bar higher to achieve something like this. And I welcome you all, and I am sure you will have an excellent academic feast. You will have a wonderful occasion to mingle with each other and have fellowship and enjoy yourself. So welcome to Endocon 2024. Let's begin.
I want to personally welcome you to Endocon 24, where Dr. Rajesh Puri has actually put together a very extensive and exciting program for scientific discussion on interventions, insights, and innovations.
My dear friends, it's my pleasure to invite you to Endocon 2024.
Good morning to everybody. I will start with the first case of the morning for our Endocon. This is a 35-year-old male, right upper quadrant pain for last 10 days, deranged LFTs, and MRCP shows filling defects
Dr.
in the
Zubin,
CBD.
one
The
second.
plan is for an ERCP and CBD clearance. OT1, Dr. Martin Free, you are ready, and we'll go live with our case one. Over to you, sir.
Okay, all right, well, good morning, everybody. So honored to be here. Thanks to Rajesh Puri and Nalini Gouda, is my close friend, who's done so much work to set this up. So we have a patient, young man with large bile duct stones and a normal pancreatic duct on MRI. So my approach is very different, and I'm going to show it to you. In a patient like this, I intentionally cannulated the pancreatic duct first, as opposed to bile duct, because we're going to do a large balloon dilation, risk of pancreatitis. So I have a wire. We have accessed the pancreatic duct, and this is a, can we go live?
Left one, the other one.
Oh, I see. Okay. So we have a wire in, this is a 018 wire in the pancreatic duct and a very small caliber papillatome. And what I'm going to, this wire is unique because it won't perforate side branches. If you use a standard slippery wire, it can easily perforate the genu or side branches, which can lead to terrible complications. So I just want to make sure I'm in the main duct here. So inject a little more contrast.
So, just a moment, please. Sorry for the interruption. I would like to invite the following chairpersons for the session: Dr. Amit Agarwal, Dr. Rajneesh Gulati, Dr. Manish Kar, Dr. Naresh Agarwal, and Dr. Devesh Yadav. And the moderators for the session are Dr. Amit Bhasin, Dr. Devender Singh, Dr. Bhagwan Singh Thakur, and Dr. Hitendra Garg. Please join the podium, and now we can carry on with the live session.
Okay. Are we back on? Can you hear me? No?
Yes, doctor, we can hear you. The chairpersons are just coming up on the stage. Give them around 30 seconds to just settle down, and they'll be starting the interaction soon. Thank you.
Moves down all the way.
Yeah, I'm not going to try to go deep here.
Exchange.
Yeah, I'm doing it. That's why the scope dock. See? Yeah, see, this is a good one for a short step.
Yeah.
I'll use one of mine, although we could do a Geenan 5-3 softlex. Okay, let me just get the jiggle zone.
I could do that if you want.
I got it. Jiggle zone. There we go.
Okay, got it? Hear the wire?
Yeah. And then can you load up the
Tracer?
in the Omni 21? And we're going to do
Okay.
double wire. If that doesn't work, I'm going to needle knife it. They'll let me know when I'm live again.
Yeah. Yep. Let's see. I'm gonna put this here.
So very good morning from the auditorium. Could you please elaborate that what is the right situation and what is our plan? Thank you.
Okay, so because this patient
Tracer
has
wire.
large stones, I'm
Yeah.
going to do a large
Tracer
balloon
meaning.
dilation.
Yeah.
He's at risk of posterior speed pancreatitis. So I intentionally went for the pancreatic duct with a very
Pick up the
small
flex-
caliber 018 Nova Gold wire, could be a Roadrunner wire. They're Boston Scientific or Cook. And I want to get a protective soft stent. I developed these soft stents years ago because rigid stents can cause damage to the pancreas. And especially if you do a large balloon dilation, the pressure can actually transmit through to the pancreas and cause a rigid stent to perforate the duct. So because I can't get deeply into the duct easily because of that turn, I'm not going to try. I'm just going to put a short stent in. So you got the stent on there?
This is tracer. You want to?
Oh, yeah. Sorry. I want to, my bad. I want to put the stent first.
Oh, okay.
No, you're right. You're right. I went, yeah, you're
We're
right.
gonna get the wire,
Okay.
right?
So what I'm going to do here is a double wire cannulation, which in our hands works 95% of time to get even difficult bile ducts. And I'll do that before I put in the pancreatic stent. If I can't cannulate the bile ducts, it would be surprising here, I think. Then I'll needle knife it, but after a pancreatic stent. You may know the SVI trial has shown that for high-risk patients, rectal anti-inflammatories are not adequate, and we have never abandoned pancreatic stenting as primary prophylaxis. The problem here is none of the wire in that deep. Notice I'm using the scope dock device, so I have free hands. So I'm old, but I can do many RCPs for a long time in a day and not fatigue. Also gives me more precision. So what I'm doing here is picking off the bile duct, which we'll see if that's it, and which is a tracer.
So, sorry to interrupt. If we have option for a third picture, can we have the fluoro also?
Yeah, there we go. Okay. So now what I've done is pick off the bile duct. There's bile duct, so inject a bit.
Yep.
And part of the commonest mistake with us is to get excited and shoot the wire up before you're lined up. So bow down a bit.
Goes all the way down.
Yeah. And then what I want to do is float the wire all the way up the bile duct. So this is how we do 95% of intact papillas. I use very small wires because especially the 018 wires cannot perforate the pancreatic duct. And it's widely underappreciated, as I will talk tomorrow, that just putting a wire in the pancreas is a major risk for posterior CV pancreatitis. So if you're going to do that, so now I've got double wires, bow down.
Goes down all the way.
I'm going to remove the papillotome. And the first thing we do is put a stent in the pancreas, not the first, because then it's protected. It's protected for the duration of the case. So I'm going to hold the wires, and I'm doing physician-controlled wires. So I'm actually controlling everything, as you can see with my hands. Notice I have two free hands. It's amazing what you can do with two hands instead of one. Now we're going to put the stent in the pancreas, and this, because I didn't get all the way to the tail of the pancreas, I'm going to put a short stent in with a retention flange. We could do, and this patient is not super high risk, we could do short without a retention flange, but that might fall out. Okay, and here's the stent. We designed this specifically for short ducts, and it has it has an inner retention flange that's very soft, so it won't damage the duct, and then two outer retention flanges. So, and then we use the papillotome as a pusher tube. I'm going to put the stent in first, then cut the sphincter.
Okay.
Then I'm going to
You can do
large
that in
balloon
5 minutes.
dilate it.
5 minutes or so.
Now you could argue we could have done all this just with pure biliary technique, but I live in a world where, because of the studies I've done, the complications I caused in the past, and the unbelievable series of complications I see from our region and nationally, that I practice defensive ERCP. Rather put in 100 pancreatic stents to prevent one case of necrotizing pancreatitis. And I know the patients would. So I've got two wires in here, and this is our standard. The little 018 wire is in the pancreas. The striped wire is 021 wire, and that's in the bile duct. So notice I'm holding the wire with my left hand, and So
Can
I'm
we, sorry to
prevent-
interrupt, can we
yeah.
just see that you have stabilized the ERCP scope? You have used some belt to stabilize it?
Well, the scope dock is stabilizing. I have no hands on the scope, right? So that's the beauty
can
of
we
it.
zoom
Notice-
on that once and see what is that, how you have stabilized the scope?
Well, it's called a scope dock, and Cook made it for years, and I think I heard that Ken Bildmiller invented it, but nobody except me, I think, in the world uses it. So if anybody in India with ready ability to 3D print and manufacture it wants to do this, my view is it not only makes ERCP better because it's stable. Notice the scope hasn't moved at all. So there's the pancreatic stent, and I'm going to pull the wire. Make sure I pull the right wire. Okay. So there's pancreatic duct stented. It's a soft stent. Okay. And now
I can take this, right?
yeah, I'm losing my biliary wire. Hang on.
What is the size of the stent? This looks to be a
That's
normal.
it's 4 French. See it draining? That's what you want. Okay. So now I've got the wire in the bile duct pulling out the papillotome. We're going to do a sphincterotomy, a big sphincterotomy. For bile duct stones, doing a small sphincterotomy doesn't get you anything. I'm going to do a full sphincterotomy, then balloon dilate it so that we don't have to struggle. So we should have this hopefully all done in 5-10 minutes. But this is ultimately safe. And I will show you data tomorrow that even in low risk patients or average risk in pancreatic stents, if you access PD at all, once with a wire, just single deep wire passage, that's a risk for pancreatitis that you can completely reverse with a pancreatic stent.
Go to other room for 2 minutes?
Yeah.
Can we?
Yeah, sure.
Yeah. Or should we just cut the sphincter before you go?
Okay, I think you can
Yeah.
cut the sphincter.
All right, so give me the.
Yeah, because the main aim was to show the sphincterotomy technique.
Right, I want to show, I'm going to do a very here, and we're on the 233 current, which is good.
So we'll just shift to the other case and quickly to just start that case and come back. So this is a 65-year-old female who had a lesion just near the dentate line. And this lesion appears to be a JNET 2A, 2B, and biopsy showed a tubular villus adenoma. We'll just begin with an ESD and then we'll come back to for the ERCP sphincterotomy. So over to OT4, Dr. Vanchi.
Good morning. Can you hear me?
Yeah. Good morning. Yes, we can hear you.
Good morning. So first of all, I'd like to really thank the organizers, especially Dr. Rajesh Puri, for giving me this chance to join this tremendous conference of Endocon 2024. So I've been given a task to perform ESD in the rectum for this lady. So you can see on the screen, so I've already done a little bit of diagnostic and some marking. So basically, this lesion comes directly near the dentate line. So this is already the anus and the squamous, anal canal squamous mucosa. And so you can see that here is where the dentate line is located. And on the around 6 o'clock region, you can see this lesion that is Paris, I would say 1S plus 2A components. Mainly it's 1S component. And there's some extension towards the 9 o'clock to 10 o'clock region, which you can see here. So, it expands around half circumferential in the anal canal in this region. And because of these, for the sake of better assessment of the margin, so I did some proximal marking. And this lesion can also be assessed quite nicely underwater as well as using NBI. So, and I changed to NBI, you can see the pit pattern quite well. And mostly you can see they are all villiform in appearance. So compatible with the previous diagnosis of tubular villus adenoma. So there could be some tubular component over this area, which is less villiform in the mucosal appearance. But majority of these lesions are still very regular in terms of the pits and the NBI pattern. So it's a JNET 2A lesion. And we can also assess the lesion on the retroflex view. So you can see how I put the lesion completely underwater so that I can actually see the entire lesion quite well with some magnification provided by the water. And the lesion appears bigger on the retroflexion, but I think it's because of the sessile component. So if you see the base is actually not super wide. It's mostly over this area and extending towards this side and here as well, and then towards here. And this goes back to where we already did some marking. So the strategy of resection, so I think there's little doubt that this is a good lesion for ESG because this is a regular lesion. Biopsy shows it's benign lesion. And I think on-block resection is still required. There might be some components of a high-grade lesion hidden inside. For lesions in the anal canal, personally, I like to do incisions from the anal side first because usually there might be some hemorrhoidal vessels around here. So hemostasis around the anal canal is quite important. And for that purpose, I'll need to carefully open up the mucosa on this end until the lesion will flip into the oral side.
Till you are starting, can we go to Professor Martin Freeman to do the papillotomy and you will come back?
Yes, of
So
course.
I request Dr. Jubin to go to Dr. Professor Martin Freeman. We'll come back to the other room.
Short stent in. Let's put the bow up part way. I had to put a short stent in. And one thing to orient the sphincterotome, it's a little bit, I'm going to turn the little wheel counterclockwise to get it to go up the middle. Okay.
Good boy.
Yeah, that's good. Okay. And then I'm going to go all the way up here and stop for a minute. And try not to tap it. Okay, bow up. And then what I do is periodically tease it out. And then as we get close to the top, I'm going to go through one more fold there. I'll tell you the other reason I put in pancreatic stents is about 1 in every 100 of these, you cause a perforation. And if you have a pancreatic stent in and you put a fully covered metal stent in, it will close the perforation and not cause pancreatitis, which if you do a fully covered metal stent otherwise can. Bow down. Okay, bow up. I'm going to go further here. It's quite a big papilla. But, you know, you can still, I practice for the 1 in 100, not the 90%. Pancreatitis should be 0 in a patient like this. Enough, Raj, or should I go more?
I would go a little more.
Yeah, I would too. Yeah. And notice I'm going right up the middle. Okay, and let's, okay, bow down.
Go down.
Let's try the balloon now. And if it doesn't come out, I'll large balloon dilate it, but I don't think we need to. Notice we've already, that short stent in the pancreas has an inner flange because it's short. If you put a short unflanged stent, it will fall out right away, which is no good. Some of the worst pancreatitis you will see is ampulectomy with a short stent that falls out, and then they get necrotizing pancreatitis. Probably not as critical in this case. I could have cut a lot further, by the way, but I think if this doesn't do it, I'm going to balloon dilate it.
This short wire.
But see how the pancreas is draining
short
there?
wire, right?
That's what you want. This stent will not get knocked out by the stone removal, which is another danger. So yeah, I could have definitely cut more, but let's see how it goes here. And flush contrast.
Yeah.
But I like to always anticipate the next step.
Long wire, Marty.
Oh, it is?
Yeah.
Okay, that's fine. That's fine. Let me know when you get the wire.
Yeah, I got the wire.
Okay, pull. All right, flush.
Flush. Okay.
Okay, we're gonna see we'll see what the stones look like. First, I like to sweep the bottom. So there's one stone. That's a pretty big stone.
Megan, one more.
Yeah, Meg, one more. Notice the pancreas is totally drained now. Let's put the balloon up and let's see how it comes through before we try to get the stone out.
Okay, so we're out still.
Yeah, okay, let's put it up in here. Okay, go ahead. Balloon up, lock.
Balloon up, lock.
Yeah. So that'll come through. I think we might get the stone out. Otherwise, I'll go to a basket.
Yeah.
And this will also stretch the sphincterotomy a bit. Okay, inject there. I'm going above the stone. Pull the wire back a bit. I don't know where the wire is. Yeah, okay. So these are pretty big, actually. Yeah. Okay, balloon up. I'm just going to pull these down just a little bit. I'm not going to try to pull them all out. Balloon down? Yep. Okay, and then let's go above the first stone, which is right there. Balloon up, lock. Up and lock. Okay, I think this will come out, but if it doesn't, there we go. Okay, there's one.
First baby is
Okay.
born.
Okay. All right.
And we are going to Dr. Malay Sharma room. Thank you for demonstrating the nice, and rest of the stone is going to
we'll
clear
get these out
offline.
easy.
So I
Okay?
request Jubin to shift to the other room.
Yes, so we will start with the next case. This is a 15-year-old male who had recurrent abdominal pain, and the imaging predominantly shows a suspicion of a divisum and some cystic lesion. The plan is to do an EUS, and we will demonstrate the lesion. So, Dr. Malay, sir, over to you, sir, in OT3.
So good morning. I am thankful to Dr. Rajesh Puri for allowing me to demonstrate how to see pancreas, and this is a suspected case of pancreas divisum. So when we are in stomach, broadly we are dividing the pancreas structure because the pancreas is a retroperitoneal structure.
Dr. Malay, good morning.
Good morning. Yeah.
Can we have the EUS image?
Can we
They
transfer
want to
the?
show the EUS image.
Yeah. Transfer the US image.
Yes, we are doing.
Jubin, shift the EUS image,
Yes.
please, on the screen.
Yes, we are doing.
Yeah, now the
Now
EUS
we can see. Yes.
Okay. So now what we are seeing here, whenever you are starting US, first don't move. The first thing is don't move. Analyze what you are seeing on US. So in this picture, right now what I am seeing is, I am seeing the retroperitoneum structure, and I will say this is the splenic artery, splenic vein, this is the bowel, and this pancreas lies in retroperitoneum. So broadly, when you see four kind of structure. This is the bowel, this is the pancreas, which has got an appearance, speckle appearance, like the face, particular speckle, and then these are the anechoic structure, and then these are the whitish ligamentous structure. So you see four types of structure, and the next thing you want to find out is which of them is a colored structure. So immediately you find out that out of these structures do not carry color. This one does not carry color, and this one structures. So these are the anechoic structures which carry color. This is aorta, splenic artery, splenic vein. This is the pancreas. This is the bowel. Now, we have to see this, but we want to see what else we can see. Now, here is where I will freeze the image, and I will trace that in this case, two things. Number one, I will trace the adrenal gland. This is the lower limb of adrenal gland, and this is the lower limb of adrenal gland that I am tracing. This lies posterior to pancreas, and this adrenal gland is going like this, like this, like this. I can't trace the upper limb, but this is the lower limb of adrenal gland. Second thing that I want to trace in this structure is the pyramidal shaped pancreas, which I have. This is the pyramidal shaped pancreas, and this is the pyramidal shaped pancreas, on the posterior surface of which lies the splenic vein, and on the top border of which lies the splenic artery. So now, and posterior to this is the left kidney that we are seeing. So we have taken a stock of the situation that when we are seeing this image, we have pancreas, splenic artery and splenic vein posterior to pancreas, adrenal gland, and then the left kidney. So based on this structure, we try to rotate and all this. But when we rotate, we want to remove these structures and we want to delete the structure we have written, delete. So now I will follow this pancreas by rotation. This is the pancreas. I am trying to follow this pancreas by rotation. And this is the pancreas. As I rotate it, I find out that this particular pancreas, this pancreatic duct is falling away from me. I want to reconfirm that this is pancreatic duct by a flying color Doppler, and this is in fact pancreatic duct. So what is happening? This pancreatic duct is falling, the splenic artery and splenic vein are falling away from my probe. And why are they falling? Because they are going to the tail of the pancreas. And this is what I have demonstrated now, that this pancreatic duct splenic artery, splenic vein on clockwise rotation will go to the tail of pancreas. So this particular structure, that whitish structure that I go is the linorenal ligament, which indicate that I have reached the tail of pancreas. Now I want to see this body. I have traced to tail. Now I have traced to trace this to head.
Dr. Malay,
Yes.
till you are going to the head, I request Jubin to start Michelle room, and then we'll come back once you are aligned with that.
Okay.
Dr. Jubin, you can go to the room 2 for EUSFNB.
Yes. So this is the 26-year-old female who had history of pulmonary tuberculosis, has taken ATT. Abdominal pains is 1 month. Labs are okay. And on a CT, there were some peripancreatic and periportal nodes. So the plan is to do an EUS FNB of the lesion. So over to you, ma'am.
Thank you, Dr. Michelle and Dr. Saurav, and hand over to you. Please start the proceeding.
We cannot hear you in the hall.
Just 1 second, ma'am. There is a small issue with the audio. We are just also.
Okay. I think this works.
It's better now?
Till they are adjusting.
Now it's on.
It's on now.
Now we can hear
I
you.
think so. Okay.
Hi. Hi. So we did some surveying throughout the stomach and the duodenum for a suitable site. You can see both on the
Can we have the EUS images, please? No, yeah. Now we can see the
cross-sectional pictures that you saw already that several of these nodes have a mixture of more hypodense and hyperdense texture. And so in tuberculosis, which in all frankness, we don't see very much of this in the United States, the nodes can be very heterogeneous, and I'm told by my expert colleagues at the course that you see this a lot, and that's very common because the nodes develop necrosis. And when we're doing EUSFNA for anything, whether it's for node biopsy or for malignancy, necrosis is bad, right? That doesn't give us a tissue diagnosis. It often won't give you a culture or even an AFB stain, I think. You would agree?
Yeah, so I think it won't give you the tissue you need. So you'll have to ensure that you get a sample from a non-necrotic area.
And so the area that we're in right now that you're seeing on the screen is in the hilum of the liver. And you can see, and I'm going to ask you to just demonstrate, the node that we're going to get is close to the probe, but you can see that there's an adjacent node that's coalescing with that node that is more dark and hypodense.
Right there.
And that node is probably almost all necrotic. It doesn't look like it has any normal tissue in it. But you can appreciate the heterogeneity of the node that we are going to get over. You can see there's areas that are more dense and less dense. And so this is the node that I think we're going to go after.
Yes, yes.
Do you want to talk about elastography?
Yeah, so I think with the new EUME3 with Olympus, we have the ability to also perform elastography. And this is very well demonstrated in malignant masses.
Enlarge
but
it,
yeah, I think I'm going to zoom it in. Yeah, so there you go.
Yeah.
So I think once we do elastography, we can, let me do this here. Okay, set. Okay, sorry, we'll have to just freeze it. So on elastography, you see different colors. Let's freeze it for a moment here. 1 second. Yeah, no. Let's see. Okay, no. Location over here. Yep. Okay. So for whatever reason, it's not working. Let's see. We'll try it again for a moment.
Maybe the area is too big.
Yeah, I think
maybe
so.
make it only. There you go.
Yeah.
There you go.
So I think this is the lymph node, and what we are looking at are different areas, and it's a very heterogeneous lymph node. The red corresponds to a very soft area, and the blue corresponds to a very hard area. So this patient, this lymph node is heterogeneous. You can see this is a soft and this is the hard area, and we can perform some degree of measurement. So something called a strain ratio, which I'll perform here. So you set in the hard area, and then this is the soft area of the lymph node. And what we can see is a B by A ratio, which is actually 8.16. So So this
Do you
is,
want to circle that on the screen so they can
yeah,
see
I
through?
think so. I'll show that right. Yep. So it gives you a B by A, which is a strain ratio, which is 8.16. Now we end up doing this for malignant masses, and we expect it to be above 10. So this is below 10, suggestive that it's probably not a malignant mass, and it's like a benign lymph node.
Dr. Saurabh, till you are preparing for FNB, we are going to Malay Sharma room, and
Okay.
I request
Okay.
to start the Dr. Malay Sharma room, Dr. Jubin,
Perfect.
please.
Perfect. Okay, we can get the FNB going. Thank you. Yeah. Okay.
Same
sorry.
time, what we have done is we have gone to the bulb and we are trying to see what is happening in the bulb. Once I start, the principles of imaging in the bulb are that you must first identify the portal vein, and this is the gastroduodenal artery. So once you are in the bulb and you identify this classical appearance where posteriorly there is portal vein and anteriorly there is gastroduodenal artery, you can be sure that you are in the neck of pancreas. And this is the pancreatic duct within the neck of pancreas. So now what do you do? If you rotate clockwise, you will follow the course of the pancreatic duct. And this is how we are following now the course of pancreatic duct. First, I will rotate anti-clockwise to show you that this pancreatic duct, when I rotate it anti-clockwise, is turning in the neck of pancreas and going into the body of pancreas. And this is how it is. So this is the curve of the pancreatic duct, and I can show it by application of color top. So this is the pancreatic duct in the neck. This is the point when it is in the neck. Now I want to show on clockwise rotation, how will this pancreatic duct behave? If it comes close to this wall, this is pancreas divisum. If it goes around to this place, this is not pancreas divisum. So once I rotate it here, I am following it that this pancreatic duct is coming somewhat here, but at this particular place, I find a communication of this pancreatic duct with this part, and there is another pancreatic duct, and there is presence of some sludge-like ball within this part of the pancreatic duct. So what I'm going to do is I'm going to enlarge this picture and show to you that in this case, there is a minor duct, this is the major duct coming, and then there is a sludge ball within the major duct, and this is the pancreatic duct, main pancreatic duct that is coming to the head. This is the main pancreatic. So this minor duct is coming toward the wall, and this is the communicating duct. This is the and this duct is going to the duodenum. We can feel there is some cyst-like space which is filled. There is a cyst here. I will push it here, and this cyst-like space is this cystic structure within this part of the pancreatic duct. So this is what you see here. This is the main body pancreatic duct. You rotate anti-clockwise. You follow it all the way, making like a hook. Now you rotate it clockwise. You follow this duct, and this duct is going close to the wall of duodenum as I move my scope. And this is opening at the minor papilla in the duodenal wall.
Thank you, Dr. Malay. And we go to the EUS FNB. I request Dr. Jubin to shift to Michelle room.
Hello. Okay.
Hi.
I think we're on.
Are we back?
Yeah.
Hi.
Yeah, it looks like we're back. Yep.
So we've inserted the needle. We're using here a 22 gauge sharp core needle, and a couple of good teaching points for people, especially if you're new to doing F&B. This needle, all needles, in fact, that do EUS FNA are the distance that the sheath should be out from the end of the scope is set by the scope manufacturer. This is an Olympus EUS scope, and so for this particular needle, we want the setting to be at a 2 on the sheath. If you see, I'll demonstrate real quick. If I change that and pull that back, it pulls the sheath out of the view, and now we don't see it on the EUS screen. Can the audience see the EUS screen?
Mm-hmm.
Okay, so,
yeah.
you want to make sure that that's to the manufacturer specification. Here are the 2. because you can damage the scope, and cost to repair EUS scopes is higher than any other scope that we have. So we have this on the correct setting. The other feature that this particular needle and many EUS FNA needles have is to make it sharp. So I'm going to unlock the safety lock that determines the depth. I'm not worried about this. If we could turn on the Doppler briefly. We always want to make sure that there's no blood vessels, major blood vessels. There's some tiny ones up here in the pathway of the needle, right? Okay, you can turn that off now. And one of the other teaching points is if we don't use the elevator and I were to advance right here, that needle's going to skid across the top of the node and not give us a good insertion into the node itself. So I've got my elevator on a little bit, not hard, and I've got my needle is at the end of the sheath. You can see it. I'm making the needle sharp by pulling back the stylet, and I'm seeing the needle the whole time that it's entering into the node.
Yeah.
So we're going to use a technique called slow pull to do this, and the stylet coming back will create the negative pressure to allow us to get a specimen. And so I'm going in, I'm going a slow withdrawal all the way to the edge, not coming out, because I don't want to contaminate. And right now what you're seeing is a fanning technique that I'm using to get the specimen.
How many passes do you recommend? How many passes should be done?
So we haven't done, this is our first one, but in general, if you don't have on-site pathology, rapid on-site evaluation rows, then you should do a minimum of 4 passes in the setting of malignancy. I don't know if there's any data for tubercular nodes, is there?
No, I think it's now with all these new needles, I think we go by macroscopic assessment if you don't have rows, and that works quite well as well in our experience. But if you have rows, it works best. Otherwise, on macroscopic assessment, if you see there are 2-3 passes, generally suffices, yeah.
And
the question was also how many jabs do you do in a one?
Oh, we do it till the stylet's almost out. So we're almost at that point here.
Yeah.
And I don't pull it all the way out because I use the stylet as we reinsert it to express the specimen. So we're going to stop here. I'm going to withdraw it with no elevator on. I'm going to lock it. And if the camera could zoom, I want to show a special feature of this needle that makes you very efficient in the endo unit. So we're not going to take the whole thing out. We're going to release it by pushing on the side button here. And now that allows me to actually take the needle, leaving the stylet and the casing inside the handle. Don't pull too hard because you'll bend it. There's a last part, and now the whole needle is out. It has a safety guard on the end. Where am I here? That you can see to protect the text, so you're not going to poke anybody with it. So I'll pass that off, and we're going to express that, and we'll show you the specimen in just a moment.
Michelle, 2 questions here.
Yeah, go ahead.
So one, with shark core, I've seen a lot of bleeding. Especially to the duodenal wall. I have a couple of cases who presented with hematoma like days later.
Yeah.
Excuse me, can you focus on the sample which has been taken?
It's safe enough to be used everywhere.
I use this needle preferentially above all of the other needles, with one exception. Okay. The exception is if it's a fluid-filled, cyst or something like that, then I'm more likely to use a needle like the Acquire with a negative suction after it. I have not experienced a lot of bleeding, but when I have, or if it's a lesion that is hypervascular, like a neuroendocrine tumor, which are very hypervascular, then I go to a 25 gauge needle. Yeah. And I experience less bleeding. Do you have a different experience?
So I've moved away from this because of the.
So thank you, Dr. Michelle, Dr. Saurabh and Dr. Rajiv Atam. We are shifting to Professor Honchi room for the rectal ESD. So I request Dr. Jubin to shift the room to the rectal ESD.
Welcome back. So we've already started the incision, and this is what we have. So as I mentioned, I wanted to get through the rectal part, the anal part first. So that's why I made the incision deep in the rectal part. So just now when we were off air, there was quite some bleeding. So as you can see here, there were quite a lot of hemorrhoidal vessels, which I had to use a coag grasper to control. So I think before I end the procedure, I will still to control these once more, just to avoid major bleeding, delayed hemorrhage. But you can see that once I get through the anal part, the rectal part will become easier because the plane of dissection is easier. The muscle will be less in the way, but you can still see this vessel here. I think this is one of the larger vessel. Okay, knife out. So I will need to control this later. Hopefully that will not cause a major bleeding here. So the key here is to identify where the muscle is located so that you dissect above the muscle. So identifying the correct layer of dissection is very important in an ESD procedure. And now you can see with underwater technique, you can basically observe directly where the muscle is on the left side around 9 o'clock region and then dissect around this.
Planche, do you think there is addition or this is due to the coagulation we have used? So vessels are like the layers are not that visible.
I think in the rectum, though, so because of the vascularity, so it will make it much more difficult to see the exact plane. So once you coagulate them, then the view will become less obvious because the vessels are coagulated. There's a coagulum over that area. So it makes it difficult. But I don't think this lesion is particularly has a particular fibrosis. I think most of the rectal lesion appears in a similar way. But just that you need to be patient and dissect through this hemorrhoidal tissue, then you'll be able to get through.
What is the maximum size of polyp you can remove?
Sorry?
What is the maximum size of polyp which can be removed by
I don't
ESD?
think can you inject? I don't think there's any size limit. Basically, it all depends on your histology prediction. So most importantly is whether you're sure that this is a suitable lesion for ESD. Because if you cut a cancer, then obviously whatever you do, you're not going to cure the patient from the lesion, from the cancer. So I think that's the more important aspects of management rather than the exact size of the particular lesion. So
Professor Honchi?
Yes.
We are going to the other OT for 1 minute.
Okay, sure.
Just to show the specimen, I request Dr. Jubin to shift to the Michelle endoscopy room. Michelle, you are online.
Yeah.
Can you show the specimen?
I will. Is it the patch here? Hi, so I just wanted to demonstrate for the audience what the specimen looked like. We just smeared it, but before we smeared it, it looked like a tiny little white worm. And you can see the white smear across, and I'm told by my colleagues much more experience with tuberculosis that this is diagnostic for a tubercular lymph node.
Dr. Michelle, can you focus it because we can't see it, the smaller icon.
Can we cameraman focus? Yes. No, on the left side, Michelle, on the left. Yes.
This
Now,
side?
yeah.
Right. Now we
this is better. Can we show the specimen also, FND specimen?
the vial also.
I don't think they've put one in a jar yet.
Do we have any specimen?
Not in the jar, just the smears. We're
So
gonna do one for the
take
jar.
the next pass. We will come back.
Okay.
And we shift to Professor Honchi OT, please.
Okay, we can do that. Thank you. They want to see it in the jar, yeah?
Dr. Jubin?
I sometimes will use
Dr. Jubin, please shift to the ESD.
I don't think it's a must. So it's just no, I don't use. Actually, if you don't use, you can still see.
You can see the muscle very
Yeah, you can still see it very well. So that's why my personal preference.
Dr. Honchi,
or-
you
actually,
are
this is something
back
I learned
online.
from my teacher in Japan.
Professor Honchi, you are online.
Oh, hello. So can you see the view? So I can see the submucosal layer quite well now. So I'm trying to cut through this a little bit more fibrotic part so that I can achieve the view in the deeper layer. So I believe just right underneath this lesion, there's some degree of fibrosis. So that's why this part is a little bit more difficult and challenging to dissect.
Dr. Haji, which type of knife you are using for our information?
So for this particular procedure, I'm just using the Olympus Steel Knife J. I think it's a very handy tool for dissecting. This is a short knife, 1.5. Yes, inject. Thank you. So this is a short knife, 1.5 mm. So I think it's suitable for most colonic procedure. And I personally like it also in the rectum, because if you encounter like vessels, then the short nature will make it less likely that you will injure deeper vessels that you encounter in a deeper layer. So this is my own preference. I think basically for most rectal lesion, I think most experts will like to use a needle type knife to begin. Whichever your preference, I don't think it matters.
Professor,
Yes.
we are going for a 1 minute.
Okay.
Jubin, please shift to EUS FNB session to show the specimen, please. Can we switch over to EUS FNB? Dr. Jubin? Yeah. Michelle, can you show the specimen, please?
Yes, we're going to express it maybe by your blue. Yeah.
Yeah, it can be focused little bit more. It's
Can
in a small
cameraman
icon.
enlarge the
Put the
image?
stylet back in.
Can enlarge the image, please? Furthermore, enlarge.
There it goes. Yeah. Keep going.
Can you
Yeah.
make the external image
It is in the
bigger?
See
small icon.
really zoom in on the
Yeah,
tip
yeah. Now it is in the main picture.
Whitish.
with a little bit of blood too.
Yeah.
It's back in. Yeah, go ahead. Now we're going to use some air or saline through
Yes.
to express it into the jar. Is it through? Ah, there we go.
Thank
Wonderful.
you, Professor Michelle. And we go to Professor Honji.
Looks a very nice piece.
Saurav. Thank you, Saurav. Thank you. Jubin, can we go to the
But we
ESD
use
room, please?
in our hospital,
Thank
we
you,
don't have
Professor
the
Michelle.
Japanese muco up, so we have to use the. Oh, sorry, there's some bleeding, so we'll change to a coax grasper to stop this bleeding. So there were two vessels on this side that is bleeding, causing the bleeding. So the trick is to apply the cap just to press on it. So hopefully that will slow down the bleeding and allow you time to change your instruments. And once you're back with your coax grasper, then you can just move quickly towards the bleeding sites and hopefully stop the bleeding. Okay. Out, open. And I think it's here. Okay. Close. Have you changed? Okay, open. Close. Still a little bit. Still a little bit here. So open. Close. Okay, open. Close. So now I think we've passed through that part and the bleeding has slowed down. I think that the elevation is not ideal, so I will inject a bit more. So can I have the needle now this time? So I can do both the needle injection through the knife or injection using the needle. But sometimes if the view is not particularly good, I would prefer to use the needle, just to needle. Just to help me to gain a better view of the correct dissection plane.
So do you prefer underwater ESDs most of the time, or what is your recommendation? When should we
Actually, I
use
like
underwater?
underwater quite a lot. So because underwater you have both a magnified view and also a very stable view. And in addition, sometimes if you use underwater, the buoyancy within the water will help to lift up the lesion. As you can see here, I didn't need to do much, but the lesion already lifted up. Okay, needle out. So I do like, okay, inject. Okay, needle back. Needle out again. Needle out. Inject. Okay, needle back. Needle out. So the problem with inject. The problem with underwater is if it bleeds torrentially, it could be sometimes challenging. Okay, needle back. Yeah, correct grasp one more time. So it could be sometimes at times challenging because the water will be so red that you can't really see it through. So so the key in underwater procedure is hopefully you prophylactically coagulate any vessels before it occurs. Then maintaining a clear dissection environment will help. Okay, open. Close. Okay, open. Open. Close. Open. Close. Okay, open. Close. Okay, knife.
Do the previous biopsies make the job difficult?
Sorry?
Do the previous biopsies from the polyp make your job difficult?
I don't think so, unless it's a very aggressive biopsy with multiple large bites. So, but nowadays, I think most endoscopists has been well educated not to do extensive biopsies for okay, need a knife out for potentially ESD amenable for ESD lesion. So unless you're doing a very extensive biopsies or large bite biopsies, otherwise, I don't think just doing a biopsy would have a significant effect on the ease of the procedure. So, but of course, it's still, there might be a little bit of fibrosis underneath, but I don't think it will be very bad from the biopsy. So, but sometimes for colorectal lesion, if there is a large sessile component, sometimes you would encounter a lot of fibrosis because that piece of fibrosis, the floating nature of that sessile component may cause a lot of fibrosis underneath the muscle layer, in the submucosal layer, but not necessarily. Yeah.
So, Professor Honchi?
Yes.
So, I think another 2 minutes, we are going to the main hall for the lectures.
Okay.
So, you want to conclude in 2 to 3 minutes? You want to give some last minute comments? Please go ahead with that.
Okay, so I think for rectal ESD, the message that is most important is to make sure that the hemostasis at the hemorrhoidal area is well controlled. I think once you get through that part, the procedure will become smooth and much more easy to do. So as in this case, the initial part is always most difficult. But
Dr.
once you
Hanchi,
get
you are
through,
planning
then
to
it
do
will be
entire
okay.
procedure from the anal direction?
Yes, yes. So it's better to start from the anal direction to control all these hemorrhoidal vessels first, so that it will bleed less and help you to dissect through in the subsequent part.
So how do you compare the anal direction from the retroflexed scope when sometimes you have to do retroflexed
Yeah,
positioning?
so for the oral side, you will need to do it with with a retroflexion. But so for instance, once I get into a nice pocket in this case, then I would change to a retroflexion position and open the oral side mucosa in a retroflexion position. So I'm getting through this fibrotic part and probably very vascular part. You can still see the vessel beneath it. But generally speaking, I think rectal ESD is quite safe because here, even if you have muscle damage or muscle perforation, unless you're really having a very extensive muscular injury, otherwise.
So thank you, Dr. Professor Haunchi.
Yes.
And I request to start the lectures in the hall, and he is going to continue. And once he is going to finish, we are going to talk in the evening, or we are going to show that this is finished. Thank you, Professor Haunchi,
Thank
for the
you.
live demonstration. Thank you.
Thank you, chairpersons and moderators. Our next session is going to be the SGI AEG Advanced EUS session. For this session, I invite the expert moderators, speakers, and chairpersons on the stage.
Unless it's really big and difficult, I think otherwise.
I request all the speakers and chairpersons to stick to
rectal
the
on
time
sometimes.
limits.
But I actually nowadays
I would request the chairperson to
because
invite the
traction
speakers.
often have some limitation. You always need to change
The
device.
expert moderators, Dr. Nilay
Use
Mehta,
a rubber band
Dr.
or something.
Nilesh
So I prefer
Fernando
to
Pule,
use
the chairpersons, Dr. Nirmaljeet Singh Mali, Dr.
pocket
Vishwanath
if
Reddy,
I'm
Dr.
using
Vaishali Bharadwaj,
for
Dr.
right
Neel Kamal
colon.
Yadav, Dr. Manoj Yadav,
Maybe fibrotic
and Dr. Dinesh Kini.
use traction.
Yes.
Can't see that.
Good afternoon, everyone. So we are straight into business and we are talking about something really advanced as far as EUS guided procedures are
Now you
concerned.
already see the
So we are covering
normal
with
layer.
pancreatic duct intervention, portal dynamics, which probably is the in thing, and I think it's going to stay for a long, long time, and gallbladder drainage and other things. So may I invite the first speaker, Nikhil. Everybody knows Nikhil, and I'm not going to discuss too much. Nikhil, can you please start your presentation?
Thank you, chairpersons. Thank you, SGI and Team Endocon for this opportunity. So I'll be talking on EUS guided pancreatic duct interventions, techniques, and evidence for efficacy. I feel this is one of the most complex interventional EUS procedure. This will be the flow of my talk. So EUS guided PD interventions are analogous to biliary interventions in the sense the clinical scenario where we do this as technically it is similar to biliary drainages where you access the duct, create a fistula and use. But there is a caveat. PD interventions are more complex and more chances of failure as compared to biliary interventions because there's lack of experience. Even in high volume centers, the average cases must be around 10 to 12 per year. It is more challenging because of various reasons like guide wire tends to pass to the side branches, the firmness of the pancreas in a setting of chronic pancreatitis, less favorable orientations of pancreatic duct, and lack of dedicated device. So always assess surgical candidacy attempting this procedure. The classic situations where these are required is failed ERCP in a setting of chronic pancreatitis with pancreatic duct obstructions. Other indications include pancreatic duct
difficult lesions, sometimes it will really take a
pancreatitis.
long time.
The other scenario is post-surgical patients like post-Whipple's, post-gastrectomy, or ruined by anastomosis with anastomotic strictures. So again, EUS guided PDD only for suboptimal surgical candidates or those desiring minimal invasive approach. Contraindications are similar to other interventional procedures like coagulopathy, lack of window, large vessels, and ascites. So the basic types of EUS guided PD interventions include rendezvous technique, where like for biliary intervention, we access the duct either mostly from the gastric side and we pass the wire through the papilla and you change the scope to side wing scope and then do a anatomical drainage. The second option is antegrade stenting, where you pass the wire and through the pancreatic duct into the either jejunum or duodenum, and then you stent across that, providing a ring drainage. And the last is transmural drainage, when the wire doesn't go beyond the stricture or the papilla, and then you drain it into the stomach or into the duodenum. So the basic algorithm approach is, if you have a pancreatic duct obstruction, you assess for anatomy. If it's a normal anatomy, you attempt an ERCP. If it fails, then you see whether the papilla is accessible or not. If yes, then you attempt for rendezvous procedure. If it fails, then you go for transmural drainage. If the papilla is inaccessible, then you attempt an antegrade procedure. If wire doesn't go, then you go for transmural drainage. If it's an altered anatomy and the papilla is not accessible and the wire is not passing, then the last option becomes transmural drainage. So before you attempt, you should have a good cross-section imaging to give you a roadmap. You should have an expert person attempt the ERCP. If required, give a second attempt. You should have skills both in ERCP and EUS, and a multidisciplinary approach with a backup option should be there. So you plan your procedure with the technician, because there are some minute nuances which your technician should be aware. You give antibiotics, keep patient give good sedation, because most of them are alcoholic chronic pancreatitis. So you need a therapeutic EUS, you need CO2, you need electrosurgical unit. 19 gauge needle is commonly used. In some cases, 22 gauge needle can be used. A 0.025 Visiglide wire is commonly used, or option is Teremo. Dilatation, there is option of balloon versus boogie versus cautery dilatation. In our scenario, we mostly commonly use cautery. Stricture dilatation, for which you require a balloon. And the stents, we use the usual pancreatic stents, but there are centers which have dedicated stents as well. So the basic steps is, you identify the access route, transgastric or transduodenal. You do the needle puncture, 19 gauge. You take a pancreatogram, insert your guide wire, dilate and stent. But it is not as easy as it sounds. I'll go to each step one by one. So transgastric, difficult to maintain scope stability, difficult instrument exchange, but better MPT visualization. Transduodenal, long scope position, better stability, but then angles are difficult for rendezvous and GDA may cause a problem. This is the most time consuming step, where you have a comprehensive evaluation of at which angle you should puncture. So for a rendezvous technique, you puncture at the head and neck junction, and you have try to have an as straight angle as possible between the duct and the needle. But if you are planning a transmural drainage or an antegrade drainage, you need a long wire inside the pancreatic duct. You need to loop the wire, so you puncture slightly distally. So the first image, you have a perpendicular axis, which is a wrong position. The second image, when you have a kind of parallel axis between the needle and the pancreatic duct, which is the correct position. Depending upon the scenario, if you are planning a rendezvous or an antegrade transgastric, your scope should direct towards the head. If you are doing a bulbostomy, the scope directs towards the body and tail. If you are treating a disrupted duct towards the tail, then your scope should direct towards the splenic area. So 19 gauge needle is most commonly used because it can accommodate a 0.025 wire, and you have a better contrast injection. 22 only when less than 5 mm duct. Select trajectory and measure the length to the targeted duct. You may need to have a fast puncture because of fibrotic tissue, the needle bounces back. Pancreatogram, you dilute it, avoid, inject minimal amount, try to avoid, minimize your aspiration and slowly inject the contrast, otherwise you may fall out of the duct. And after the contrast you obtained, you have to do a saline flush. So guide wire manipulation, I personally feel the shearing of guide wire occurs more in PD interventions as compared to biliary intervention. So instead of push and pull movement, try to do a rotatable movements. The similar techniques like lever impaction techniques can be applied here also if you think wire is getting stuck, but never try to have a rapid push and pull movement, otherwise wire shearing will occur. For rendezvous and antegrade, wire goes to the duodenum. For transmural, you loop it and keep inside the duct. Again, dilatation is difficult because you have to go through gastric wall, pancreatic parenchyma, duct and anastomosis. The trick is you apply this force in the same direction as your puncture. Check your fluoroscopy to see the direction of scope has not changed. Keep your guide wire deep and try to have EUS view of wire. Even after keeping all this precaution, sometimes the whole system comes out. Cystotome, what we commonly use, has an inherent risk of burn effect, which can lead to pancreatitis. Stent, commonly used are 5 French and 7 French. Some reports have used metal stent as well for anastomotic strictures, and then you upgrade the stent 1 to 3 months. There are dedicated plastic stent which is not commercially available to us. So this is one of our cases we did a couple of days back. In a chronic pancreatitis with pancreatic divisum and tight stricture where ERCP was failed, you get a good longitudinal view of the PD along the neck. You measure a distance which was 1.5 centimeter. I had used a 19 gauge Cook access needle in this case, which minimizes your shearing because the stylet is the sharp thing which punctures, and then you remove the stylet when you are manipulating the wire. So after confirming the position with pancreatogram, wire manipulation was done. The wire, once it goes into the duodenum, you loop it, then you slowly take out your EUS scope. When you exchange with side wing endoscope, you can see the wire coming out through the minor papilla. And by the side cannulation we were lucky enough to have cannulation by the side of the existing wire, otherwise you would have had to catch the wire inside your US side wing scope. Once you confirm the position with pancreatogram, you remove the rendezvous wire. And then the procedure is usual as ERCP. This is another case of PJ stricture where access was difficult because the needle was perpendicular, but very carefully after the access, the scope was pushed so that the needle and the scope becomes parallel to the pancreatic duct, and then the instrumentation was done. This was one of the cases when I was learning this procedure. It was done by Professor Song at Asan. Whipple's patient with recurrent pancreatitis due to pancreatic jejunostomy stricture. Again, a good position in the body. 19 gauge needle was used, then contrast injection was done, and careful guide wire manipulation across the stricture. Cystotome was used to create fistula. So when passing cystotome, you should try to keep the wire on EUS visible. Then the balloon was used to dilate this PJ stricture site. And again, cystotome was passed across that. Then a 5 French 9 centimeter stent was placed. This is an example of pancreatico-bulbostomy. This case was done by Vinati sir. So it's a dominant stricture in the head with failed ERCP. Access was made in D1 in long scope position using 19 gauge needle. After aspiration, contrast injection was done. Then Termo guide wire was introduced. Then needle was removed and cystotome was introduced over it. And then a wire was exchanged and stent was placed. So when you are trying to upgrade the stent, instead of taking out the stent, you try to go by the side of the stent because the angulations are difficult. People have attempted doing lithotripsy as well using the metal stent. So what is the evidence? So pooled technical success is 78.7%, clinical success of around 70%, and adverse event rate is around 21.8%. There's a large series from India by Dr. Ankit and his team, where they have shown that overall technical and clinical success is 88.6% and 81.6% respectively. In them, the rendezvous technique had a 95% success as compared to pancreaticogastrostomy, which has only 77% success. The adverse events that we encounter is bleeding because of cautery dilatation or too big balloon dilatation, perforations if the wire slips out after successful dilatation, stent migration if the stent is misdeployed, the tract is too tight, PD leak, and pancreatitis. So to take home message is rendezvous technique preferred, low complications, pancreatico-bulbostomy only when MPD stenosis in the head, and last option should be pancreaticogastrostomy. So there are a lot of unanswered questions. What dilator should be used, balloon versus boogie versus cautery, routine stents or dedicated stents, immediate post-procedure, most of the patients have some amount of leak, do we need to do a CT, follow-up strategy, in the follow-up cases you try to do a rendezvous or you keep repeating the stent exchange, and what is the rescue strategy in case failure or complications. Thank you.
Thank you, Nikhil. An excellent talk. You made it very simple and it looks very simple, but you get problems at every step,
Yes,
right?
yes.
So what problems do you get while, so puncturing is easy, putting a cystotomy is easy, What difficulties one will
I
have?
feel there's no step easy in this. Identifying the right site of puncture is the most time consuming, and you should dedicate it at least 5 minutes in that. So when we put the scope inside the stomach, the access site comes from the proximal part of the stomach, which is a mobile area. So what trick I do is I go to the D2 and then I shorten the scope so that the puncture site comes in the middle part of the stomach, which is relatively stable. After you puncture, you try to slowly push the scope so that you get that parallel access between the scope and the needle and the PD. Wire manipulation, again, a combination of a good technician and your stability is important. Then there's the Achilles heel, I feel, is the dilatation. Because of the fibrotic pancreas, you have to go through so many structures. So the tips that I told, you keep the scope direction on fluoroscopy and EUS wire on your view constant, and try to puncture, push the cystotome in the same direction. But still we have cases where the cystotome just falls out because of the thick fibrotic pancreas and a lot of calcification around. And once you have the wire inside the PD, you have to loop the wire nicely so that you don't get lost. Most of the complication happens, you have dilated, and once you are exchanging, the wire loops out and there is pancreatic leakage. If you are able to reach this stage, then stenting is relatively okay to be done. But reaching this stage is important.
So there is a problem at every stage, and I would not recommend it to be done by someone who has just started US guided endotherapy, because many a times we put a wire. So putting a needle is probably the easiest part of it, and then wire manipulation comes. Sometimes you go towards the head, but the wire comes back to the tail, and then it's quite a jugglery. And the maximum problem I have seen is pushing a cystotome.
Exactly, that's the case.
Because it doesn't go just like what you do in gastrostomy. The stomach moves.
The consistency of pancreas is so heterogeneous that it can get stuck at any point.
And then you lose wire, and so it's not so easy as what
I think wire sharing is more in PD drainage as compared to.
So any questions, any technical problem? Okay, so thank you, Nikhil. We'll move on to the next talk, and the next talk is on portal vein intervention, and we are fortunate to have Anthony. Anthony is a master of endoscopic ultrasound and endoscopy. He has been pioneer in many endoscopic procedure, mainly lumen opposing stents, gallbladder drainage, and he is also into this portal venous intervention. So and this is what I think has the maximum potential. So again, we are fortunate to have Anthony over here. Please go ahead.
Thank you so much for your kind introduction. So today I'll be talking about US guided portal pressure measurement and its future applications. These are my disclosures. So as we know, liver cirrhosis is this description of the liver for the yellowish color of the diseased liver. It affects many people around the world, as well as in India. And in patients with high portal hypertension, they have increased risk of hepatic encephalopathy, varices and bleeding, hepatocellular carcinoma, and mortality. So throughout the years, we have seen many development in terms of measurement of the severity of cirrhosis. We know the gold standard would be an invasive method, which is the hepatic venous pressure gradient. This procedure is quite invasive, so actually for patients, they need a lot of preparation, and actually as clinicians, it's not easy to perform this. So as a result, we have tried to look at various ways to measure the severity of liver cirrhosis, either through clinical or biochemical means like the Child-Pugh score and the MELT score, and most recently the non-invasive imaging like the FibroScan. But however, we have seen in the last few years an increasing popularity of using endoscope to assess the severity of the liver cirrhosis. So as a result, the term endohepatology has come up, and we have seen the application of endoscopy in various ways to assess the severity of portal hypertension. And in terms of endoscopy, we can do many of these procedures with one single visit, like endoscopic surveillance of varices, US guided liver biopsy, US portal pressure gradient measurement, so that we can give a package to these patients, and a one-stop means to assess the severity of the cirrhosis. So why is hepatic venous pressure gradient important? As a radiologist, when they measure the hepatic venous pressure gradient, they actually float a catheter from the internal jug all the way down to the hepatic vein and have the catheter there. So they do two measurements. One is the balloon wedge pressure. When they inflate the balloon pressure, it should equate the portal pressure. And then they have another measurement, which is the free hepatic vein pressure. And this is the hepatic vein pressure. And by calculating the difference between these two pressures, then they get this hepatic venous pressure gradient. So we know the hepatic venous pressure gradient correlates with many signs of cirrhosis, like in patients with varices, large varices, and those patients with bleeding varices, they have a high high hepatic venous pressure gradient. In terms of mortality, high hepatic venous pressure gradient also predicts mortality. Hepatocellular carcinoma, patients with high hepatic venous pressure is also at high risk of developing hepatocellular carcinoma. And also in terms of after surgery, if they have liver resection, any patient with high hepatic venous pressure gradient also more likely to develop liver decompensation. And there are many other ways that the hepatic venous pressure gradient may influence clinical outcomes. So as a result, it points out that US measurement of portal venous pressure gradient may be quite useful. And in terms of US, we are actually measuring the true portal venous pressure gradient. We insert a needle into the hepatic vein as well as the portal vein and directly measure the pressure differences between the two veins. And from Ken Chan's initial study comparing US versus a transhepatic measurement, he found a very good correlation between the portal venous pressure as well as the transjugular hepatic venous pressure. In terms of how to perform US guided portal venous pressure measurement, patients usually are placed in the left lateral position. We prefer deep sedation because as the patient coughs or even becomes more aware, the venous pressure changes. After deep sedation, we usually insert the linear scope and identify the portal vein and the hepatic vein. In patients with cirrhosis, the liver actually changes shape. And sometimes the portal vein and the hepatic vein may not be easily seen or accessible by EOS. The hepatic vein is usually very small, maybe 1 millimeter, 2 millimeter, 3 millimeters, and may not even be seen in very cirrhotic livers. And in terms of the left portal vein, sometimes it also cannot be seen because the liver undergoes hypertrophy. And in those situations, we may need to insert the scope to the duodenum and assess the right system. The pressure transducer is placed in the right atrial level, so I usually place a cloth at the right atrial level. And where I would stick the device with a tape to the cloth to secure the position. Afterwards, I would puncture the hepatic vein and portal vein. For small veins, I usually use the overshoot method. So you puncture the vein, overshoot, do a double puncture, and then pull back the needle slowly so that the needle would be inside a very small vein. And you need to remember we are using a 25 gauge needle without stylet. So after the first puncture, there might be some liver tissue stuck in the needle. So usually after the first puncture, when we do the first measurement, I will inject a lot of saline so as to flush out any possible tissue that is stuck in the needle. And I will perform 3 readings for every vein and calculate an average of each reading. So for your information, a portal venous pressure gradient should be normally between 0 and 5 millimeter mercuries. And if it's more than 10 millimeter mercuries, there's increased risk of developing esophageal varices. And if it's more than 12, then there's increased risk of variceal bleeding. So this is a patient, 61-year-old, child species cirrhosis on antiviral since 2014, converted in 2015, but developing worsening cirrhosis. OGD for esophageal varices surveillance showed 4 columns of grade 2 OV, and then banding was done. So in these patients, we are recruiting them for a study to see whether we can change the portal pressure gradient through the use of medication. So if they have presence of varices requiring banding, then we will recruit these patients. So this is the patient on OGD. And the patient also had previous CT, which is useful because if they have access to a CT, you can plan your puncture. So from here, the stomach seems to be just, the hepatic vein seems to be just visible at the upper end of the stomach. But for the portal vein, it should be easily puncturable from the stomach. So this was a live case. So right here, you can see the scope is in the OGJ level. We can see the portal triad right here. This is the portal vein. Usually it's surrounded by white capsule, the Gleason's capsule. And the idea of puncture is that we have to go through a bit of liver parenchyma. So you don't want to do a direct puncture from here, for example. You want to go through a bit of the liver. And here you can see a very dilated main portal vein, and then you can see all these very active extraesophageal varices. So in terms of the hepatic system, hepatic vein, so this is the hepatic vein. You can trace it to the insertion of the IVC. I'm doing a measurement here. This is 2 millimeters. But from this angle, although it's only 2 millimeters, the needle path should be on this direction, so the puncturing should not be a big problem. In terms of where to puncture the hepatic vein, if you borrow the concept from radiology, they would puncture at the bifurcation around 2 centimeters from the bifurcation. So this is the IVC. You can see this is the intrahepatic portion of the IVC. And in case you have problems puncturing the hepatic vein, you can actually puncture the intrahepatic portion of the IVC to do a measurement. Okay, so right here you can see my needle going in. And once inside the needle, the vein, we inject a lot of saline. You can see my pressure transducer there. And I would inject saline to flush the needle. You should see saline or air bubbles coming out from the needle. And I would do 3 measurements. So usually you need to wait for around 1 minute for it to stabilize. So here's around 1 millimeter mercury. So there are 3 measurements, 1, 2, 2. And then on withdrawal of needle, there is no more blood coming out from the puncture site. So I move forwards to puncturing the portal vein. Again, you puncture through a bit of liver parenchyma and enter into portal vein. The portal vein is usually not problematic. So again, you can see the pressure gradient coming down, and we do 3 measurements. And this is the portal venous pressure gradient. So in terms of future applications, we want to see the correlation with variceal bleeding, risk of bleeding, and also whether the use of beta blocker can influence the changes. And currently, studies are ongoing to assess these future applications. So in conclusion, endoscopy has an increasing role in assessment of liver cirrhosis. USPPVGM adds a powerful tool to quantify the severity of liver cirrhosis, and further studies are required to evaluate the clinical role of the procedure. So thank you for your attention.
Thank you. Thank you for an excellent talk. It's open for discussion.
Sir, do we directly measure the portal vein? That should be sufficient. Why do we need to puncture the hepatic vein, sir? Because in that IR procedure, they do both pressures to just calculate the gradient and that would reflect the portal pressure. Here we are directly measuring the portal pressure. So do we really need to measure the hepatic vein pressure?
So you need to assess the difference between the portal vein and the hepatic vein. So the hepatic vein may not be always zero. Sometimes it can be raised, and then depending on the patient's clinical status, if they are more awake, actually the hepatic pressure will be higher. So you actually need to measure both the hepatic vein and portal vein to calculate the difference.
Does sedation affect the portal pressure, sir?
There will be sedation effect. So if you do it under conscious sedation, the hepatic vein pressure will be significantly higher.
Anthony, you said if left is not possible, do right. How do you go about right?
So you do a transduodenal approach. So you insert the scope into the duodenum, and then you visualize the right hepatic vein, the right lobe of the liver, and then usually from there you can see the right portal vein as well. So you can do that. And then we have also experience puncturing the right hepatic vein from the duodenum as well. So, but it's not possible in every single patient. So it depends on the anatomy.
So one more question, sir. Is puncturing through the GE junction, we are very concerned about the varices in that area. Although we put the color Doppler, they may get compressed while the application of the EUS probe. So how do you take care of that?
So of course, if you compress very hard, the varices will go away. So always before puncture, relax your big knob, have a look at the paraesophageal or the submucosal varices. And then after puncture, also always look at the puncture site. If it's bleeding from the gastric side, actually you can easily control the bleeding with a clip or injection.
Any questions from the audience, please? If there are no questions, we'll move on to the next talk. Thank you, Anthony. The next talk is by Dr. Yeah.
Yeah, I'll just take the hall for half a minute in OT4. We are just about to finish with the EST. Dr. Honchi, if you can just see your live for half a minute only, we'll go back to the hall then.
So we are almost done here. So just to show the progress. So I've already made a reasonable dissection on the anal side. You can see almost the lesion has been completely inverted back into the oral side. And also I already made the incision on most of the oral side as well. So all I need now is to dissect from the anal side and connect the incision, then the lesion will be completed. So unfortunately, I couldn't show the entire procedure. There's still a little bit remaining, so which may take me about 15-20 minutes more.
Thank you. Thank you very much, sir. Thank you. We can go back to the hall now. Thank you.
Thank you. The next talk is by Dr. Ankit Dalal. He is from Mumbai. He is with Dr. Maide's group. I don't see him.
I'm here.
Oh, I'm sorry. Yeah. So he's going to talk on a very interesting topic that is gallbladder drainage, whether to do it endoscopically or US guided. Ankit, please go ahead.
Thank you, chairpersons. Thank you, SGI, for this opportunity. So I'll be talking about endoscopic drainage of gallbladder, whether to use EUS and lumen opposing metal stents or go transpapillary and place an ERCP guided stent into the gallbladder. So when you're talking about treatment of acute cholecystitis and the patient is not a surgical candidate, we have three options, whether to go percutaneously and do a cholecystostomy or do endoscopic methods like a transpapillary stenting at ERCP or do an EUS guided gallbladder drainage using a LAMS. So what are the indications for endoscopic drainage? So a patient with acute cholecystitis who is not a surgical candidate because of his underlying comorbidities, as a bridge to surgical cholecystectomy, maybe the patient is not currently fit for a surgery, but we just need to decompress the system so that he becomes, once he settles down, and then we can perform a definitive cholecystectomy. Convert a percutaneous gallbladder drainage to an endoscopic if there's a failure of a percutaneous gallbladder drainage. And gallbladder drainage, EUS guided, can be an alternative to failed ERCP and then biliary drainage for patients with extrahepatic malignant biliary obstructions. So as I mentioned, these are the two methods of endoscopic drainage for gallbladder. So let's go step by step. So when you're looking at transpapillary drainage of the gallbladder, the steps are pretty much like ERCP. You need to cannulate the bile duct, obtain a cholangiogram, see the cystic duct insertion, locate it. So this is the tricky part. On fluoroscopy, sometimes if the cystic duct is located posteriorly, you may not be able to visualize the takeoff and you need to rotate your C-arm. So you inject contrast, get an anatomy of the biliary system, advance a guide wire across the cystic duct into the gallbladder, make certain loops. You may then need to dilate it. So, and if the duct is tortuous, you need to straighten it. So the best way of doing it is to pass in a dilator, a 7 French or an 8.5 French dilator, a Sohendra dilator, which helps to straighten the path as well as dilate the tract. Once you have done that, you can place in a double pigtail stent transpapillary and achieve gallbladder drainage. So certain tips to improve this. So use of a rotatable sphincterotome. This helps especially when the cystic duct is at an angle, is it posterior. So then you can rotate your sphincterotome to give direction to your guide wire manipulation. Use of the guide wire. So we prefer to use the hydrophilic, the angle tip hydrophilic Terimo guide wire for initial cannulation into the cystic duct and the gallbladder, and then we exchange it with a stiffer wire. Dilators, as I mentioned, Sohendra dilators or your hurricane dilators are essential to dilate the duct and before placing a stent. And of course, cholangioscope guided access to the cystic duct remains an attractive option when you are not able to visualize it on fluoroscopy. So this is just a video of a patient with cholecystitis who's got some ascites as well and is not a candidate for percutaneous drainage. So we went in with an ERCP, injected contrast. We can see a tortuous duct, cystic duct, and we are manipulating the guide wire to go inside into the gallbladder. Once we've achieved that, you can exchange the wire with a stiffer guide wire, then pass a dilator as is being shown here. This helps in not only dilating the tract but also makes the path straighter. Once you achieve that, you make loops of wire into the gallbladder and then pass a stent, a double pigtail stent into the gallbladder. As you can see, a copious amount of dark bile sludge can be drained from the gallbladder. So who is an ideal patient for a transpapillary gallbladder drainage? A patient who comes with cholecystitis but also has got a stone in the bile duct and has got cholangitis, so he needs an ERCP anyway. If there's some contraindications to percutaneous drainage like presence of ascites or coagulopathy, he is a good candidate for future cholecystectomy. And you want to preserve the anatomy, especially patient who's got a liver transplant. He requires a liver transplant in the future, so you need to preserve the anatomy. Contraindications, again, presence of perforation, peritonitis, altered anatomy. If the cystic duct is completely obstructed by a stone or a malignancy, then doing transpapillary drainage is going to be really difficult. So then what happens? What are the options we have if it's a difficult? So use of cholangioscopy. When you're unable to gain access with just fluoro guidance. So you push in a cholangioscope, you can see the cystic duct insertion, and under vision you can place a guide wire into the cystic duct. And in this case, once you place the guide wire, you can actually see a stone popping out of the cystic duct, which was making it difficult for the guide wire to go in initially. So this was a retrospective analysis which was published from a group in Thailand, which they evaluated about 100 patients for ERCP guided gallbladder drainage. They achieved success in about 53% of the patients, and then the rest of the patients were subjected to cholangioscopy guided cystic duct access. So what they found was with the use of cholangioscopy, they could increase the technical success to about 75 to 77%. So, but still there was a substantial amount that they failed cannulation despite the use of cholangioscope. So what they found was if you have a small and a tortuous cystic duct, or the cystic duct orifice is located posteriorly, or it's an angulated duct, then your failure of ERCP and transpapillary gallbladder drainage is going to be difficult. On the other hand, cholangioscopy can also fail if you have an unstable cholangioscope position, especially if there's a low insertion of the cystic duct, if there's an aberrant cystic duct which is taking up from the right duct, and a slit-like duct or a tortuous or again a posterior duct insertion. So still, it's a very technically demanding procedure. The technical failure rates are much higher as compared to other procedures of endoscopic gallbladder drainage. So the other one is a gallbladder drainage, which is EUS guided, wherein you visualize the gallbladder through the stomach or the first part of the duodenum. You access the duct using a needle, you place in a guide wire, and over the wire, you can place a lumen opposing metal stent. Other way is to do a freehand technique. You just puncture the gallbladder directly using the electrocautery enhanced lamps and deploy this stent under EUS and endoscopic guidance. So this is the video of a patient who had acute cholecystitis. You can see a thickened gallbladder wall with ecogenic material, and we are using a freehand technique. We're puncturing the gallbladder directly, deploying the distal flange, following which we deploy the proximal flange endoscopically, and we can see drainage of pus-like material. So who is a good patient for EUS gallbladder drainage then? A patient with acute cholecystitis who's not a surgical candidate, has altered anatomy, some duodenal obstruction. If there is obvious cystic duct obstruction due to a stone or an indwelling metal stent which has been placed for a prior procedure like a biliary malignancy, if there's large burden of stones within the gallbladder, and you can, if a patient, you can consider if your patient is, you want to remove stones from the gallbladder, he doesn't want to remove the gallbladder completely, the patients can, after an EUS guided drainage, perform a cholecystoscopy, remove the stones. Contraindications, again, presence of massive ascites, coagulopathy, gallbladder perforations, or presence of peritonitis. So if you look at efficacy of transpapillary drainage for gallbladder, we see that the technical success ranges between 70 to 80% in various studies. The clinical success though is high. So if you have managed to drain the gallbladder through transpapillary route, your success of the patient settling down is good, and with minimal side effects, similar to what you would expect in a routine ERCP. And all these patients who in the studies, they could undergo a routine cholecystectomy later on once the patient settled down. And when you compare it to a percutaneous drainage, again, the technical efficacy is lower than a percutaneous drainage, but in those patients whom you could successfully achieve drainage transpapillary, the clinical success was similar. And if you look at overall picture, the length of hospitalization or the reintervention rates were lesser with transpapillary drainage compared to the percutaneous. EUS gallbladder drainage, several studies are available which evaluated just self-expanding expanding metal stents and lamps with great clinical success and technical success with very less adverse events. And when we compare it to percutaneous drainage, couple of RCTs, one recently by Dr. Teo, which showed that it had equal clinical and technical success with lower adverse events, lower reintervention rates, and lower chances of recurrent cholecystitis. So one thing is clear, that endoscopic technique when compared to percutaneous is favorable. Which one, whether it is transpapillary or EUS guided, it depends on your expertise and your surgeon's requirement and the patient obviously. So there have been some studies which evaluated all these methods, whether it was percutaneous, transpapillary drainage or EUS guided drainage. So this retrospective analysis which compared all three showed that the technical success of transpapillary drainage was on the lower side compared to percutaneous drainage and EUS gallbladder drainage, but the clinical success was decent. Another study which compared transpapillary drainage with EUS drainage, the clinical success was statistically significantly better with EUS drainage compared to transpapillary drainage, but the technical success rate of recurrent cholecystitis, adverse events didn't achieve any difference. Several meta-analyses showing the comparison. So EUS gallbladder drainage and percutaneous drainage have high technical clinical success when EUS drainage is preferable in terms of lower adverse events and lower recurrence rates. Again, same thing, which was comparing a meta-analysis comparing transpapillary drainage with EUS drainage. EUS drainage was favorable in terms of both clinical as well as technical success. So again, there are some advantage of EUS drainage where you can perform a per oral cholecystostomy. You can assess the gallbladder mucosa. You can identify malignancies, maybe perform polypectomy. Or in this one patient who didn't want a gallbladder surgery, we performed EUS guided drainage, placed a metal stent, and then went ahead with removing the gallstones using cholecystoscopy. So EUS guided drainage does offer certain advantages, added advantages like these. So to conclude, who is a good patient for transpapillary drainage? Transpapillary drainage serves as a bridge to elective cholecystectomy by allowing recovery from sepsis. You can allow optimization of the patient. It does not compromise the anatomy for future surgery. It is cost saving, and the use of cholangioscope can increase the technical success. Whereas EUS gallbladder has great technical and clinical success. It's ideal for non-surgical candidates, it has fewer reintervention rates, safety profile is better than percutaneous drainage, especially indicated in patients with malignant cystic obstruction or presence of previous biliary SEMS. So just to conclude this algorithm, so if a patient who is a non-surgical candidate does not have perforation and can tolerate sedation, you can go ahead with transpapillary drainage or EUS drainage after assessing the patient for cholecystectomy and with your surgeon. And if either one fails, you can then go switch over to the other endoscopic method or a percutaneous drainage. Thank you.
Thank you, Ankit. Any questions? Ankit, I have two questions. I'm sorry, please go ahead.
So Ankit, what is the preferred size of the lamps for a EUS guided gallbladder drainage? You use 10 millimeters or the standard 15 millimeters?
I use 15 millimeters, but both 10 or 15 is adequate.
Okay. And what will the time, once patient then becomes surgically fit and comes out of acute cholecystitis, what is the timing where you think to take these people up for surgical cholecystectomy?
After an EUS drainage or transpapillary?
After the EUS drainage.
So EUS drainage, you need to first speak to your surgeon beforehand, whether he'll be comfortable with doing a closure of the fistula while doing surgery. So once you have discussed with your surgeon and he's comfortable, maybe after 3 to 4 weeks of the whole patient settling down, you can subject the patient to a cholecystectomy.
That's what is my worry. Like, if you are planning a subsequent cholecystectomy, what would you do, a percutaneous one or EUS guided? Because there is a definite problem of closure during cholecystectomy.
That's agreed. So that's where I think transpapillary comes in place. It has its role. So you can attempt doing a transpapillary drainage. You can try using a cholangioscope also to gain access to the cystic ducts, especially in patients whom you are going to operate, who are not terminally ill or who are not completely off the surgery list.
But why not percutaneous? Because that's the least invasive. If you see, it's a 5 minutes procedure, radiologist goes in, just put a tube. It's simple drainage procedure. Why do you want to do an ERCP procedure when patient is sick?
Correct. So again, so as I mentioned before, the ideal condition of doing a transpapillary drainage would be if the patient has concomitant CBD stone or cholangitis, which requires biliary decompression as well. So you can subject these patients. But again, still percutaneous cholecystostomy has its advantages and disadvantages with a catheter being there. Patients do suffer with slippage or migration of these catheters, the discomfort of the procedure. So these kind of problems do remain with percutaneous drainage.
Just to add Dr. Nilai's thing, another typical indication where you would prefer an endoscopic transcystic drainage over percutaneous. Suspected MI recently, patient on double antiplatelet, where you can't do a percutaneous procedure. I would think a transcystic drainage. Sometimes this MI, CBD stones, the biliary colic, is mistaken for an MI and he has some ECG changes and patient who have had a stent and double antiplatelets. You can't do a percutaneous drainage and this would be the choice.
Okay, thank you, Ankit. I think we'll next move on to the next talk. It is by Dr. Manoj Sahu. He is going to talk about US guided pain management. Everybody knows Manoj. Please go ahead and tell us about the pain management.
Respected chairpersons, seniors and friends, I'm extremely grateful to Dr. Puri for this opportunity. We'll be discussing very briefly on US-guided pain management in pancreatic disorders. Pathophysiology of pancreatic pain. Different mechanisms, different types of pain. At the onset, initiation, you have stimulation of the nociceptive receptors and subsequent involvement of peripheral and central nervous system, leading to peripheral and central sensitization. If you see the right side, chronic pancreatitis and pancreatic cancer can have inflammatory environment leading to neural inflammatory infiltration, neuritis. They release neurotropins, can have neuroplasticity, increased neural density called spouting, and the pancreatic cancer can have neural invasion. So if we are intervening at the early stage when there is no extensive involvement of the peripheral central nervous system, the outcome is expected to be good. Pancreatic tissue pressure and pain in chronic pancreatitis. Significant dilatation of MPD is present in 1/3 of cases of chronic calcific pancreatitis. Similar dog dilatation observed in both groups of patients who didn't have pain, painless and painful patients of chronic pancreatitis. Decompression is associated with improved pain only 50% of patients. Total pancreatomy fails to alleviate pain in 1/3 of patients of chronic pancreatitis. So we have now the additional mechanisms, additional ways of development of pancreatic pain, need to identify the predominant contributor for pancreatic pain, and the management should be individualized. Pain management. Indications. Chronic pancreatitis patient with persistent pain. Despite optimum medical management. ERCP endotherapy done, pain is persisting, post ESWL, post surgery, and the patient is not willing, not keen for surgery, we may consider celiac plexus block, CPB. Additional causes of pain which might contributing in initiation of pain like ulcer, pancreatic mass, fluid collection, CBD stricture need to be identified, need to be ruled out before considering USCPB. Pancreatic cancer with persistent pain, we need to consider celiac plexus neurolysis or CPN. The transmission of pancreatic pain we know occurs through the celiac plexus, and it is visible in many patients while doing US. Celiac plexus intervention, USCPB, there is a study comparison between bupivacaine and ropivacaine. Bupivacaine found to be superior, better efficacious, and in CPB triamcinolone can be added. USCPN, alcohol mostly in addition to bupivacaine. Broad plexus neurolysis, BPN. So we need to inject at the vicinity of superior mesenteric artery. The purpose is to wider coverage, wider involvement. Can we cover the celiac ganglia very widely to have a great benefit, to have better outcome. The injection can be done into the ganglia, can be done centrally, single injection, can be done bilateral. In the right side injection, if it is difficult, one study that documented left and midline injection can be done. Another study tried to find out the ethanol volume in CPN. 4 ml into the ganglia, 20 ml around the celiac trunk, they found to be good. For good response, and the increasing the volume may not suffice our effectiveness or response of pain management. 22G needle is commonly used. We need to give 500 to 1000 ml of normal saline intravenously pre-post procedure to prevent hypertension. Prophylactic antibiotic, no great data in CPN. Alcohol act as a bactericidal agent. So which modality, US or percutaneous intervention? RCT, mean follow-up 15 weeks, response is better in the US group, no difference in complication rate, but another recent RCT, US intervention found to be safer than percutaneous intervention or CPB. There is a meta-analysis, US CPB found to be more effective. to reduce pain. So US modality, US intervention is safer, efficacious compared to percutaneous intervention. US guided celiac plexus injection therapy. Selected clinical trials, if you see, in chronic pancreatitis, the response is not very great, response is lesser compared to pancreatic cancer. If you are injecting, intervening at the early stage, response is good. And there is a study comparison between RFA versus CPN. They found RFA response is better in this study, but we need to have more data. US CPB in Indian chronic pancreatitis patient. Response is good, 72.4%. Mean time to response is very quick. Mean duration of response is 8 months. The overall response in short duration group, less than 2 years, is better than long duration group. If the intervention is done early, response they found is better. No difference in response with respect to prior history of ERCP, surgery or etiology of chronic pancreatitis. If there is positive response at first attempt, had better response on subsequent procedure. If somebody responded nicely, 50% decrease of pain score, we need to consider if required the second procedure or subsequent procedures. Pediatric chronic pancreatitis, there is a report of 2 patients, satisfactory pain relief safely performed. What they suggested, US CPB must be considered and implemented early before usual complications. US CPN in pancreatic cancer. Ethanol is commonly used, phenol can be used as a solvent. Minaga et al., the efficacy rate is 73 to 90%. Various other study, efficacy rate is 80 to 90%. There is a meta-analysis significantly relieved and eliminated pain in 80% of patients. Recent meta-analysis, if you are injecting directly into the ganglia, CGN versus central injection versus bilateral injection, they didn't find any difference in efficacy and safety. The similar study, comparison between central versus bilateral injection, similar outcome. Another meta-analysis with 3 modalities, no difference in efficacy and safety. US guided broad plexus neurolysis versus US CPN. US BPN means you need to inject at the vicinity of the superior mesenteric artery, and they have proved, they have established that the coverage of the celiac ganglion is good enough compared to if you are injecting centrally or both sides. In the US BPN group, significantly greater pain reduction, which is found to be better than CPN. Typically, for their advising in patients without improvement following CPN. If CPN you have given no improvement, so US BPN, broad plexus neurolysis, may be considered. Ethanol or phenol, 22 patients, 6 patients with alcohol intolerance, they have injected phenol. No difference in response rate, duration of pain relief, and rate of complication. So, phenol-based US CPN can be done in patients who do have alcohol intolerance. US RFA versus CPN in pancreatic cancer. Recent RCT, 26 patients, significantly more improvement in RFA group. 20% of patients with persistent pain after CPN, they do responded, successfully managed with RFA. What they are suggesting, RFA likely mark the next phase in the evolution of US guided pain control for patients with pancreatic cancer. But we need to have more data. We need to see the cost effectiveness of the procedure. US guided pancreatogastroscopy, pancreatobulbostomy for the treatment of pain. Patients with pancreatic ductal dilatation, inaccessible papilla, ERCP stenting is not feasible. In this study, what they have found, the response rate, response to pain is close to 70%. Complications of pancreatic diseases and pain. Different complication of pancreatic diseases which is contributing to pain. fluid collection pseudosis, walled-up necrosis. The pain can be managed with US-guided stent placement. Gastric outlet obstruction secondary to pancreatic malignancy, and pain is very significant, and we have alternative therapy with US-guided enterostomy. Different mechanisms can cause pain. There are different mechanisms which can contribute to pain in pancreatic diseases, commonly chronic pancreatitis and pancreatic cancer, resulting in different types of pain. We need to identify which is the predominant contributor of pain. If you are able to identify, then we can advise individualized management protocol. The management of pain in pancreatic diseases is frequently complex in clinical practice. But if it is individualized, we can able to take care of patient's symptom. At present, no pathogenetic treatment is available to tackle directly the mechanism of pancreatic nervous system impairment. Nervous system impairment does not start at the beginning, but if you are allowed the pain to continue for a long time, the peripheral central nervous system are involved. But there is no pathogenetic treatment as of now. The transition from symptomatic therapy to pathogenic treatment is always crucial, and it is important and have better clinical results. US-guided approach to celiac plexus intervention is safe and effective even in pediatric population. The three modality injecting ganglion, CG and central bilateral, no difference in efficacy and effectiveness. Careful patient selection is important. Shorter duration of disease do have better clinical outcome. And there is a suggestion from a group where on-site cytopathology is available, patients with painful inoperable pancreatic cancer should undergo US CPN at the time of diagnosis. Broad plexus neurolysis BPN for patient without improvement in pain with CPN, but we need to have more data. US RFA more effective than CPN, need to have more data, see the cost effectiveness. Different complication of pancreatic diseases may contribute to pain and need to identify, need to rule out, need to address properly. Thank you.
Thank you, Dr. Sahu. Any questions from the audience?
Uh, 20 gauge needle with side hole was available, is available now also. But there is a study comparing the purpose is if the side hole that can lead to more coverage of the area, the plexuses will be well covered. But there is a study comparing between 22 gauge side hole and 22 gauge needles, 20 gauge side hole and 22 gauge needle. There is no difference in efficacy in both needles. But now the commonly used needle is 22 G. Various societies also they are advocating 22 G needle.
It's probably one of the easiest procedure US guided. But I have a question to the audience. Actually, how many of us are doing it? Both CPB in chronic pancreatitis and CPN in pancreatic cancer.
So we need to ask the audience.
Yes.
But if you see the study from India, Indian population, a study from Dr. Mohesh Goenka group, the response seemed to be very good. But we need to correctly identify the group of patients who can respond nicely. But in chronic pancreatitis, response may not be very great as compared to pancreatic cancer. Response will be transient. But if the patient is coming continuously with pain and you have ERCP done or surgery done or ERCP is not feasible, not indicated, and multiple hospital admission, I feel we need to consider CPN, the EG modality. The pain can be controlled at least transiently, give us some time, some space, we can able to manage the patient.
So actually very few people are doing CPN and CPB in spite of it being very simple. My personal experience of CPB is not great in chronic pancreatitis actually. But CPN, it's a good it's having a better response.
CPN in chronic pancreatitis, definitely better response. But if you see CPN in chronic pancreatitis and pancreatic cancer, the response is better in pancreatic cancer. If you are doing neurolysis in chronic pancreatitis, there are many studies. So there will be retroperitoneal fibrosis. The complications are likely little more compared to plexus block. So if you see many studies, society, the advocacy is neurolysis should be avoided in patients of chronic pancreatitis.
Just one question. In chronic pancreatitis, we know the pain, the last probably about few months, only about 6 months. So do you wait for the pain to come back to do your second injection, or would you do it prophylactically before the pain comes?
So you need to see the response. If you see various studies, they have followed up. Our Indian study is 8 months. So if the patient responded to first injection, so there are studies that is likely to respond to the second injection also. So if it's coming back with pain, so you may consider the second injection.
Thank you, Dr. Sahu.
Thank you very much.
We'll conclude this session over here. Thank you all the speakers for, it was a great learning exercise. Thank you again. And also I thank my co-panelists over here.
I thank the moderators and chairpersons. We shall now be breaking for lunch, and we shall reassemble for the orations at 1:40. Good afternoon, everyone. We will now begin the afternoon session with the orations. I call upon the chairpersons to chair the session. Dr. Mohammad Kuru, Dr. Jang Dilavari, Dr. S.K. Tyagi, Dr. Rakesh Kochar, and Dr. Godas Chaudhary.
Well, we're going to start this session, very important session, our oration of Dr. H. Desai will be given by Vinay Dheer. Vinay Dheer, may I invite you? Vinay Dheer is the chairman of the Institute of Digestive and Liver Disease Care in SL Raheja Hospital. Vinay is one of the world expert in endoscopy ultrasound. I watched him doing the procedure, very impressed indeed. And he has written almost more than 100 papers only on endoscopy ultrasound. So Vinay, we look forward to your talk.
Hello. Yeah. Thank you, Professor Dilavari. It's really an honor to be speaking in front of you, in front of Professor Kuru, Professor Gaur Chaudhary. It's a real honor. I would also like to thank the SGEI for awarding me this oration. This oration, as you know, is named after Professor H.G. Desai. Professor H.G. Desai, anybody who is from Mumbai, is a student. He taught all of us for a very, very long period of time. I have had, I think, close to 2 decades of association with him. He was the one who interviewed me for my first lecturer post in Tata Memorial Hospital. A brilliant clinician, a brilliant educator, and to top it all, his interest in research on gastric juices. At that time, he had 9 publications in gastroenterology in that era. We don't have even one. So that was his interest in the research of gastroenterology. He started the DM gastro program in Nair, and he, along with Professor Antia, gave fillip to the gastroenterology in the western region and the rest of India. So it's an honor to be speaking here, giving H.G. Desai oration. The topic that has been given to me is US guided biliary drainage, a topic very close to my heart. So let's get going. Basically, it's more than 2 decades old now. 2001, the first hepaticogastrostomy was done. Since then, it has proliferated into many different procedures. Broadly, you can classify them into 2 procedures, access procedures and drainage procedures. So access procedure is called as rendezvous. It is used in conjunction with ERCP in patients where ERCP is done, but cannulation, selective cannulation is not possible. US guided biliary drainage is again 2 types, transpapillary stenting, that is called as antegrade stenting, and transluminal or transmural stenting, that is choledochoduodenostomy or hepaticogastrostomy. depending on where you are entering from, the duodenum or the proximal stomach. To this, we can also add gallbladder drainage. I'll talk about it later. So as you can see, the beauty of this procedure is you are not dependent on papilla. So picture A shows a choledochoduodenostomy. So you are entering the biliary system from the duodenum. Picture B shows a hepaticogastrostomy. So from the proximal stomach, you are into the left biliary system. So 3 is the antegrade procedure, where you have placed a stent across the papilla into the duodenum from the proximal stomach. Picture D shows you a picture of a gallbladder drainage. You can see an axios being placed in gallbladder and air in the gallbladder. Picture E shows a rendezvous, and picture F is a procedure which is less done for right-sided blocks, hepaticoduodenostomy. So a huge number of procedures have proliferated for biliary drainage. So this is an advantage. You don't depend upon papilla for access, but this is also a little bit of disadvantage because so many procedures for biliary drainage, standardization is becoming difficult. We'll discuss about that later. Let's talk about the access procedures now. What is new? So in 2012, we published a paper which was quite controversial at that time. We compared pre-cut papillotomy with EUS rendezvous for access and distal malignant biliary obstructions. That was a retrospective study. It told us that EUS RV is superior to pre-cut if you take only first attempts. We thought the idea was exciting, so we started a randomized trial in 2013. So the results are now ready, and we are going to talk about it in DDW, Presidential Plenary. So this is the first time I'm showing you the results very briefly. So you have patients of distal malignant biliary obstruction, naive papilla, 208 difficult biliary cannulations, randomized to pre-cut and RV, and these are the results. So you see technical success, no difference. Adverse events, no difference. Only if you see RV has less but no significance. PEP, that is post-procedure pancreatitis, trending towards significance but not significant. But time taken for procedure significantly longer for EUS guided rendezvous. So both procedures are equivalent, more or less equally safe, because this is a large patient group. So now we can't say that the patient number is small, but it looks like EUS rendezvous is equivalent to pre-cut, and in centers with expertise, and in certain papillae where you find pre-cut is difficult, you can go for rendezvous instead of pre-cut. So these are the procedures I already talked, the variety of procedures, the choice of puncture from stomach, antrum or duodenum. You can usually use a 19 gauge needle, sometimes 22 gauge, guide wire 0.025, 035, or you use a hot axios, then probably no guide wire is required. Dilators and different kind of stents are used. So this is where I think the future research should be as, if we want to choose one procedure out of all these so many procedures, is there one procedure which you will say is the EUS BD procedure? Difficult, but we will see. In 2015, we published our retrospective multicenter comparison of EUS BD and ERCP for distal malignant blocks. And what we said at that time stands true even today. We said that EUS BD can be used in patients with or without duodenal stenosis. So that's a big plus and could be potential first line procedure for relief of jaundice in patients with malignant distal bile duct obstruction. So challenging hypothesis there. We also said that success rate and adverse event rates were equivalent to ERCP. If you see pancreatitis rates in difficult access group in that study, significantly higher in the ERCP group, and clinical success in duodenal stenosis obviously significantly higher in the EUS BD group. Following this, there is a plethora of randomized trial that have been published. I hope you can read them. I will not talk About the first two, they are small numbers, and I think we should disregard these two studies. The next three studies have decent numbers in both the groups, and the conclusions drawn are more or less same, that similar technical and clinical success rates for both the groups. However, there are trends. So, for example, in the PIKE, the Korean study, there is lower adverse event rates and longer stent patency with EUSBD. In the Teo study, Anthony Teo from Hong Kong is here, higher technical success but significantly shorter procedure time. So higher technical success. Why? Because this was an intention to treat analysis, and 10% of the patients had duodenal stenosis where ERCP failed but EUSBD succeeded. So when you go by intention to treat, higher technical success. And in the final study, which is published in Gastroenterology recently from Canada, similar technical success and clinical success, similar shorter procedure time and lower radiation exposure. So if you look at it, both procedures appear equivalent for distal malignant biliary obstruction. However, there are some trends which show that probably EUSBD works better. So coming to which procedure is better, CDS or HGS? Obviously, if you have a patient with malignant hilar block, you will do a hepaticogastrostomy, you will not do a CDS. But the issue is distal malignant biliary obstruction. What should you do? The question has not been answered as yet. There are several studies. There is only one prospective study, others are retrospective. Numbers are okay. Similar technical success, similar clinical success, but if you look at the remarks, higher proportion of adverse events in HGS group, in the Japanese study, length of hospital stay was significantly shorter in CDS, in the American study by Moin, and another American study said longer stent patency in CDS group. So some minor things you can say which favor CDS, but technical success and clinical success is more or less the same, so you can choose whichever procedure you are comfortable with. Very briefly, I will show you how easy the procedure is. So this is a distal malignant block, duodenal obstruction. You see this is a duodenal obstruction. So we go from D1, obviously ERCP cannot be done, and we go to the dilated bile duct, use a 19 gauge needle, inject contrast, pass a wire across into the liver, use a cystotome to dilate. A 6-French cystotome is a great accessory for EUSBD, and then a stent is placed. So the whole procedure takes less than 10 minutes, is a very fast and efficient procedure. There is this meta-analysis about CDS and HGS recently published, which shows again that CDS takes shorter time and early adverse events are less with CDS. But the final word has not been said. The new kid on the block here is using gallbladder for drainage in patients with patent cystic duct in distal malignant block. And here you have to use a LAMS, although SEMS has been used in some small studies. Technical success is 100%. As you can see, clinical success varies from 77 to 100%. Adverse event rates are similar to other EUS BD procedures. So this is another attractive option. Why? Because it's very easy to perform. You will see here it's even easier than EUS BD other procedures. So here you see a hugely distended gallbladder. All you have to do is just put a hot axios or a hot spexis, whichever you like, and the procedure will take less than 5 minutes. So in this case, we wanted to place a plastic stent, so we have passed a wire, but not always necessary. So you can see here, stent is being deployed, and once the axios is deployed, you can see immediately a lot of pus comes out. Very helpful in non-malignant conditions also. We place a plastic stent here just to keep the gallbladder wall away, because sometimes it is inflamed and the stent can cause problems in the gallbladder wall. So very easy, simple procedure. And in patients with patent cystic duct, this is one of the options. What about using LAMS or a tubular stent? So for hepaticogastrostomy, we are using only tubular stents. But for distal blocks, you can use a LAMS or you can use a tubular stent. So this is meta-analysis of 31 studies, which shows no significant difference. The preference for LAMS is because the procedure is pretty easy, is fast and efficient, but there are problems with LAMS. So you see this study which is recently published, 93 patients, stent dysfunction in almost 1/3 of them, and stent dysfunction was more in patients who had duodenal invasion. So like the patient, the video I showed had duodenal stenosis. So probably food debris getting stuck there causing stent dysfunction. So they propose that don't put LAMS in patients with duodenal invasion. So this field is evolving. The answers are not yet there, but it's very exciting. Two slides about preoperative biliary drainage. ESG suggests EUS should not be used for US preoperative drainage, and I think they are right because there is no good evidence as yet to say that EUS is good for preoperative biliary drainage. This is a study again from US, 145 patients, both EUSBD and ERCP were done, and then patient underwent Whipple's. Good clinical success in both groups, equivalent adverse events. However, EUSBD group had significantly higher clinical success and lower hospital stay. But this is a retrospective study. We really do not have answers in this preoperative group, so continue to do ERCP as and when indicated. I have just one slide on adverse events, and this is a meta-analysis from our friend Suprabhat Giri and colleagues. So it's an Indian study, very proud to talk about it. 7,887 patients. Now you look at the adverse event rates in all the different groups, you see it is much lower than what was proposed about a decade back. And the lowest is in the transpapillary group, that is the antegrade and the rendezvous group. Hepaticogastrostomy has the highest adverse event rates, and the adverse event rate which we worry about most is leaks, perforations, peritonitis. As the experience has grown in these procedures, leaks and perforations have become less and less. And you can see here, major adverse events in all the groups are less than 1%, and mortality is practically negligible, 0.1%. Now you compare this to the ERCP data and you will say this is pretty good, and the adverse event rates. Mortalities are hardly there. Initially, yes, when first 5 or 6 years, there was a lot of fear about leaks and perforations, but as experience has grown, we have known that adverse events are manageable in most of these patients. Few slides about training. So I have been part of some of the consensus guidelines. This is the Asian EUS group guidelines. So if you want to train, you should be good in ERCP. That is first thing, because lots of accessory we use are good. And if you are wanting to train, you should train in a center where you have good PTPD, good ERCP and good EUS. You should be expert in doing EUS FNA with a 19 gauge needle. You should be good with wire manipulation techniques, which we use in ERCP. Currently, the number of cases, even in the big centers, are not enough for you to have hands-on experience. So models are what has been suggested, and these are the guidelines we published, SGEI guidelines. They also say more or less the same things. You need fine needle biopsy, therapeutic ERCP. These two things are a must right now, and training should be initiated on models whenever available. So this is a review which we are publishing recently, and these are the number of cases from various studies which you require to become decent in these procedures. So choledochoduodenostomy, 32 cases. Now to get 32 cases, because primarily we are doing ERCP in most of these patients. And mastery after 100 cases. So 100 cases of CDS, very, very difficult to get. Similarly, hepaticogastrostomy, 33 cases to stabilize and 93% success. And then gallbladder drainage, easier, 19 cases for 86%. So These cases are difficult to get, and so current proposition is to use the models. This is the magic box which we created. We have published data on it, very good. To the right is the Thai model, very good model for hepatico-gastrostomy. There are various other models also available. So to conclude, this is a very, very exciting ongoing area. We do not have perfect answers. Some of the issues remain unsolved, and the future appears bright. Thank you very much.
Thank you, Vinay. It was a brilliant talk. And now I invite Professor Kuru to speak.
Thank you very much for that brilliant talk on a very important procedure which has taken gastroenterology by great surprise. Thank you. And I think we should give 3 cheers to the orator for a brilliant presentation. All of us wanted to learn all this. The next The next oration is Murari Krishna oration, to be given by also a very important faculty, Dr. Professor Zahid Nabi, who is interventional director of interventional endoscopy at the Asian Institute of Gastroenterology at Hyderabad. I think he's going to talk on endoscopic full thickness dissection techniques. And it is just Dr. Nabi, please.
Thank you for the introduction, sir. Good afternoon, all. And I thanks SGI for giving me this opportunity. And it's an honor to give Professor P. Murali Krishna oration. I think Dr. P. Murali needs no introduction, and he was a pioneer endoscopist, and he took endoscopy to a different level in Vizag or Visakhapatnam, as we all know. And he was the first person, most of us might not know, but he was the first person to perform double balloon enteroscopy, and he was trained with Professor Yamamoto, and he was also the first person in India to do a pan enteroscopy using double balloon enteroscope. We can say on and on and on. He established the department, he took the department to a different level, and it's an honor to give this oration in the memory of Professor P. Murali Krishna. So with that, I'll start my talk, and which is endoscopic full thickness dissection. In the next few slides, I'll be talking about the indications of EFTR, the techniques, various techniques, and the outcomes of endoscopic full thickness dissection in upper GI and colon. So there are 2 basic techniques of endoscopic full thickness dissection. One is exposed, or the conventional technique that you all know. You use a knife, do a full thickness, and close that defect using clips or different techniques. And you have a device or non-exposed technique, which is called device assisted endoscopic full thickness resection. Means with the device you first clip or close below the lesion or tumor, and then finally you cut it. There's a third technique which is called hybrid technique, and I think it's an emerging technique, and this is what the future holds too. And this is hybrid, which is using the best of both worlds, that is endoscopic approach and laparoscopy approach, and there are different techniques that we'll be talking later upon. So let's come to endoscopic full thickness resection, the exposed version, which all of us know, that once you resect the lesion, you close it using full thickness defect. So let's see how it goes, endoscopic full thickness resection. So this is a gastric lesion, probably GIST, that we plan to remove with endoscopic full thickness resection. The initial technique is similar to endoscopic submucosal dissection. Means you don't start full thickness dissection right from the beginning. Your aim or your target is that you do debulk the mucosa, overlying mucosa, because gastric mucosa is very thick. Do submucosal dissection till you reach the tumor and the last part of the tumor which is adherent to the muscle. So this is your aim. Till now we have not created a full thickness defect, and now we intend to do a full thickness resection. The main aim being to minimize the size of full thickness defect. So because at the end you have to close the defect. The larger the defect, the more difficult it is to close the defect. Once you resect the entire lesion, you remove the lesion and close the defect using different techniques that also we'll talk later in this slide. Traction is very important, and traction is something I always say that if you want to improve your results, if you want to minimize the time required for full thickness resection. So this is a peritoneum that you are seeing right now, intraperitoneal thing. We are applying this clip with line technique, a thread which we pull from outside to improve our visualization of the dissectable tissue. So there are two benefits. We don't lose the tumor inside the peritoneum, and second, we have increased or improved visualization, enhanced visualization of the tissue that we want to dissect. So this is a very good technique. The second video, if you see, this is a duodenal neuroendocrine tumor infiltrating little bit into the muscle layer. So this is a rubber band traction technique, very cheap, very effective. Once you apply this rubber band, you have adequate visualization so that you can minimize the size of full thickness defect. You do the dissection and finally close the defect using any of the various techniques that we'll discuss later on. So here you see we are doing it. So we are increasing the limit, enhancing the limit of full thickness resections in GI tract. So now a variety of lesions, more number of lesions are being resected effectively. As I told, closure of defects is an essential part of endoscopic full thickness resection because you have to close the defect. So there are various techniques of endoscopic closure techniques. One is zipper closure technique or loop and clip closure technique. You use simple clips, through the scope clips, with or without loop. This is a very good technique. The second is using full thickness closure clips like over the scope clip, padlock clips, or you use endoscopic suturing device if you have that facility. And now in near future, it's yet not available in India, you'll be using X-tack or hand suturing needles also to close this defect. So these are different techniques that if you see the problems and the disadvantages of, there are disadvantages with each closure technique. Zipper closure you cannot use for large defects. Endoloop closure, of course, it's time consuming and it may increase the cost also because it consumes a lot of clips and a loop as well. Over the scope closure technique, of course, again, it's not recommended for defects which are more than 2 centimeter in size, and you may require an additional closure technique. But then depending on a particular scenario, you can use any one of these closure techniques. But in my opinion, what is going to change the future is these new clips which are now available from Microtech, which is called the dual opposition traction clip, and the second is Mantis, which is going to be soon launched in India from Boston Scientific. So these have special features, like for example, this Microtech clip can grasp one edge, so you can open these prongs and close these prongs separately. So this is a major advantage. Even wider defects can be closed using these through the scope clips. The Mantis clip, the advantage is it has a strong jaws. It has sharp jaws so that it can grasp one edge, you can carry that edge along the other side and close these clips. So what are the outcomes of exposed endoscopic full thickness resection? If you see the outcomes, we have multiple studies now, but all of them are retrospective series. They have some faults, some disadvantages. I'll just discuss this systematic review and pooled analysis. Overall, the important thing to note here is that the maximum size of defect has been included less than 3.5 centimeters. So these are the lesions. You have to know your limits. You have to know the size of lesion that can be removed using endoscopic full thickness resection. Of course, this meta-analysis poses a very rosy picture, but it may not be as rosy if you don't have adequate experience. Now coming to the second aspect of my talk, which is device-assisted endoscopic full-thickness resection. So there are two main devices that have been used. One is from Ovisco, the full-thickness resection device, and the other is Gerdex device. And let's see how do they help in endoscopic full-thickness resection. So there are two main full-thickness resection devices available. One for upper GI tract, which is 21 millimeter wide, and one is for recently available is gastroduodenal full-thickness resection device, which is 19.5 millimeter in size. So it's a complete pack. With upper GI device, you also get a balloon for dilatation, you get a marking probe, you get a grasping forceps, and this is a complete set. Another thing which is very handy and very helpful is OTSC anchor, which you can push inside the lesion. The anchor opens, it opens like a fan, and you can just pull the lesion, which will help you in pulling the lesion towards your cap, and then finally you can fire the clip. We'll see the technique of endoscopic device-assisted endoscopic full-thickness resection in the coming few slides. Now, where do you perform upper GI or gastroduodenal full-thickness resection using device? So it's indicated for non-lifting adenomas which are less than 3 centimeter, duodenal subepithelial lesions which are less than 2 centimeter, gastric subepithelial lesions which are less than 15 millimeter. Now, if you see carefully here, where the size of the lesion is coming down as we are moving towards the stomach, because stomach has a big thick mucosa, and the chances of successful resection, complete en bloc resection, are less in stomach as compared to duodenum or as compared to adenomatous lesions. What are the contraindications? It's very important to remember that never use this device if the lesion is close to papilla, if the patient has uncorrectable coagulopathy. In stenotic areas, for example, if there is scarring in duodenum and there is deformity and narrowing of D1, D2 junction, you should not use this device. And you should always think that it's a possibility that incomplete resection can occur in some cases. So what is the technique? First of all, you prepare the device. And second is, because upper GI device, again, it's a 19.5 millimeter device, you need some technique to negotiate this device across cricopharynx. So there is a balloon available with that, which you inflate half inside the cap, half outside across the cricopharynx, and push this unit as a combined unit across into the cricopharynx. So always remember to minimize complications, to improve your technical success, never go without a balloon. So inflate the balloon, half of the balloon is inflated inside the cap, half of the balloon outside the cap. There is a marker which suggests that you have inflated half of the balloon outside and pushed it as a single unit. So these are some practical examples that how do you do gastric and duodenal endoscopic full thickness resection using this device. So this is a small submucosal lesion in stomach and another one is in duodenum. See, we are inflating, we are dilating the pyloric channel first with a balloon so that we can negotiate the device across into the duodenum. So always remember two areas need dilatation. One is cricopharynx and second is pylorus. Preemptively dilute the pylorus if you are dealing with the duodenal lesions. Finally, the resection part itself is not very difficult. You just pull the lesion inside the cap, fire the clip and close the snare. It's all there in a single device and you can finish the procedure in 10 to 15 minutes without any major complications. What to do after the procedure? Single shot of antibiotics, oral liquids can be started after a couple of hours. Second look may be required in duodenal lesions because delayed bleeding is a common complications and we usually give PPIs for 2 to 4 weeks. Now what are the adverse events? Is everything fine here? There are few adverse events. One is, the most important is technical failure when you don't judge the lesion correctly and you are not able to grasp the lesion inside the cap. Second is bleeding, perforation. They are theoretical possibilities, although they are very less common because the clip is there in the place. And if you pull too much of the tissue inside the cap, if you apply too much suction and resect too much of the normal mucosa, you may also encounter some luminal stenosis. How to maximize success with device-assisted endoscopic full thickness resection? So this is all according to my experience. There is no hardcore evidence as of now, but what I think is that you should always prefer dilatation even if you think that you may be able to cross. Avoid full thickness resection in flat duodenal lesions which are more than 1 centimeter in size because it will be very difficult to pull them inside the cap. avoid juxtapyloric lesions because there you won't be able to adjust your device in such a way so that you can engulf the entire lesions. Always do a side view endoscopy for lesions which are there in the second part of duodenum. Avoid vigorous suctioning, especially in second part of duodenal lesions, because this may lead to duodenal stenosis. And remember, first attempt is the best attempt. What are the outcomes of device assisted? So this is a multi-center study recently published in Surgical Endoscopy. In 29 patients, look at the size of the lesion. The max size of the lesion was 15 millimeter. Although everything was fine, but the R0 resection was 76% overall in stomach and duodenal lesions combined. But what is important is in just which are there in the stomach, only 50% lesions could be removed using this technique. So because these were deeper in origin and extradermal, so be cautious when you are using this device for gastric submucosal lesions. So this is our experience where we compared exposed versus non-exposed. Both the techniques were quite effective, but in the device assisted, we encountered failure in couple of cases due to poor selection of cases. What about colon FTRD? I think this is a very beautiful technique and much of the evidence is there only for a colonic device. The reason being colonic device was introduced much before the endoscopic device, and these are some of the indications where it is used. It's not recommended universally for all the cases. It's recommended only in difficult to treat cases which have scarring, which are recurrent polyps, which are periappendicular polyps, where you suspect deep submucosal invasion and some neuroendocrine tumors. When to avoid colonic EFTR, again very important that if you choose your patient wisely, your complication rate will be less and your success rate is going to be high. So this is from our group. I think Jayanta is sitting here. We conducted this systematic review and meta-analysis of 29 studies and more than 3,000 patients, and we could get a see that the success rate en bloc resection and R0 resection are reasonably good. There are issues with device assisted full thickness resection, and these issues, one of the major issues is that you cannot resect larger lesions because the cap diameter is limited, the cap depth is limited. Some of these limitations can be overcome by using hybrid technique, which is called hybrid device assisted endoscopic full thickness resection. You resect a part of the lesion using EMR, and then you encounter one non-lifting part of the polyp. All of us do see such scenarios where a part of the polyp does not lift. Once you debulk the tumor, resect the lifting part, the central non-lifting part can be resected using device-assisted endoscopic full thickness resection. Now, Gerdex device, we all know that Gerdex device is mainly used for gastroesophageal reflux disease, but in the beginning, to begin with, this device has also been used to resect submucosal lesions. You just place two pledget sutures beneath the lesions so that you secure the submucosal defect. So you secure the defect, finally you resect the lesions using a polypectomy snare. So this is the last part of my talk, which is hybrid procedure, endoscopic and laparoscopic, where you use the best of the both worlds. Separate different techniques have been described. The technique which I prefer in my center is the classical LES, where much of the evidence has been there. What you do basically is you cut the lesion endoscopically, and finally you close the defect laparoscopically. Because the lesion is large, you also deliver the lesion via laparoscope. So the outcomes again of laparoscopic endoscopic cooperative surgery are very encouraging. I think this is the technique which can be utilized for medium-sized lesions where endoscopy alone may be problematic. So to summarize, ladies and gentlemen, the story so far is exposed EFTR was known for many years. With the origin of over-the-scope clip, we could see the emergence of device-assisted full-thickness resection. And as of now, we are doing full-thickness resections using device-assisted technique, hybrid techniques, laparoscopic, endoscopic, cooperative techniques. And now we know that they are safe and effective. You have to carefully choose the technique according to your own set of lesions. So this is just a summary of which lesions should be targeted using which technique. And this summary slide says it all. Thank you.
Wonderful, Zahir. Really, you have done us proud. And I think that, it shows how far endoscopy has traveled over the last 30 years. Wonderful.
Much earlier. Thank you. This is very good.
So we shall now begin the live transmission from Medanta.
मुझे दिखाएं
I invite the moderators and chairpersons to please come on the stage. The moderators for the session will be Dr. Dinesh Garg, Dr. Amit Miglani, Dr. Amit Mathur, and Dr. Mohit Nanda. And chairpersons will be Dr. Nitin Gupta, Dr. Pawan Rawal, Dr. Praveen Sharma, Dr. Sandeep Bhagat, and Dr. Joseph AJ. I request the chairperson and moderators to please come on stage.
Am I audible in the hall?
You are audible, sir.
So thank you, and we are again back to the live, and this is the second session, and we are planning to demonstrate 9 cases in another 3 hours. So welcome you all to New Delhi and the Endocon 2024, and I request Dr. Jubin and Dr. Bimal to start with the first case with Dr. Nageshwar Reddy. So we can start the proceeding.
Hello, welcome back to Medanta. So the next case is a 56-year-old female who had obstructive jaundice. She is a carcinoma gallbladder, biopsy proven on chemotherapy. And this is the MRCP, which is a type 3 block. The plan is for ERCP and bilateral stenting. Over to OT1 with Dr. Nageshwar Reddy, sir.
Hello, good afternoon, everybody, and I hope you can see us well. I'm in the ERCP room here, and first of all, let me introduce everybody here. Mr. Srinivas, my technician, and we also are assisted very ably by the crew here in Medanta. Of course, we have a fantastic setup here. You can see the images very well. We just went inside now. We are in the stomach of this patient. I reviewed the films, MRCP films. This is very important before doing the procedure. Always review the background investigation of this patient. This patient has a very high bilirubin level of 14 milligrams. And of course, we have a type 3A block. We can't see the right posterior duct well. So I feel that if we can put in 2 stents, one in the right anterior and one in the left, then most likely we'll cover 70% of this liver drainage areas. So we'll see how it goes. We also discussed whether RFA should be done or not, but because this is a gallbladder cancer, RFA may not be the right thing, except for the fact that sometimes doing RFA increases the uncovered stents time. That is, it tends to take longer to get blocked. So this is the only indication here, not for prolonging life. So we start the procedure, and then I pay respects to Dr. Dilavari. I see him there from the back in the audience. I can see his. I hope that's Dr. Dilavari, Professor Dilavari.
Dr. Dilavari?
Young?
Yeah, he's there, sir.
Okay, yeah, good. So he's the one who started all this ERCP business in our country, and I think inspired many. Yeah, I can see your hand. Thank you. Thank you, Jang. So we'll start the procedure now, and what I'm going to do is I'm going to go down in the stomach. So now I've got a Olympus scope in. It's a 190 scope with a transparent hood there. So it makes it a little bulky. So sometimes it's not so easy to go. The patient is absolutely prone. So I'm going to make the patient a little left lateral. So it's easier because otherwise the stomach collapses. I see for any varices in the lower end of the esophagus, there are no varices. I go into the stomach. And then in the stomach, I tend to aspirate the fluid completely because this patient is also on antibiotics, but not on intubation. So propofol. So you see what happens now, the stomach is totally compressing against the anterior and posterior. So I turn the patient a little more. Can you help me with that? And then you can see how nicely it comes out. And those of you who are starting ERCP, this is a nice trick to show you how to get inside very easily. See now, very nicely the antrum area opens up. I go up to the pylorus, and this point of time, I like to take out all the gas in the stomach because it's easier to cannulate when the stomach is not distended. I go to the pylorus, the setting sun appearance, and then get into the duodenum. Because of the tumor, there's a little distortion here, but hopefully, yeah, we are now in the duodenal cap. I turn my small knob a little to the right, fix it there, and then you can see a lot of ulcers there. Looks like an infiltrative disease there. I come back, pull back on the scope. And this is very important again for the beginners. What I'm doing is I'm using a technique where I'm turn my body to the right, pull the scope back and use the up knob. See this? And as I do that, the scope nicely slips inside. And if you can show me the fluoroscopy film at this point, see the papilla there. The papilla starts exactly at the fold which is between the second and third part, and you can see a longitudinal fold going up, leading to the papilla, and this is the papilla. Nice papilla there. So to cannulate the papilla, I'm using clever cut spintrotome, and more important, I'm using a Terumo wire guided, Terumo angled Terumo. And I think if the camera can focus very close to me, you can see why angled is very important. You see, when Srinivas is twisting the wire, it makes a big turn outside. So this case, I expect difficult cannulation because the lower end of the CBD is collapsed. So I have to be very careful about what I'm choosing to cannulate first. So this is a very important wire. So whenever, again, for those who are starting ERCPs, when you have expected difficult cannulation like this, always choose an angled Terumo wire, short wire, and the assistant then can manipulate. So the trick now is I have my scope in a good position. The papilla is right at 12 o'clock position. That's where I want it to be. I asked Srinivas to put the wire out a little, and then I go to the expected area at 11 o'clock, opening of the papilla, and then try and cannulate by lifting the roof up like that, okay? And then we'll ask him to push. So this is a wire-guided cannulation that I'm trying to do. And he's pushing the papillary roof up and trying to go just below the papillary roof. Now as we are doing this, we'll also check fluoroscopically what's happening. Okay. So we have to have a good coordination with the fluoroscopy people. And I'll also give some buscopan at this stage to decrease the contractions. Okay. Now I go here and you can see now wire please. So when it's pushing the wire, it's getting, pushed off by the fold there. So now I change my position a little. This is very important. So you should have a very comfortable position. What was happening was I was going a little more laterally. So now I push my scope down so that I actually now look more medially and then come back again. Yeah, so now I'm more medial. I'm hoping that this will help better. And then again, we'll ask Srinivas to gently pass the wire. A part of his success for this procedure would be the assistance, how he's passing now. Yeah. So now you see he's turning the wire a little up and down. And then I'll again put the papilla more medially and, okay, take the wire in. This time I'm going to go in a little more with the papilla because the wire is getting obstructed there, probably with a fold. So this is very important to learn the different techniques of cannulation. And when there is a collapsed bile duct layer, how would you do it? Now, yeah, now Srinivas. Now he's gone little inside, so I follow the wire now. Now, when you say wire guided, you can inject some contrast also, small amount to know the lower end. So I'm now carefully looking at the fluoroscopy also, and you can see the fluoroscopic appearance here. And the wire is not going further out. He's twisting the wire. If you look at his hand, he's twisting the wire to see if he can go inside. And now he's gone into the duct. You can see this. Now we are in the bile duct, I'm hoping. Who's moderating? The moderator? We can't.
I'm Amit here, Dr. Amit Mathur.
Amit, hi. I can see you now also, yeah. So Amit, we are deep inside now. And this is again a very important point I'd like to emphasize that at this point of time, we should not inject contrast. People make a mistake here, injecting contrast. Only if you can't go in with repeatedly using the guide wire and inject a contrast. So now I'm getting my scope in a good position, and I'll ask Srinivas to manipulate the wire so that we'll try and get inside. Suppose we can't go inside, I'll change my wire to a straight wire at this point of time. I come down a little, there's an obstruction in the hilar region, almost total, so he's trying to get it in, no he can't. So small trick is if you can't, then I'll change to a straight wire. I think we should change to a straight wire. So we'll change now to a straight wire. Again, don't inject. If you can't get in at all, then we'll go for a straight wire. You will use a straight Visiglide wire also is okay at this stage. Visiglide wire 025. I like the 025 Visiglide wire because it's got a very long hydrophilic area. So Amit, any suggestions from your side of the panel?
So I think everybody agrees.
Quite relaxed there.
A lot of people start cannulation with the Visiglide rather than because
We can't hear you, Amit.
So a lot of people start off the cannulation with the Visiglide, which is also quite a good way of cannulating. A lot of people don't use a thermo.
Yeah, very important. That's a very good point you made. I think we must, for initial cannulation, always a angle thermo is very useful. So now I switch to a straight wire, a Visiglide wire, which we are trying to get in through this. We will get through. Now good, excellent. See the change in wire, how it helped. So we have put a Visiglide straight wire, and at this point of time, it's on the left side. So what I'm going to do is I'm going to take out the wire, aspirate bile, whatever comes out, send it for culture, and then inject contrast. So these are all very basic steps. They look very simple, but basic steps. So that then now we can control infections. This patient also has a prophylactic antibiotics given, has indomethacin rectally given, but still you have to be careful about everything.
Say your take on air cholangiogram vis-a-vis injecting contrast.
Yeah, so that's a good point also. There's been study from Randir's unit showing air cholangiogram is as good in terms of the picture, and of course you don't produce infections. We haven't had a lot of experience with this, but what happens is unless you have an excellent fluoroscopy machine like you have here, air cholangiogram may not be very good in terms of delineating the anatomy. So certainly air cholangiogram, especially if you can do a carbon dioxide air cholangiogram, it becomes much more nicer in the sense that infection rates are low. But I think you have to have very good fluoroscopy. We'll put a guide wire inside to go deep into the left duct. And then what I'm going to do is inject contrast. And as I inject contrast, I come down to delineate the anatomy. What I'm going to see here is MRCP right when we say it's type 3A, or is there something else? Because very often we find this discordant between MRCP and ERCP. They're not.
Dr. Reddy, sir?
Yeah.
Till you are negotiating the wire, can we go to the other room and come back?
So the wire is inside. I'll just give an injection and then you can go out.
Yes.
So that we will then we'll also show you the technique of how to put wire in both sides. Now I'm the left side. Okay, inject contrast, and then we'll see. This is a very dilated duct. Very nice. So Rajesh, you can see this. Yeah, it's a left duct which is very dilated. I come back, leave the wire in place. I come back. There's a communication between the right and left. So in fact, maybe even one stent is enough in this case. Inject, contrast. Stop. Okay, now this is a good picture you have. Just keep this picture in your mind mentally, and then you can go off and come back, by which time we would have gone to another side. But I'll also do a sphincterotomy in this case, so that I know that I have to put in maybe 2 metal stents, and also I'll have to probably.
So till you are doing the sphincterotomy, we are shifting to the other room, sir.
Yeah.
And I request Dr. Jubin Dev Sharma to shift to Dr. Amit Mahdev room.
Yeah, okay. Sphincterotomy is
Dr.
over.
Jubin.
Yes, so I'll just present the history. 56-year-old male with dysphagia and halitosis. You can see the images of the barium on the screen. The plan is to do a Z poem, and we shift to Dr. Amit sir's room. Sir, you are all live.
Good afternoon,
live?
sir. Yeah.
Yes, sir.
We can hear you.
So you can hear me?
Yeah.
Okay, hi. So, first of all, I would like to congratulate Dr. Rajesh Puri and his entire team for a really fantastic show. I think this is one of the biggest endoscopy conferences in our country. I can see that there are more than 1,700 registrations, and all the preparations and the arrangements have been immaculate. So thank you so much, Rajesh. So I'm going to show you a procedure of Zenker's septotomy. Now, as all of you know, Zenker's treatment endoscopically has evolved. Initially, when we started treating Zenkers endoscopically, we used to do a direct septotomy using a needle knife, or sometimes we used to use instruments like cutters, like clutch cutter, or even a SB knife, and sometimes even organ plasma coagulation. Then the next evolution was a Z-poem for Zenkers, where we did a tunneling in the pharynx, and from inside we cut the septum, and then we closed the mucosa. Now, as this treatment is evolving, the main reason for starting a tunneling septotomy for Zenkers was by direct cutting of the septum, we could sometimes create a small leak in the pharynx. There was a small percentage of a leak. And that's why we never used to cut the septum completely. So therefore, the tunneling septotomy came, by which we can cut the septum completely, right till its base, till the cricopharyngeal muscle. However, we realized in the Z-poem, in the Zenker's tunneling technique, that after doing that technique, some patients used to come back with some dysphagia. And when we put a scope, we realized that even though the septum, the muscle septum was cut, the mucosa which was inside was still causing a ledge, and some food matter used to go and get still stuck in that septum. So now what I'm going to show you is a modified Z-poem technique, which nowadays we have started using. We have started doing it. And our center, as well as the center from Johns Hopkins, Moin Khashab, we have done a series of patients, and the data is now going to be very soon presented in the upcoming DDW. So this is the technique which I'm going to show you. And to assist me and to support me and to help me out in this procedure, we have Dr. Kapil Sharma, who's from Medanta. And of course, we have Dr. Gaurav Patil, who works with me, who is like my critic, constructive criticism, Gaurav. So I'm going to show you this. I've attached a cap at the tip of the scope, but here I've attached a different type of a cap, not the cap which I normally use for poem. The poem cap is cylindrical. This is a conical cap. Whenever you're doing a Zenker septotomy, it's better to use a conical cap because the tissues here, the space is limited. So therefore, if you try to push a cylindrical cap, you can tear the mucosa, you can tear the tissues. So with a conical cap, it is relatively easier to enter into the tunnel. So my plan here is to first show you, this is the scope I put inside, and left side you can see is the diverticulum, and right side is the esophageal inlet. You see here, the esophageal inlet is closed there because of the septum. But if you see, this is something funny here. This diverticulum is bilobe diverticulum. There is one small diverticulum here, and above is the bigger diverticulum, which is a little bit deeper. So now this makes the procedure a little tricky, but I'm going to first cut the septum, which is in between the bigger diverticulum and the esophagus. So the plan is to create a mucosal cushion, submucosal cushion, by injecting some normal saline mixed with methylene blue. And then I will make a vertical cut on the mucosa, and then try to separate out, section on please, and then try to separate out the mucosa away from the muscle of the septum from both the sides. And after I've done that, then I will go inside the tunnel which I've made, and I will try to cut the muscle of the septum.
What name you have given to this technique, sir?
This is a modified Z-poem. Okay, so now I'm injecting this fluid, submucosal cushion. Yes, inject. Okay,
We are
stop.
not expecting such a significant bleb which we usually see in the poem. A small.
Yeah, obviously, because the space here is going to be limited.
Then you sometimes need to give a repeated injection.
During the procedure.
Nice.
So now I will take the knife, any type of knife you can use. You can use either the flush knife, which we use for ESD, or you can use the hybrid knife, I-type, or here I'm going to use the TTJ.
With the longitudinal incision or transverse?
Longitudinal. If you do a transverse incision, you will not be able to cut the septum completely. Yes, so knife out. So this is not TTJ. This is flush knife. Dual knife.
This is not going to.
Dr. Amit?
Yes.
Once you are completing the incision and coming to submucosal plane,
Yes.
We are shifting to Dr. Sood, who is ready with the
Inject.
CBD stone.
Okay.
So I request Jubin to go to Dr. Sood room and then we will come back.
So right now you are shifting?
So can we shift or you want to have some comment?
Just we want to enter into the tunnel. You can see like a poem, it is
CO2
very
is on?
essential to dissect these fiber. Otherwise, these fiber prevent our entry into the submucosal plane.
Huh? Yeah, so I'm going to go on the right side now.
I think cricopharyngeal muscles are already exposed.
Okay, inject here.
Dr. Rajesh, it's a
If you are
treat
doing
for.
the submucosal tunneling, we can go to Dr. Sood and we'll come back.
Okay.
So Jubin can present and we can.
Yes, so this is a 73-year-old male who has a large CBD stone post cholecystectomy status. Twice it has been attempted to do a ERCP, but it has failed. This is the MR image, and the plan is for a CBD clearance by mechanical or any other means. So over to you, sir.
Good afternoon, sir. Can you hear us? We can't hear you.
Not audible.
So you're not audible. Not yet, not yet.
Anyone from audiovisual?
Dr. Rajesh, it's a treat for all of us seeing all the three stalwarts working together. So it's a treat for the audience as for everybody here.
Yeah. Am I audible? Hello. Sir, you are on. That's the reason. Hello.
Sir, you are audible now.
Dr. Sood, you are online.
Okay. Can you hear me now?
Not very clearly, sir. Can be slightly louder, it would be better.
Okay.
Yeah.
I'm speaking quite loud. Is it okay now?
Yeah, now it's okay.
Okay. This is, as you were told, this is a patient for CBD clearance for large stones. The task I have been given is to demonstrate mechanical lithotripsy if possible. And the scope which I have chosen is 190V. There is certain things which I would like to show to the audience, that this has a disposable cap. Why we kept this disposable cap is because this is one modification which has lowered the rate of clinically relevant infections after ERCP, and possibly, and there is definite evidence that it decreases the possibility of any bacteria or organic matter in the side viewing channel, elevator channel particularly. So it makes our high level disinfection far more effective. So and it also has a little different optics, that it has a back flip of about 15 degree compared to 5 degrees of the regular 180 scopes. So it shows us papilla in a little different plane. So one has to get used to that. It continues to have a V groove in the elevator to make it possible for us to exchange guide wires comfortably.
Can we have the endoscopic image? We not have the.
So I'm just entering the
endoscopic image.
And
Jubin, Dr. Sood, endoscopic image.
Yeah.
I've gone into the duodenum. When I'm at this point, I'll push it a little. I'll make it right and up and pull it back so that my papilla is there. Now, just a question to the audience. This patient has been attempted twice. He has undergone papillotomy. Where will you look for the biliary opening? Right at the apex of the papilla. So this is one mistake which you can do, because if somebody has done a very wide papillotomy, you will see the complete mount, but you will see this hole. Yes. This is actually the biliary's bile duct opening, and because you might confuse it with a small diverticulum. Right. But you must explore it to see whether it is bile duct opening, and that's where we go.
Can we slightly improve the audio? It's not very clear, sir.
Can you hear me now? Because here the voice is very, very good. Hello, is the voice better? You, can you hear me?
Better, sir. It is better.
Do you hear
We
me
can
now?
hear you.
Okay. So now I'm up in the CBD. I'm going to put a guide wire if I can go across the stone, because I've always tried to inject above the stones. If I
Can
can
we
go
shift to the fluoro to Dr.
Fluoro
Image.
put the guide wire. Fluoro on. You see, I'm being assisted by our chief technician Bhagwan, who comes to our rescue whenever we are in trouble. So I have gone into the hilum now. So I'll start injecting here. Inject. Why I do that is that this prevents any small stones flying into the intrahepatic ducts. So you see this stone,
Right.
and then we see whether there are any other stones down there. So you keep injecting above and then keep coming down. This gives you a good idea. It is not a miridi. You see the cystic duct separately and going behind it. So we'll go now with the mechanical lithotripter. So
Dr. Sood, till you are going with the prepare with the mechanical lithotripter, we are going to Dr. Nageshwar Reddy room for 2 minutes.
Definitely.
And we are come back. Jubin, we can shift to Dr. Nageshwar Reddy room.
Sure.
Dr. Nageshwar Reddy, sir, you are online.
Okay. So I think we are online now, but this is what we did when you're away was that we put another wire. You see the first wire is in the left duct, the second wire went into the right duct, so the right anterior duct. There's a short stricture at the beginning of the right anterior duct, so we could manage to get the, so we have two wires. One is a VisiGlide wire, which is left side, and we have the JAG wire, the Boston wire on the left side. So we are giving equal opportunities. Following this, we put in a radio frequency ablation catheter. And fortunately, during this period, we also have advice from Rajiv. Rajiv is behind me, very experienced ERCP. So we took his advice also. We are contemplating whether to do an RFA or just put stents. The reason why we're doing RFA is that this patient has a very a tumor which is just confined to the neck of the gallbladder. So it still could be useful. But most important, we have found that when we do RFA, the stent patency lasts much longer. The uncovered stents compared to not doing an RFA. That's the reason. And you can see RFA catheter right there. You're getting the fluoroscopy picture? Yeah.
Yes,
you can
sir.
see I've
Yes.
placed it exactly in the stricture site. And you can now look at the RFA catheter. These principles are very important. This has got 4 rings and you get about 2.5 to 3 centimeter RFA injury. But the important thing is this RFA generator is very important. If you're looking at the generator, you'll see you have a wattage, we kept at 10, but it's not staying at 10, it's moving rapidly. The reason is the temperature is important. We're keeping a constant temperature at 75 to 74. This is very important. The wrong thing people are doing earlier, or even some of the machines, they give a high temperature, whole thing gets burnt. It's like cooking. But here what we are doing is a barbecue, very slow cooking. And you can see also the impedance. Impedance should not be very high. If impedance goes to more than 100, that means it's not very effective. The time is maintained here. We usually give 2 minutes. So these are the important principles. Look at the temperature, always between 70 to 75. Wattage can vary. Don't worry. Don't put a fixed wattage. The time is 2 minutes, and impedance should be always below 100. If you use these principles, then your effect of RFA is very good. Unfortunately, in the literature, there are a lot of papers saying RFA is not good and so on. The reason for this is because of the fact that these principles are not used. So always this is important. The other important thing is you can see I got my hands very fixed here. If you can see, I got one wire in between my fingers and another RFA catheter here. You should be very still during the procedure of 2 minutes. 2 minutes looks very long in the workshop. You can crack jokes with the anesthetists and so on during this. But 2 minutes, be very still. The catheter should not move. If it moves, the efficacy of RFA comes down again. These are all the general principles. So I think we are almost coming to 1 minute. Yeah.
Sir, meanwhile, one question.
Yeah.
What are the tips and tricks to negotiate wire into the right duct?
So this is again a good point. Unfortunately, we couldn't show it online because you're off. So the thing is that once you go into the left duct, getting into the right duct is much easier because your sphincterotome is naturally oriented towards the right side. So we come down with the sphincterotome, change to a straight wire, and then go up. The sphincterotome is going all the time towards the right side. If you cannot go in still, then of course we have to come really right down to the bottom and then dive from below. The other important thing is, if we still were not possible, we will put a balloon, inflate the balloon, and then you change the angle. For the left duct, it's often more difficult, and what I normally do is I come down hit the wall of the bile duct and then go into the left duct. So these are the general.
So Dr. Reddy, can we go to
Yeah.
now, once
Yeah.
you will come back with the stent placement?
Yeah, yeah.
We are shifting to Dr. Sood room. He is going to demonstrate the
Sure.
mechanical.
Sure. Thank you. Thank you, Rajesh. Thank you.
Yeah. Hello.
Yeah. You're audible, sir.
Sood, you are online.
Yeah. So you see now I'm using a mechanical lithotripsy, which is the Buscopan, please, which is a device with the a Dormier basket with a coaxial steel sheet to crush the stone. The basic thing is that we should be having a technique to enter the bile duct. So you keep the sheath out, and then you must be below the papilla. Use your up and down, up and down knob to get in, and then push the scope down so that you're directing your, device upwards. Because what happens, this is the place where injuries can happen if you're not careful. And then I'm going to ask Bhagwan to open the basket, because I think I'm going into the cystrid. Open this basket a little. Yeah. See? That,
So which sphinctotome are you using, sir?
This is.
Are you not doing a
I'm
mechanical?
doing a basket. No.
Are you going with a routine
This
basket?
is the Olympus,
Olympus
mechanical
lithotripsy, BML3Q. Close. You see, this is the angulation which makes sure whether you're going this way or not. So I've twisted my scope. Can you see it?
Right.
I torqued my scope so that I now will open my basket.
Open.
Yeah. So I have gone up beyond that. So you have to come to a position. Now I have with full open basket. I'm just fluoro, please. So with full open basket, I'm going to catch the, don't move down. Yeah. See this? I'm going to jiggle it so that I get the stone firmly inside the basket. Yes, now it's completely in. I'm going to ask Bhagwan to close the basket.
So you're keeping your basket somewhere in the mid CBD?
In the mid CBD. I'm not pulling it down into the distal CBD.
Right.
Now I'm going to forward my sheath. If you see that the basket is closed too much, that means we are stripping off the stone. It seems a little, just open it a little, open the basket a little, because I don't think the entire stone is inside. Yeah, now it's okay. So you can distort the basket a little and then close it. Yeah, don't close, open. Yeah, now close the basket. Yeah, now close the sheath. Now we'll close the, start closing the basket against the sheath to crush the stone.
So one question, what is your take on the different types of lithotripters?
Well, I think there is only one lithotripter which works always, which is this BML3Q. The trapezoid is not a lithotripter, that's a basket, which is salvage lithotripsy function with it, that in case you're stuck, you can get, now I'm taking out, I'm not leaving the basket now, I'm taking out the fragments,
So thank you, Dr. Sood, and we are going to Dr. Amit Mahdev room. I request Jubin to shift to Dr. Amit Mahdev room. Dr. Amit, you are online. Dr. Amit?
I've done some progress until you were there. So see what I've done.
Dr. Amit,
This is the tunnel in the center. Okay. And this I've gone inside. And this is the septum. So this septum I've already cut a little bit. Now left side is the diverticular area. And right side is the esophageal area. So I have separated the septum out. You can see the muscle here.
Yes, we can see that. Excellent.
So now I'm going to cut the septum muscle here. So let me first go here. Let's take the knife back. Inject.
It was simultaneously myotomy along with the tunneling.
It is almost at the end. See, here the muscle is almost gone. Okay, knife out.
Are we reached the end point, sir?
Yeah. A little bit is left here. Now see this.
This is the cricopharyngeal muscle.
Little bit left here.
Yeah. Yes. Yeah, it's curving like it's a part of it is a muscle of.
Inject here. You have to clean the lens, please.
Here you can see two muscle. One is the cricopharyngeal muscle, another is the esophageal muscles. Sir is being cut to the cricopharyngeal muscle right now.
Now it's cut completely.
Any question from audience and
Any
chairperson?
questions?
Utla motha wala.
Yeah, we have a question from Dr. Nile.
Delay, sir. Yes.
Kutla? Muscle nahi right la. That is the mucosa. That is also left.
Dr. Amit, there's a question from Dr. Nile.
Question for whom?
For you, sir. From Dr. Nile.
Can't hear anything.
So the question is, how can you differentiate between the two muscles?
Cricopharyngeal and septal.
And the septal.
Or it's just a continuum.
Just a continuum.
And you have to just see the approximate size of the diverticulum and cut it approximately.
Yeah. That's a gut feeling.
You can measure by the scope sometimes, but that is arbitrary.
Okay, knife back.
It is important to know where we have to end. Once, where is the base of the septums?
Yeah.
If you go, you start seeing the adventitia at the
Clean,
base
please.
of the.
Okay, knife out. And then I will show you what I'm going to do. I'm also going to cut the mucosa.
So
we
Dr.
don't.
Amit, till you are cutting the muscle, before you cut the mucosa, we are going to Dr. Nageshwar Reddy room. And before you cut the mucosa, we'll come back to you. Is that okay?
Yeah, okay.
So I request Jubin to go to Dr. Nageshwar Reddy. I think he's ready with the double stenting, and we'll come back to Dr. Amit room.
Okay.
Jubin?
Yeah, so we come back to ERCP room, and what we're doing is we are dilating that stricture because we're putting two stents, always better to dilate the stricture. The entry into the right duct was a little narrow, so I'm using a Titan balloon, the 8 millimeter balloon to dilate it. So it's dilated quite adequately. You can see the waste is completely gone. Both the wires are now in place, the left on the main left duct and the right anterior. Again,
So how do you decide which stent to put first?
Exactly, that's a very good point. Normally, what I would do is I'd put the left stent first because that's a more difficult stent to put in, and then put the right. But in this case, the right duct is very narrow at its origin. And again, Rajiv, when we were discussing, we thought whether we should do the right first, followed by left. So usually left should be the first because it's very curved. But in this case, because the stricture is very tight on the right origin of the right duct, we decided to put a thing. So now I'm going to remove the Titan balloon before putting the two stents. But one important principle whenever you're putting double stent is to have both the stents ready, because if you leave too much time for it to expand, then what will happen is the second stent is difficult. We are also discussing a very important concept here. Rajiv was suggesting, why not put a Y stent, a stent instead? Can you ask the audience how many would prefer Y stent at this point of time? Amit, you want to ask the audience? Get a poll. They put side by side or stent in stent? Which would they prefer?
Raise your hands who are willing to put Y type stent.
In fact, how many have tried a Y stent?
Only few hands in the audience. Only three or four
Everybody wants
hands.
side by side.
Yeah.
Okay.
That's safer actually.
Yeah. So this being a democratic country with elections, now we'll follow that. I don't want to get into it. So we'll put in. So what I'm going to do again, this is very interesting, is that I'm going to put both the stents on the wire. See, I'm catching both the wires with my fingers here. You can also use a wire holder, but I'm a little old-fashioned in this, so I use my fingers. So what I'm doing is I'm going to put both the stents simultaneously, because as soon as I release the first stent, the second stent will go in. I don't have to wait for the wrapper to open and so on. I'm using a 10 centimeter, 10 millimeter uncovered 90 stent. This is on a 7 French catheter with a very nice tapered tip, so I prefer that. Of course, you can use any uncovered stents. It doesn't matter, whatever you have. But this stent, one of the advantages is the wire goes right across the whole catheter, so it's easy for our operators to manage it if they get stuck in between. And this is also on a 7 French catheter, unlike other stents which are a little higher, 8 French
So,
catheter.
Dr. Reddy sir, any trick of putting the two stent you feel, or the release is more important, or going inside is more important? What is the difficulty?
Yeah, the important thing is that you have to have both the stents ready. That is the first important principle. The second principle is that when the stent, you're releasing the stent, sometimes it doesn't get across the stricture. In that case, the small trick is to open and close the stent, open and close the stent. When you do that, in a even a tight stricture like this, it goes inside without any issue. And then once you go inside, you can open the stent. The third important principle is it is better to have both the stents at the equal place down, either outside the papilla or inside the bile duct if you're releasing them. Reason is if you want to intervene again, then many of these people are now living long because of chemotherapy. If you want to intervene again, you want the openings to be in the same side so that...
So, Dr. Reddy sir, till you are putting the stent, we are going to Dr. Amit room.
But we'll finish in another few minutes. I'll just see this second stent. I think Rajesh, I'll just finish up in 2-3 minutes. So that again the patient doesn't have to wait. She's very sick.
Sir, is it your standard practice to dilate till 8, or you can do with 6 also?
6, you can do with 6, but this stricture is very tight in that area. So I selectively went into the right and did 8. So now see both the stents are ready, right? See, I'm having this stent in the channel. The stent which is going into the left duct, I'm having it put right at the mouth here. So both the stents are ready. This is again very important to do. So that, see, both stents are ready. So I first deploy one and then quickly deploy the second stent. My policy is to try and put them at same distance, either inside or outside. There's one recent Korean study which seems to suggest that intraductal stents in this situation may last longer, but I'm not sure. Rajiv, can you pull the wire? So he's pulling on. So the first stent is going in now. And again, principles of stenting: be very close to the papilla when using the metal stent. Use pushing more than the elevator up, and you can see the stent going into the right duct. Yeah, nicely gone to the right duct. I'm looking at the lower end of the stent to see where exactly the lower end is down. It's a longish stent, so it's good. Yeah, now open the stent. No, when it opens up, it goes.
Stent makes a difference. Like some stents are stiffer and some stents are more flexible.
Yeah, yeah. So this is a stent which is a little more flexible. That's the reason why I chose this stent. So you can see what I'm looking at is the lower end carefully. The yellow mark indicates the lower end of the stent. So as I'm pulling back, the only disadvantage with stent is not reconstrainable. So now see, I'm out and I quickly put in the next stent beside the other one. So can you pull the wire a little? Okay. Okay, pull, little, not too much. Yeah. Okay. So now I'm very ready, and before the stents expand completely, I have a chance to put the stent quickly through. That's the reason why I keep everything ready. This is a little more flexible stent. Suppose there's any problem now, I can switch on to a stiffer stent from other companies, because this sometimes can buckle if there's a resistance. So pull is going to pull on the wire so that I get a good opening. Yeah, you can see the stent going in now. Hopefully it crosses that. Rajiv, yeah. We're all praying for this, that it goes through. Yeah, this is the tough part, it's going in now. I'm using a thumb a little here, although I don't like to do that much. It's gone in now, gone in. Yeah, hopefully. Okay, now it's gone. So now I'm going to release the second stent there, and then wait. And then pull back a little so that I get equal. Yeah, now release. Srinivas is going to pull back a little. Back, yeah, pull back a little. Yeah. Now both are open in same. And then I think you can see both the stents are in place. Fluoroscopy, please. I want to see, yeah, they're opening up also nicely.
Thank you, Dr. Nagi sir. Thank you for the nice demonstration.
Yeah.
And we are shifting now to the Dr. Amit Mahdev room, who is ready with the cutting the mucosa.
Thank you.
Thank you, sir.
So are you there with me?
Yeah, Dr. Amit, you are online.
Online?
Yeah.
We can hear you.
So you can see now I've already done the muscle septotomy. I'm now going to cut the mucosa to open up everything.
Dr. Amit,
Yes.
if you give 1 second, Dr. Sood want to show fluoro image, we are coming back. So I request Jubin to shift to Dr. Sood. Just wait for 2 seconds. He is coming back. Jubin, can you shift to Dr. Sood? Yeah, Dr. Sood, you are on the line.
Yeah, just 1 second, because I just wanted to show the completion cholangiogram. You can see that, do you see the fluoro image?
Yes, sir, we can see that.
Yeah, so complete clearance of the CBD has been achieved. So the trick was to completely crush the stone and take out all the fragments. And there's no need for leaving a stent in such a situation where you're sure that there is no stone left.
Thank you.
That's why we took the.
Thank you, Dr. Sood. Thank
Okay.
you. And we can
Thank you,
go
sir.
back to
Thank you.
Dr. Amit
Thank
Mahdev
you.
room.
Are we on?
Yeah, Dr. Amit, you are online. We can shift to Dr. Amit Mahdev room. Dr. Jubin.
Are we?
Dr. Jubin.
No, we are not on.
Dr. Amit?
Dr. Amit, you are online.
You can see now.
Yeah.
So I've done the muscle septotomy. I'm now going to cut the mucosa of the diverticulum side and also of the esophagus side. So now this first is the mucosa of the diverticulum side. Okay, so this is that mucosa. Let's start from here.
This is the new concept in the JED poem. Initially, everybody was afraid for doing this mucosectomy, because if we leave this excess mucosa, it can give rise to the recurrence.
See, we almost come to the base of the bigger diverticulum.
Very fast and very meticulous.
And now we cut the esophageal mucosa.
So what is the endpoint on esophageal side?
It should become flat.
It should be wide, inlet should be widely opened.
Yeah, see, you see this gap here? That gap shouldn't remain.
I thank the moderators and chairpersons. I'd like to invite the next moderators and chairpersons, Dr. Arvind Gubi, Dr. Shaina Parveen, Dr. Arvind Kurana and Dr. Bilal Ahmed Khan will be moderating the session. And chairpersons, Dr. Gopinath Ramaya, Dr. Harshal Gadikar, Dr. Kinsuk Das, Dr. Munish Chhatjeva, and Dr. Sunil Jain. I please request the moderators and chairpersons to come on the stage. Thank you.
Listen.
We always cut the plan.
Huh?
We always cut the plan.
Yeah, now we have started. Now we have started cutting, because with this, what happens now, there is no ledge formation. And now we have done proper complete septotomy of the muscle, at the same time proper mucosa, but all under vision, so that it doesn't cause a leakage. So now see what has happened here. Now there is hardly any diverticulum left. Here, this is the first diverticulum, which is very tiny, and the second one is also not there. And if I put the scope is going very freely inside the esophagus.
So thank you, Dr. Amit. And we are shifting to Professor Anthony Theo room and Dr. Jubin.
Yes, sir. So I'll just present the history. 45-year-old female, autoimmune hepatitis, suspicion of cirrhosis with dilated portal vein. And the plan is for a PPG measurement as well as for a liver biopsy. Over to you, sir.
All right, hello, can you hear me? Hello. So we have a case of a autoimmune hepatitis patient here. So scheduled for US guided blood pressure measurement as well as the liver biopsy. So before we go to US view, I want you to look at the endoluminal view. So I'm using the Fuji scope, which has a almost straight endoluminal view. This is together with a Arietta 850 module. So before we do the US, I want you to focus on the luminal view because we want to see if there's any esophageal varices. And you can see right here, it looks very nice. So no varices. And I'm going to insert my scope deeper into the stomach. Again, in the antrum, you want to look for any portal gastropathy, very minimal. And with the Fuji scope, this has a very nice angulation. So we can actually try to assess the cardia. Here. So no GV. I don't think there's any GV.
No.
So at least in this patient, just by endoscopic view, we don't expect her to have a very high portal pressure.
Right.
So can we change to US view? We have the US view.
Are you getting the US picture? Yeah.
All right. So this is the Arietta 850 module. You can see a very nice resolution. This is the liver, and you can see some heterogeneity in the liver parenchyma. With the 850, we can also use a elastography to assess the
Stiffness
of the liver. So you can see this is quite heterogeneous. Some areas are hard, some areas are medium, and with some 850 module, you can actually measure the shear wave elastography. So very similar to the
ME3
FibroScan kind of imaging. So right here, we want to identify several things first before we measure. One is the portal vein. So if you look at the left lobe of liver, if we scan through the liver slowly, you can see the portal vein is usually surrounded by a white capsule. This is the Gleason capsule. And as I turn clockwise, you see the umbilical ligament curving towards here. And this is the segment 2, segment 3 portal vein joining into the main portal vein, main left portal vein. And then if I rotate further, this will become the main portal vein right there. This is the branching to the right side, and this is to the left side. So for puncturing of the portal vein, we want some liver parenchyma. So probably somewhere around here, it's good. So we have a bit of a parenchyma around 1 centimeter, and the portal vein here is standard to around 7.8 millimeters.
So is there any amount of threshold you need of liver parenchyma to puncture?
Well, around 1 centimeter is fine, I think. And then if I pull my scope further up, you can see the left hepatic vein. This is the left hepatic vein joining into the IVC right there. Yeah.
Yeah.
And this is probably the middle. Yeah. Okay, so
yeah,
the left hepatic vein is quite big. So right here, it measures 4.7. And then we have quite a bit of parenchyma, around 2.4 centimeters.
Yeah.
So this area is good for puncture. And since we are here, we'll just do quickly a color Doppler, make sure there are no varices around the stomach or the esophagus. All right, so from the left side of the liver, I think we have quite a nice area for puncture. So remember during my lecture, I also said if we have problems with the left side, we can also go to the duodenum and assess the right side. So here my scope is in the duodenum. You can see the gallbladder here. If I rotate my scope further, right here,
Portal vein.
you have a nice angle for the portal vein, right side. And then just now we were trying to see if we can see the the right hepatic vein from this
The
area
duodenum.
as well. And then we had a glimpse just now.
There. There.
Well, just now we saw it. I'm not sure if we can see this time.
A little more anti-clockwise. Yeah, there.
So, Dr. Anthony?
So this is the right hepatic vein actually, right there.
It's a rather uncomfortable position.
Yeah.
Dr.
So-
Anthony?
Yes.
Can we go for a few minutes to Dr. Amit room and come back?
Okay.
I
So we
request
have the
you-
total pressure device ready.
Yeah, I'll put the needle in.
Dr. Jubin, we can go to Dr. Amit Mahdev room. Dr. Amit, you are online.
I've finished the procedure, Rajesh.
Thank
So-
you,
So
sir.
you can
Thank
see
you.
here now that the septum is also gone, mucosa is also gone. So where is the diverticulum now? We can't see it. Left side was the diverticulum. So I've gone right till the base. And right side, this is the mucosa of this is the esophagus. Now it is a free entry into the esophagus. So now what happens is this becomes like one raw surface which will heal. But there is no leak into any space. And because now there is no mucosal ledge, there are no symptoms afterwards. I hope everyone is convinced.
Yeah, thank you, Dr. Amit. And you want to say something or we should go to other room?
No, I'm quite okay with this. Maybe with this little bit of refashioning I would have done. Right side, this little ledge is there, I would have cut that also.
And what is the plan like oral,
So
liquid? How
24
do you proceed?
24 hours, we put a Riles tube, nasogastric tube. And then
Okay.
after 24 hours, in case in your initial stages, you can do a oral gastrographin study just to make sure that there's nothing going into any space. And if nothing is going, take out the Riles tube and start liquids orally.
As rightly said by Sood sir, it's a traditional septotomy which is done in the 3-layer.
Yeah.
And the advantage that we are able to reach the base and we're able to do
Exactly.
extend myotomy on the esophageal side.
Yeah.
And then we cut the mucosa, the chance of recurrence is absolutely nil in this case.
Yeah,
And we are
because
going to open these areas.
if you ask me personally, trying to do a traditional Z poem, making a tunnel in the pharynx is making a simple procedure difficult. Because making a tunnel in the pharynx is not easy. Every time it bleeds, sometimes you can't reach the septum properly, and then closing with clips in the pharynx is not easy.
Thank you, Dr. Amit. Thank you. And hands to Dr. Amit, clapping for Dr.
We need a
Amit.
round
And
of applause for Dr. Amit sir.
we are going to the next room to Anthony Theo where he's waiting. So I request Jubin to go to Dr. Anthony Theo room. Dr. Anthony, you are online.
Okay, hello. So can you show the US view again? So right here, the needle has been inserted. You can see the whole device is connected to the portal pressure gradient device.
Can you
which
show
is
the
right
device?
here below my finger. So it's
Can you see it?
right there. So maybe we can show it later, okay? So right now I'm gonna puncture the hepatic vein.
US image, please.
There you can see my needle.
Yeah.
So you can see the needle is inside the hepatic vein. Okay, I'm gonna ask Ankit to flush for me.
Yeah.
Flush. And at the same time, we see if there is any.
Flush.
So you can see in the needle
Yeah.
tip, you can see some fluid. Yeah, right. Flush a bit more. Because as I mentioned, sometimes there will be some tissue stuck on the tip of the needle. Okay, I think that's good. And then now we just wait. So if you have the video, you need to come here and see this
The device.
because the pressure is coming down to around 52. Yeah.
Can you see it?
So now it's 36, 35, 34, 30, 28. You need to zoom in a bit more, I think. 22, 21, 20, 19, 18. Right here.
Yeah.
So 15, 14, 13. So this device is placed at the right atrial level. 11, 10, 9.
Kindly zoom it out, zoom the picture.
9, 8.
6.
So for the hepatic pressure, for this lady, because she has a relatively normal liver and she has probably quite a normal past health, I don't expect it to be very high. So this is around 7 millimeter
7.
mercury. So it stopped.
Yeah.
We are not able to see this. Kindly zoom it out.
Can you zoom out a bit?
Zoom in.
I think
Bigger,
the
bigger.
image is getting blurred. The image is getting blurred.
So now it's around 6 millimeter mercury.
No, no, ऊपर नहीं उठाना है वो heart के level पे रहना है.
Well, let's take a picture with the iPhone and show them.
I'll do that.
Okay, can you show the picture?
Photo. Here.
Can you show him?
And
So that's 6 millimeter mercury. Okay.
Yeah.
Yes, yes.
I'm gonna do this 2 more times. Okay, can we flush again?
Yeah.
So usually it's very accurate. Usually within 1 millimeter mercury or even 0, the same measurement or 3 times. Okay. Oops. Okay, so now if you look at ES view, my needle has changed position. It's out of the vein, so I need to push it back in. Okay, and then anchor it. Can you
flush again?
Yeah, flush again for me.
Yeah.
Okay, thank you.
And again, it's gradually coming down.
Okay, 27, 26. 19, 18, 17. So this procedure actually is very similar to just our FNA procedure. So
So if your needle changes position, does it matter? If
well, I think it's still the same puncture site. It just
Yeah.
moved out from the vein, so I think it's okay. Still the same area where we punctured. So we can see if there's any change
in the
needle.
value.
So now it's 11, 12.
Coming down.
Particular time that you get?
Till it stabilizes.
Yeah, till it's stabilized. So now it's around 11. So you see there's a bit of discrepancy.
Discrepancy, yeah.
First one is 7, now it's 11.
11.
So we'll do another flush.
Yeah.
Because we did go through a bit of living parenchyma, and the position of the needle has changed a little bit.
Huh?
Great, thank you. So we're gonna repeat this procedure until we get 3
Consistent
readings.
values.
Yeah.
And we know, other than demonstration purpose, what was the indication of measuring this portal pressure in this very patient?
Indication was autoimmune
Hepatitis. It's coming down.
14, 15, 14.
So you do the 3 times reading every time you puncture?
No. We just stay in the same position, but we flush.
We just flush the device here.
Yeah.
So,
So how many reading we have taken?
so this is the third reading we are taking.
So till can we go to other room, and when you come to the portal vein, we are coming back. Is that
Okay,
okay?
yeah.
Sure. Yeah, sure.
I request Dr. Jubinder
11.
Sharma to go to Professor
11. You want flush more?
Newhouse.
Okay.
So
He
we'll
is
take the
ready
last
for his
two
case
readings.
with the ampulectomy. Dr. Juben?
Yes, sir. So this is a 42-year-old male who had incidentally detected periampullary mass. Biopsy showed an ampullary adenoma. The plan is to remove it and block. So over to you, sir, in OT1 for ampulectomy.
Yeah, you're online now.
Oh, so hello, good afternoon. Horst Neuhaus from Düsseldorf, Germany. It's a great pleasure for me to participate again in Endocon and to attend here the live demonstrations. And I have perfect conditions here, wonderful unit, great team. So I will be assisted by Sinvas and Nagi. Reddy is, of course, I'm a little bit under pressure when he's standing behind me, but so everything is well set, and I'm using the Olympus TG F1Q190V. And as you can see, we have an excellent vision of this lesion here. So the first, what you should consider before resection, is there any evidence of malignancy? That means, is there an ulceration, which is not the case. So it is movable, which is a good sign. And we can also evaluate the surface. Also with NBI, you see a regular pattern here. So there is no suspicion for cancer. And therefore, I think a very good case for endoscopic papillectomy. And then the next question is, do I need ESCP? I won't do that. Firstly, it's not so easy to identify the papilla. It's probably here, somewhere here in the center, probably here. But we have EUS and MRCP was done, so there is no ductal infiltration, therefore no need for opacifying the ducts. But we just consider to resect this lesion en bloc, to get a good specimen and then to identify the pancreatic orifice. Next question, is it sessile or is it's pedunculated? So I move it here around, and as you can see from this point of view, it's obviously pedunculated, like a polyp in the colon with a stalk. So I pushed it upwards. Usually, I think we try to grasp it from above, but here we have two options. Yeah, I think I try to grasp from above. So we have a snare master prepared, and now I asked Simmers to push the snare a little bit out. It's 20 millimeter in diameter. So we want to cut from here, from the normal mucosa. So I get it here at this side, even a little bit higher. So now open it more.
Open.
Okay.
Yeah.
So, and now I move the scope slowly forward. Open it now completely.
Complete.
It's completely. And now I move forth and back to get it completely inside the snare.
Yeah. This is a very important movement that Horst is showing, how he rotated the scope to get the
Close
whole
it a
thing
little bit.
inside. Beautifully
Okay.
done.
Okay, close it
Close,
slowly.
close, close.
No. So now before we resect, we reconsider if it's still.
Horst,
can I ask question?
Yeah,
Yes,
please
please.
go ahead.
Do you go for US before this papillectomy?
Not necessarily, but I think it is advantageous, especially when you want to avoid ESCP before. I think we are in a good position.
Yeah, good position.
Yeah. To rule out intraductal infiltration, And MRCP has also the advantage that you can identify lesions case with pancreas divisum. So you see the whole lesion gets a little bit bluish. So it's triangulated. So, and now the next step is I pull a little bit. So to avoid that the tip of the snare is touching the duodenal wall, which would increase the risk of thermal injury and delayed perforation. And now I choose the endocut mode, effect 2, so not too much coagulation, cutting duration 1, cutting interval 3. So 3 means we will have an alternation, cutting coagulation, tuck, tuck, tuck. If we would set it on 1, it would go even faster, tuck, 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 but this would increase the risk of bleeding. So it must be a mix to minimize the risk of bleeding. So more effects, longer cutting duration, but on the other side, we want to avoid thermal injury to the pancreatic orifice and want to have a good specimen.
And the snare you chose was a monopolar, or what type of snare do you prefer?
This is a monopolar, yeah. So I pull a little bit, and now I activate endocut. It's already off.
Yeah.
So and now the most difficult part to grasp the specimen. So open. So we don't see any blood, which is a good sign. So we try to get it here. I lift the elevator. So close it.
Yeah.
So I move it in the.
So do you take it out completely and then go in, or leave it in the stomach?
No, we leave it in the stomach.
Okay.
Open. We can do it after live.
Okay.
Or we can close it. We can also remove it quickly.
Yeah.
So because we have a good catch.
Take the nail. Yeah.
So can we go to the another room and
Yes,
we come
yes,
back?
please. Yes, please.
So I request Dr. Jubin Dev Sharma to go to Professor Anthony Theo room. Dr. Jubin?
Yeah.
Okay, open.
Dr. Anthony, you are online.
Okay, so we are ready to puncture the portal vein. You can see the portal vein here. My needle is coming out. So it's going through a bit of liver and then going into the portal vein. Right, and then we'll flush.
After flushing, now we are.
Pressure is coming down again.
You want to focus? Can you focus again?
So the portal pressure just now from the hepatic vein is the 11. And a normal difference should be 0 to 5 millimeter mercury. So in this patient, I actually expect the
Normal.
pressure should be pretty normal.
Normal. Or maybe slightly elevated.
So now it's down to 16.
Hmm.
And then stop.
16.
15. All right.
Yeah.
Can we flush one more time? Okay, great.
It's coming down. It's coming down.
26.
Hmm. So if you have variable values, what do you take, a mean or a median?
Mean.
Okay.
Mean. So average of 3 values. So now it's 16.
Yeah. Needle. Yeah. Flush again.
Okay. Again.
Second value also 16.
Sir, we will just shift to OT1 for 1 second to show the base of the tube area.
Up to you, we're finishing anyways.
Yeah.
So 26.
Yeah, so
Okay.
as Horst is showing the base, quickly just to show you, if you can, the camera can focus on the specimen here.
So
It's
show
stretched
the
down
tip-
on
the
a
tip
foam
of-
board here, and you can see it's about 2 centimeters in size. There's an opening you can see very nicely there. Okay. Horst.
So I try to get the wire first inside.
Or maybe a little above.
If preamplectomy CT shows large feeding vessel, do you have specific adjustments in RB or cautery settings?
You should try above.
Yeah, I think it's a little bit above here.
You change the.
This is probably the bile duct.
No.
No, it's a
PD.
PD. It's a PD, as you can see.
So regarding the setting,
Okay. So the setting.
They wanted to know whether it's a large vessel feeding, whether you'll change the setting. You'll change the wire. Can you
No,
push it?
no, we can change. We push over this one with this assistance.
So anyway, as the Horst is doing this, we generally don't. But what we have done recently is, if the size of the tumor is more than 3 to 4 centimeters, we do an angioembolization and then do the procedure. We find that bleeding rates are very low with this.
Yeah. So of course, when there is an even bigger stalk, I would increase the effect to 3 and extend the cutting duration to 6. Then it's cut. And what is also important was Sinvas, who is very experienced, already did, to close the snare tightly when you have the specimen inside. Because if it's too loose, then you don't have enough tissue, and then it coagulates and coagulates but doesn't cut. So we prepared a 5 centimeter single pigtail PD stent. So we changed over the terumo wire. This should be only done with expert assistance because you may easily lose the wire. So pull it a little bit.
Yes.
Just 1 more second. Okay,
Yeah,
we are
let's finish
right.
this.
Yeah, we finish quickly.
I think it's also important that you wait for some time, because the bleeds generally occur a little later, not immediately.
Okay.
Okay.
So
Yeah.
okay.
Yeah.
Remove.
Yes.
Okay.
Okay. Perfect.
I think a big round of applause for Professor Horst. Thank you. And can we shift to other room?
Yeah.
Questions to
Rajesh, just a minute. That should we put something like clips or a PC or a hemospray even on this prophylactically? Because there's a large lesion supposed to bleed. Possibly there is a good chance, as Dr. Reddy was telling. Kingshuk here, Dr. Reddy.
Yeah. No, I think Kinshuk, we will not put any because it's actually a few RBC there, not much of a bleed. And even if there's a little bleed, you can always use a co-op grasper to actually stop the bleed.
But we don't see, this is quite a spurter, and this is more a little bit diffuse, but you see no blood here in the descending part. What we do, and I think you do the same in your institution, before the patient is sent back to the ward after 3-4 hours, we have a short second look.
Yeah.
And because usually it bleeds right after, within a few hours after the procedure.
Thank you, sir. Thank you for the nice demonstration. And we
Thank
go
you.
back to Anthony Theo room. I request Jubin to shift to Anthony Theo room.
Thank you.
Professor Anthony, you are online. Professor Anthony, you are online.
So
Actually, you did a
liver biopsy.
liver biopsy. So we can do it one more time.
So,
Show it over here.
Can you tell the steps of liver biopsy?
Why
Can
don't you do it
tell
one
the
more
steps
time?
of
We
liver
can do it
biopsy?
quickly one more time. So first of all, we used a 19 gauge acquired needle, and it's a heparin flushed needle with a negative suction of 20 mils heparin saline.
Flushing it.
And then we try to find a long segment of the liver, for example, here, where we don't have any veins or bile ducts to puncture. And then we would do a long jab all the way to around 4 centimeters and try to get a long core of liver tissue. Right, so the venous here, 4
We measured.
centimeters.
We measured already. It's about 4.5 centimeters.
Go for a long fast jab. So just now we were discussing whether we should do a few jabs or not. Ankit does it for one. I added a few more. All right, I think that's enough.
Yeah.
Right. And then we observe for any bleeding.
Okay. Nothing. So वो तो उसमें दिखा पहले का टिश्यू दिखा देते हैं.
So that's it.
So this is the tissue we got from the first sampling. You can see there's a good long core. Yeah. Yeah, it's falling. You're speaking the formality.
Okay, so thank you.
Thank you.
So, Anthony, you want to say something or we can go to other room?
Nothing. I think Dr. Puri, you've been doing a great job. So thank you for having me.
So the
And what
final
was, what was the portal pressure gradient in
5.
this case?
So 5.
The difference was 5 millimeter mercury. Normal.
This patient has an autoimmune taking treatment from last 2 years, but his fibroscan value was, I think, 27, if I'm not wrong.
Yeah.
That shows F4 fibrosis, but no significant portal hypertension.
No, so no varices, no portal hypertensive gastropathy.
Thank you. Thank you for the nice demonstration.
Thank you.
And now I request Jubin to go to Dr. Vikas Singla room. Dr. Jubin?
Yes, sir. So the next case that we have is a 29-year-old male who had refractory GERD like symptoms, PPI dependent. There was lax LES. Previously, it was a LA grade B esophagitis. Manometry is fine, but the demister is around 36, 38. And he's going towards ineffective motility. The DCI is around 600 right now, but will get weak. So we go for ARMA by Dr. Vikas Singla, and we move to that room. Sir, you are live.
I thank the moderators and
Good evening,
chairpersons,
everyone.
and I invite the
Dr.
next
and
moderators
thank
and
you to Dr.
chairpersons
Rajesh
for
for
the
the
next session.
time.
Dr. Pramod Mittal, Dr. Arun Sharma, Dr.
Going
Nikhil
to
Mahajan, and Dr.
perform
Jaideep Sarkar
ARMA
will be
in this
moderating the
case.
session.
Dr. Arvind,
And
can you
chairpersons will be Dr.
Dr.
Rajneesh
Mani?
Monga, Dr. Ramesh Garg, Dr. Rohit Gupta, Dr. Sandeep Pandey, and Dr. Deep Goel. I request the
Are we
moderators
audible in
and
the hall?
chairpersons please come on the stage.
Are we audible there? In the hall?
Yes, sir. You're audible there.
Yeah. Vikas, what's your take on why you prefer ARMA in this case?
So Kapil, whenever we do endoscopic anti-reflux treatment, first thing is to confirm the diagnosis. So there should be classical symptoms of GERD like heartburn and the regurgitation. Then on endoscopy, there should be either B, LA grade B, C or D esophagitis that will confirm the diagnosis. If endoscopy is normal, we have to go for pH study. On pH study, you look for the acid exposure time. If it's more than 6%, that qualifies for the diagnosis of GERD. And the pH study is mandatory prior to performing endoscopic anti-reflux treatment. So the choice between the surgery and the endoscopic treatment depend on the anatomy. And second is the patient wish. Because the efficacy of endoscopic treatment is around 60 to 70% compared to surgery, which is 90%. And second choice will also depend on the type of G junction. So first we will examine in the antegrade examination. So we can see in this patient with the GERD, there is no Barrett esophagus and there is LA grade A esophagitis. We can see slight, slightly LA grade A esophagitis. And on antegrade examination, there is no large hiatus hernia. So if we have hiatus hernia more than 2 centimeter in size, endotherapy will be less effective and should be avoided. In this patient on antegrade examination, we don't see any hiatus hernia. So this patient is candidate both for either a long-term PPI as he is PPI dependent. Other option is going for anti-reflux surgery. And third option is endoscopic treatment. So we have various options, endoscopic mucosectomy, that is arms, or we can do ARMA. So in this patient, first we have to examine the G junction in retrograde position, which is very crucial. So first we look at the flap wall. So on the left side, this is G junction. So on the left side, we can see this is the flap wall. So this is a longitudinal fold. So so we can see a ridge which is just touching the scope. So this is lip of flap wall, and here we can see length of flap wall. It is measuring around 2 to 3 centimeter in length. So flap valve is nothing but the lower esophageal sphincter along with the mucosal fold. So in this patient, we will do the Hill grading. For that, we have to spend some time in retrograde position. So we should fill the stomach with the air and folds should efface. Now we can see most of the folds have been effaced, and we can again examine the G junction. So we can see there is intermittent opening of, now we can see there is intermittent opening of the crura. So this is likely Hill grade 2 or Hill grade 3, likely Hill grade 2 because there is intermittent closure of the flap wall. So crura are slightly lax, and then we look for the Z line. So this impression is because of diaphragm, and we can see Z line is within 1 centimeter of the crura of diaphragm. So there is no axial migration of stomach. So there is no hiatus hernia. So this is Hill grade 2 with slightly patulous G junction. Crura are slightly separated, and there is no hiatus hernia. So this patient is an ideal candidate for the endoscopic anti-reflux treatment. If patient want to avoid long-term PPI and not willing for surgery, surgery is still the gold standard treatment for the if you want to fix the loose G junction. If the patient is not willing for the surgery, then we can offer endoscopic treatment. So plan is to do ARMA in this patient. So we are planning 270-degree ARMA in this patient. On the right side, we can see this is the lesser curve, and the left side is the greater curve. So we will leave around 1 centimeter area on the left side, and we will do ablate more on the upper, lower, and the right side. And we are using the force APC in this patient, setting our 70-watt energy and with the organ flow of 1 liter per minute.
So Vikas, Rohit here, do you need a manometry or pH metry in all cases, even if there are ulcers in the lower esophagus?
Can you repeat the question?
So if the patient has Hill grade 4 with the proximal shift of Z line by more than 2 centimeter, in this patient endotherapy should be avoided.
No, my question was, do you use pH metry in all cases, or you can, if there are ulcers in the lower esophagus, then you can do it?
So if the patient has active ulceration, LA grade C and D, it should be avoided. First, we should start PPI. Only after healing of ulceration, we should do the endotherapy. So first, we'll mark an area of 1 centimeter along the towards greater curve. So we are using force APC.
It should be 1 centimeter, 2 centimeter away from the.
Yeah, it's around, so gap should be around 5 mm to 10 mm. So our APC should start 5 mm from the lip of flap wall.
So till the Vikas is completing, we are going to the room number 4 with, I request Dr. Jubin to go to the room with the esophageal ESD. Dr. Jubin?
Manometry is essential before.
Yes, sir. So the next case that we have is a 56-year-old female who had a nodal lesion just above the GE junction and suspected to be high-grade dysplasia or carcinoma in situ. The plan is for evaluation of it and an EST.
Are we live?
Yes, we are live.
Yeah. So Zubin, thanks so much for the invite. So this is a case who's been referred for a esophageal resection of a high-grade dysplasia. So as Dr. Pankaj has we were just seeing this case offline, and it's quite slightly a atypical case. As you enter the G junction, can see a laxity at the LES, and the moment on white light endoscopy, you can see there is some nodularity which is around 12 o'clock, 11 o'clock area. So the moment you see that, and you first visualize the normal mucosa of the esophagus, which is the squamous epithelium, and you go close to the squamo-columnar junction. Now, on white light examination, the first thing that you notice are two nodules, and these nodules can be well appreciated with the distal attachment. The nodules come on face, and you can visualize them even better, study them better. And these nodules are irregular, and this is the TXI mode. This is a mode on the 1500 series of the Olympus endoscopes. And with this, you can, you're able to get a grasp of good surface architecture of the entire lesion. Now, once you start seeing these nodules, you start to wonder whether these are inflammatory or whether this is something which is a neoplastic process that is going on in the esophagus. So for that, you need to first differentiate whether it's inflammation or not. So there are two ways to do it. One, which is with the endoscopy, you can do electronic and chromoendoscopy. That is, we use the NBI on the Olympus system, and now the NBI mode is on. And over here, you can see there's a lot of distortion of the surface architecture. There's no normal surface pattern that is seen. The
Absolutely.
microsurface pattern. What do you think, Dr. Pankaj?
Yeah, I think this is the nodule which is appearing dysplastic. You have vascular irregularity, you have some bare areas there. And also when you are looking on the other side, this is a normal gastric mucosa below it, which you see here. And on the other side, there are other couple of nodules just adjacent to it. So I think this is the only area which appears to be dysplastic, Gaurav.
Yeah. So we always want to biopsy these lesions prior to deciding whether you want to go ahead with the EST. So was a biopsy done, and can we have a confirmed report that this was dysplastic?
I think they have done a biopsy somewhere outside, and that biopsy is showing carcinoma in situ, right? And or high-grade dysplasia. So what I think is we were just contemplating whether we should go on this side, but I think this area appears more of inflammation. What do you say? Or should we include this in our resection also?
I think, yeah, this is slightly, irregular. Yeah. Yes.
Yeah.
So we would want to, even here, the best.
Pankaj,
Yeah.
Nilay over here. I don't think it's inflammatory. Take it out, huh?
Yeah, we are just.
It's nodular. See the vascular.
Yeah. We already started. We off screen. We already started our marking, and we have included that in the distal marking that we have done here, as you can see. And we would try to remove this entire part from say 9 o'clock to 3 o'clock. Yeah, that is what our intention is, right?
Yeah.
So I usually would start by doing markings. I would prefer to use a dual knife, which 1.5 centimeter length, and we would be using this is the Olympus scope X1 series, as you all know, and you can see a beautiful picture here. We have put on this narrow band imaging with near focus view, and you can see the beautiful architecture here with this scope. So should we start going with the marking?
So Pankaj, you are going till marking, and I think Vikas is ready with this case. So I request Jubin to go to Vikas room.
Yeah, you can go and come back. We will just mark and see.
Jubin, we can shift to Dr. Vikas Singla room.
Are we on?
Dr. Jubin?
Vikas sir, you are online now.
Yeah. So
Dr. Vikas nicely made a necklace.
So we have spared 1 centimeter diameter on the gator curve. So scope diameter is 1 centimeter, and we can see that we have left 1 centimeter area on the gator curve, and the width of area ablated, the diameter should be width should be around 2 centimeter, and we can see the width is around double the size of scope. So it's adequate width is there. Maybe we have left small area here, so we will ablate this area also. Small part is left. But I think rest of part we have got enough width of 2 centimeter, and we have spared 1 centimeter. So if we do the 360 ablation, there is risk of stricture formation and dysphasia. So Kapil, do you think we should? So I think width in this area we can do more ablation. This part. So we can. I think we can increase depth in this area.
Slight increase in depth in this area.
Yeah, because still the pinkish mucosa is visible in that area. So we'll do slightly more ablation in this area. So Kapil, what's your preference? You do ARMA or arms in your patients?
I do ARMA.
Yeah. In
What
arms,
do you think? After arms, ARMA can be done.
yeah. So with the arms, actually, there is a risk of perforation also, and the efficacy by both are same. I think that's width is enough, I think.
Width is enough.
Yeah. So this patient should continue PPI yeah.
I think Kapil is right that if you do arms first, you can fall back into this procedure later on.
Yes, yes, yes. After ARMA, there will be fibrosis. You can't do arms after ARMA.
Yeah.
I think the patient selection is the most crucial thing. The patient who has proven GERD, who are PPI dependent, they benefit best from this treatment.
So, Vikas, how do you control the depth? Which depth? Is it subjective or?
So just disappearance of the pinkish hue. So wherever, so there shouldn't be any pinkish area visible.
You can see some island of.
Yeah. So movement with some charring and try to stay away from the mucosa. That way you can control the.
We are very close.
Yeah. Maybe select.
So thank you, Vikas, and we are going to the room number 4 with ESD case. I request Dr. Jubin to go to the ESD case.
Okay, back. Hold the scope, please. Scope pakdo.
Pankaj sir, you are live back.
Yeah. So what we have done is we have marked the lesion distally and a circle needle out. And we are injecting, we just try to see how we see in the retroflexion, and we are seeing the lesion well. So what I am doing is, what I would like to do is put a incision distally first and then start dissecting from the top. That is what my preference is, Gaurav.
Yeah, I agree with
Back.
it. The lesion is more on the it's on the Z
Dual
line, and a part of it is moving towards the fundus. And once you go in the stomach and retroflex, you can see the distal margin of the of the incision of the mucosal markings. So now what Dr. Pankaj is going to do, very expertly going to create a smiley type of mucosal incision, which will incorporate all these white markings that you've done. And the advantage of doing a retroflexed position of the scope is that you can control the
Four square,
depth
tunneling.
slightly more easily as compared
Upar,
to
tunneling, bas.
front on ESD.
Okay.
Soft पर खाली force
ठीक है. Okay. So I'm using a force coagulation current here, and I will be starting just distal to my markings. This is a very vascular area, as we all know. Even when you are doing arms or such a procedure, this is the most vascular area, and we will expect a lot of bleeding if things go wrong, and slowly we will be trying to expose the submucosa here. You can see, luckily so far we have no major vessel which is spurting. I am using the Herbe Viod 3.
So that's the advantage of the dual knife. It's a 1.5 millimeter
Indeed.
knife, which has a knob kind of tip towards the end. And with that, you can create a very nice and a very accurate mucosal incision. So there are no, you can see the mucosal incision. It's very straight, very linear. There are no irregular borders to it. And once that is achieved, Dr. Pankaj, I think he's going to go deep inside and start dissection in the
indeed.
retroflex manner.
Yeah, we'll just dissect a little here so that when we come from the proximal aspect, we know where we are. There is a little edge which is left here. We will just combine this, because these small things at the end of the procedure, when you are trying to complete the procedure, they will hamper you when the mucosa is not cut.
So Gaurav, if you allow, can I just switch on to the next room?
Okay.
Yeah, you can go and come back. This is going to take time.
Yes,
It's
sir.
not going to be very easy.
So I will go on to the next case. This is a 75-year-old female, again obstructive jaundice. On evaluation, she was suspected to have a lower end block, periampullary mass. The plan is for evaluation and biliary stenting. So we go on to OT1. Dr. Praveer, sir, you are back.
Yeah, very good afternoon. I would like to thank Dr. Puri for this wonderful opportunity. I think it's really a pleasure seeing so much of audience here. A very well organized conference by Dr. Puri. So 75 female, case of CA pancreas, we intend to place a metal biliary stent transpapillary. So I think what we are using is side wing scope. As you know, this is insertion of the side wing scope is a blind, semi-blind procedure. We go above the tongue, more of a feel. And then once you're in the esophagus, it's very important to do down on the up-down knob so that you can visualize the mucosa of the esophagus while you are traversing the esophagus. This helps you to see the, as you can see right now, with some insufflation and down on the up-down knob, it becomes similar to an upper GI scope. You can see the varices if they are present. So we are going gently down. And then once you have crossed the G junction, you need to do suction to ensure that there is no fluid or residue in the stomach. And then you can just go push in the scope, and we move towards the pylorus. As you can see right now, we are seeing the pylorus ahead. And then with a sunset sign, typical sunset sign, what you say, we need to enter into the duodenum. And then, as you can see, we have reached the second portion of the duodenum. And now I need to shorten the scope. So I have just pushed in a bit my scope. And then with lock and clockwise movement of the scope, I'm pulling back, and you can see a large bulge here. And this is lower down. You can see a large bulge at the level of ampulla. So we'll start with ultratome. And then we are passing this. We are using a Terimo wire here.
Praveer, is this unresectable?
Yes.
Okay.
Yes, it's unresectable. Okay.
Parveen, Nilay over here. This is an ampullary mass, right?
Yes.
So why do you want to put a metal stent? Because plastic would last as long as metal. In fact, probably more than metal in this scenario.
So can you have the fluoro, please? So can we just flip this image? Right, left. Yes, please. Can you just flip the fluoro image, please? Can someone do that? Yeah. Okay. So Dr. Nilay, see on imaging, what I was told that this is CA head of the pancreas, and that's the reason we intend to place a metal stent. Flip, please. Right, left. Okay.
So, Dr.
Yeah.
Till you are flipping,
no,
Jubin,
I'm
can
not.
you show my image?
Yeah.
Jubin, Dr. Vikas wants to convey the message. Yeah, Vikas want to tell the post-procedure instruction. Vikas is here.
Yes, that's good.
So
okay.
Once we have done the procedure, liquidite can be started same day, and patient can have mild chest pain. For that, analgesic can be given. And we should continue proton pump inhibitor maybe twice a day for a month. Then after that, we can do the check endoscopy and we can stop PPI. Then on-demand PPI can be given, and around 60 to 70% of patients, they can be maintained off PPI at around 1 year.
So thank you, Dr. Vikas, and nicely done procedure. And Pravir, are you ready or?
Yeah, no, we are ready. So what we have done is, so I'm tuned to.
Yeah, Jubin, we can go to Dr. Pravir Rai theater. Dr. Jubin? Can we go to Dr. Pravir Rai theater? Yeah, Pravir, you are online.
This to remove with the Visiglide wire, stiff wire. And we intend to do a cholangiogram first, do a small sphincterotomy, followed by placement of the metal stent. This is what the plan is. So Dr. Bhagwan is exchanging the wire. So as you can see right now, so we have the wire reaching up to the hilum and into one of the system in the left ductal system. We now intend to do a cholangiogram. Please. Yes. Yes. So we are expecting a dilated ductal system, which it is above. The CHD you can see is dilated. I'm pulling back the sphincterotome, and I need to ensure the site where the narrowing has started. So my stent has to be above it. As you can see now, this is the site length of the narrowing what we have, which tells us that possibly it's a compression from CA head of the pancreas. So now I intend to do a sphincterotomy.
Why do you want to do a sphincterotomy? Can't you place? Is there a risk of pancreatitis, or will there be risk of bleeding as well after cutting?
So I don't think normal sphincterotomy in a CA pancreas or a periampullary has got any increased risk. So we will do a sphincterotomy here. And this is because we intend to place a 10 millimeter stent, and we want to ensure that it moves, it goes in easily. So wire, please exchange. Yes. So small amount of bleed. So the good thing is once you intend to place a metal stent, the small amount of bleed that happens can very well be controlled with a metal stent. As you know, for bleed, post-sphincterotomy bleed, one of the very effective measure is placement of a metal stent. So this small amount of ooze, I'm not much concerned about it. So we are exchanging this. And now once we have done this exchange, what we are placing is a 6 centimeter uncovered metal stent. This is by Boston Scientific. So yeah, this is unresectable. And that's the reason we have chosen to place a uncovered metal stent. Even if it is resectable, the guidelines do suggest that you can use a fully covered short metal stent, which will obviously not interfere in the procedure, pancreatic or duodenectomy, which you intend to perform later on.
What do you mean by a short stent? 4 centimeters.
6 centimeters.
4 centimeters is not available here as in the West.
So 6 centimeter stent is the one that we intend to use. So as you can see, this is going in nicely, and we can see that on the fluoro as well. So this is a 6 centimeter stent that we have chosen to use. Yes. So now we will deploy the stent. Yes, please. So I need to ensure that this yellow mark is around, slowly, please. So I just need to ensure this yellow mark is around 1 centimeter. So this is the portion of the end of the stent. Please deploy. End of the stent, and 1 centimeter is good enough. If outside the papilla, that is good enough. So I think we can see the yellow mark. That's just wait. This is the yellow mark. You can see nicely. Yes, deploy, please. Please deploy. Deploy. Yes.
Thank you, Dr. Praveer, and thank you for the excellent case. A big applause to Dr. Praveer Rai. And we are going to the
Thank you,
ESD
Dr.
room. Dr. Jubin, we can shift to the ESD room.
Hi, are you with us? Hello?
Yes, you are with
Yeah,
us.
so now this is what we have done at in the retroflexion. We have put a big incision and done quite a dissection. You can see the muscle here. We are just above the muscle in the SM3 layer, right? And we have dissected, done hemostasis. And now what we are doing is we have come proximally, started our injection on the proximal aspect, and then we have started our dissection on the proximal side. Gaurav, while I am doing, you can please take the questions, Gaurav, and
So yes, I think now the plan is to go dissect via this pocket that Dr. Pankaj has created and try and connect the distal part of the mucosal incision to the proximal part. And that makes your life much easier. You don't overshoot, and you can have a more controlled dissection with the help of such method rather than a conventional EST in the esophagus.
what I am feeling is there is a lot of fibrosis in this area, Gaurav. What do you feel?
Yes, definitely, especially
Sukrit,
towards
Sukrit is also here, and Zahir, I think, is there. Zahir just left. Okay, because I am being helped by so many. This is not going to be easy. We are just trying to do it slowly. There is no hurry because you can't make a haste and make a problem here. So you have to be very careful. Inject, please.
Pankaj, you are making it
Assisted by Ashish and the anesthesia team, Dr. Suruchi. Loud. And trying to do as much hemostasis while dissecting as possible. And again, going towards the muscle rather than dissecting near the lesion. That is important. Yeah, this is very vascular area. As you can see here, now you are getting a good submucosa.
So as he will dissect deeper, he will go towards the gastric side, and there will be an area where you'll start seeing the previously dissected, the
That's right.
submucosa. And that will be the marker that you have crossed the lesion. And then you're sure at least some part of your scope has crossed the lesion, and then you'll connect the lateral parts of the lesion. I think maybe somewhere there is,
Yeah, we will just see that the two markers will meet here. This is the distal end and this is the proximal end here. So the advantage of doing the first incision distally is once you start dissecting from the proximal side, what will happen is this lesion will fall down, and once this falls down, it is very difficult to go below the lesion and again dissect it. So what we do is put a distal incision, start from proximally, and then make these two ends meet. That makes your life very easy.
So you first create a distal incision, then join the proximal to
Yeah,
distal
that is what we are doing. This is the
via tunnel, and then
Right.
create a bridge.
Yeah.
Based on the bridge, you
We are
then
really
dissect the
in it,
lateral
please.
parts of the bridge. And that's what Dr. Pankaj is doing. He's now cutting the
Needle.
lateral part because now he's sure that his scope will go across the lesion into the stomach.
This is only a small mucosal tank. Yeah, a lot of fibrosis in this area. Right now we have joined this area. So we'll just keep on releasing it from here now.
Pankaj, do you need some retraction at this moment now, or is it okay?
We can use retraction inject. But now luckily what has happened is the patient in a supine position, we have got the lesion which is hanging anteriorly. So by gravity, it is just falling down. So if the lesion is posterior, if we are not getting a good, we can definitely use a clip-in line traction. If required, we'll use it. But at this moment, I don't feel that it is required here. We are getting along well, I think. I don't hesitate in using if required. There is no dogmatism about it.
Sir, I will just switch on to the next case while
Yeah.
we'll come back to you, sir.
Sure.
So the next case that we have for you is a 38-year-old male with dysphagia for last 2 years. ECOG score is nice. You can see the endoscopic images. Manometry is this. It appears like a type 3 ecclesia with 10 centimeter spastic length. So the plan is for posterior poem. Dr. Zahir, sir, you are live for your case.
Hello, good evening, everybody. If the endoscopic screen is visible, you can see that this is a type 3 ecclesia. And although the picture looks more like a jackhammer esophagus, but if you carefully see that the IRP is high and distal latency is less than 4.5 seconds. So for those who are beginning to start a poem program at their center, want to manage esophageal motility disorder, it's very important to remember that the main difference between the 3 spastic esophageal motility disorder, that is type 3 ecclesia versus jackhammer esophagus and distal esophageal spasm. The main difference is involvement of gastroesophageal junction, or what you say lower esophageal sphincter. So type 3 ecclesia, lower esophageal sphincter is involved, and that's the reason that IRP is high. It's going to be at least more than 15, and distal latency is going to be less than 4.5 in all the 3 subtypes. In jackhammer and distal esophageal spasm, because LES, lower esophageal sphincter, is not involved, which means that it's not mandatory to do a LES myotomy. Now, if you see, this is the lower esophageal sphincter. This is at around 42 centimeter from incisors, and this is so tight that even a conical cap, with a conical cap, we are not able to negotiate beyond it. So definitely this patient has involvement of lower esophageal sphincter. You can nicely see the palisading vessels at near lower esophageal sphincter. So the other thing is how to calculate the length of myotomy, which is the most important aspect of doing poem in cases with spastic esophageal motility disorder. Now, in that regard, you have to use all the 3 parameters. You have to use your endoscopy skills and see if there are any spastic segments and till what extent spastic segments are reaching up to. And second is, of course, a time barium esophagogram, which is also going to give that hint. But the most important is esophageal manometry. You have to see the dark black band of high pressure zone in that manometry and see. So we have seen the manometry films, and in that manometry film, you could see that the high pressure zone is starting right from 25 to 30 centimeters. So we'll take a margin of error for at least 1 to 2 centimeters so that we don't miss any spastic segment. Otherwise, the patient will have residual symptoms in form of either dysphagia or chest pain. You can see the impression of spine here, which suggests that this is the posterior location. We come up till 25 centimeter, and here we are going to start our injection and subsequent incision. Now, telling you about the accessories that we are using. So we are using a Fuji-Scope 7000 Elixio series. This is their flagship series. This is the most high-end. It has LCI mode that you can see here, which is somewhat similar to the TXI mode. And this is the BLI mode. And if you are using a Fuji-Scope, this is a very good alternative to narrowband imaging. We are using a cap from Fuji as well, which is the best cap for beginners to start poem procedures, because this is a conical cap which makes your entry and subsequent negotiation through tight esophageal sphincter or tight spastic segments very easy. So coming back to the normal mode, this is the normal mode, and we are using hybrid knife. Hybrid knife is The reason we are using hybrid knife is it has excellent injection capacity. It has the injection and incision capacity both. My preference is I-type knife. There are 3 types of knife: the I-type, T-type, and O-type knife. So what we are using here is the hybrid I-type knife. And here we start. This is the injection. So this is the knife that you see here. What we do here is we choose the site of injection, which is at about 25 to 30 centimeter. We make a small nick here first. You see the nick here. And now here we inject. So see, a small touch, and this just with a press of a paddle, you can inject very beautifully using this knife. You can see the injection solution. If you want to inject more, you can inject more by just pressing it here. And this is going to provide you an excellent lift. So coming up, this is the lift that we have made, and we can start our incision right from the top. Yes, I always do when I'm using this knife, because I can see the entire length of my bulge. And
I thank the chairpersons and moderators for this session. I would now like to invite the next moderators and chairpersons. Dr. Shivam Kare, Dr. Saurav Patle, Dr. Vipin Mathur, and Dr. Umesh Jalial will be moderating. And chairpersons, Dr. Suraj Bhagat, Dr. Varun Mehta, Dr. Vinay K. Thorat, Dr. Charanpreet Grewal, and Dr. Manoj Kumar. I request the moderators and chairpersons to please come on stage. Thank you.
yes. So you can always extend the incision if you feel the incision is a little less. I don't mind making an extra few extra millimeters of incision, because this is ultimately the safety of the procedure is the paramount thing. So the best part is that we can inject any number of times. My assistant won't get this fatigue while he's holding the knife. The modes that we are using and the electrocautery that we are using, again, they mention special because this is what electrocautery I'm using is Vio 3, the most recent version of Arbi electrocautery, and we were using Vio 300D before, but now we have switched to Vio 3. Vio 3 is like shifting from iPhone 5 to iPhone 15 or 14 Pro Max. So this is a huge difference between these two electrocauteries, and you should always remember that this is a modification which has come after almost a decade. Like we were using Vio 300.
Plane of dissection, you made it horizontal or vertical?
So as of now, it's still horizontal, and if I rotate it like this, it becomes.
What you prefer?
So I change according to my level of comfort.
If you want horizontal poem, you can go.
You can go like as long as you can visualize muscle well, you know where is your muscle, where is your mucosa. You can always change the
horizontally you have to use a small wheel, and the vertical you have to use a big wheel.
Yes. So I often do it like this, vertical, because I can see I can reach my scope, make my scope reach up, withdraw the scope, and then from here keep on cutting and come like this. So it's a matter of convenience, I think. If you are convenient, the way you have started doing your procedures, the way you have learned, the way you have mastered the procedure, either it's horizontal or it's either way you can do it. So I don't think it's a matter of problem that if you are doing vertical or if you are doing horizontal. I can do it horizontally as well, where I can move my. But always remember that the movement that you can do with big wheel is much more than the movement that you can do with small wheel. So that is one of the reasons that sometimes I make it vertical. See, the movement of now I'm using only big wheel. The range of small wheel is much less. So that's why. So I was talking about the mode that I'm using.
So Dr. Jahir.
Yes.
Dr. Jahir.
Yes, please.
We are shifting to the other room. I request Dr. Jubin to go for the pancreatic laser lithotripsy. We'll come back to you soon, Jahir.
Okay, thank you.
Dr. Jubin?
Yes, sir. So the next case is a 31-year-old male who is a case of chronic calcific pancreatitis, and the MRCP shows a dilated MPD with a large stone in the distal body. He underwent ESWL. This is the MR image. The plan is to do a pancreatoscopy and a laser lithotripsy and to clear the PD of the stone. So over in OT2 for pancreatic lithotripsy.
So Marty, we're online, right? So we're getting a snare, right?
Yeah, sorry, I thought we had that.
Yeah.
There?
Yeah, he's getting it.
Great.
So you want to talk your steps, Marty? Like, so what
Okay,
are,
are we live?
yeah, we're live now.
Okay, so patient with chronic pancreatitis, currently dilated duct with a stone remnant in the tail. And Dr. Corey has done this.
I got it. Get everything ready.
All I'm going to do is remove the stent, sweep the duct, but I'm going to avoid contrast too much because it makes it hard to see with a spyglass. And then I'm going to, let go. Okay, right there. So I'm going to clean out that pus with a wire, a balloon, and avoid contrast other than minimal contrast so that the spyglass does best with clear fluid, not
It's a long wire, Mark.
contrast. Yeah, that's fine. You can,
Yeah, sure. Yeah.
text. I usually do physician controlled wire for everything. This is fine. Okay, you want to flush?
Yep.
And the reason to inject will be to see a little bit. I'm just going to turn towards pancreatic direction. I usually do double sphincterotomies for these, just so that we can separate. Okay, can you inject there?
Yep.
Okay. Pull the wire back. Boy, that's big.
Big duct, right?
Yeah, big duct. Okay, good. All right, let's save that. And then let's put a wire in and we'll sweep the contrast out. Okay. And this is an angled wire.
It's an angled
Yeah.
long wire, yeah.
Yeah, I like the angled wire, the straight. Okay, let's exchange.
Okay.
The angled wire avoids perforating side branches.
We have the fluoro machine, please. Can we have the fluoro image, please?
Okay, I've got it locked. So you see the stone out
Okay,
there.
you have, I don't have the wire, so you'll have to lock it.
Yeah,
Okay,
right. So
You have it locked?
There's a pretty good sized stone. I've got it locked as it'll be.
yeah, okay.
Okay, you going?
Yeah, I don't have the wire, so it's all yours.
Oh, you don't?
Yeah, it's a short wire.
All right.
Balloon?
Yeah, there's the stone. And this, I just freehand cannulate with the spy scope, but I'll show you that now.
Do you want to sweep with the balloon, Marty?
Sweep quickly with the balloon, and then we're gonna load up the spy, which I have the EHL probe preloaded in, because if you get a spy scope all the way up to the target stone, you can have very difficult time passing the electrohydraulic lithotripsy probe up, and then you waste all that time. So what I do is preload the EHL probe once I know that I can reach my target, and that way I'm ready to go. It's like, I'm not a hunter, but
We
it's
have
if
the contrast.
were to hunt and you had your rifle all set, and then you saw your target and yet you didn't have, okay, pull me in.
Yep.
And then if you didn't have ammunition and you had to reload, is what happens. Okay, balloon up.
Martin, would you do a sphincteroplasty in this patient?
I think I would, except, I mean, generally it's a good idea, but this is so wide open. I don't think we need to.
Back up one more.
Yeah, there we go. Balloon up.
Balloons
Okay,
up,
but you're
yep.
advancing wire.
Yep,
And I'm doing this just to clear out.
pieces go.
Yeah, see, there comes some small stones, because we don't need EHL for those. Okay, I want to show you a power move to get a bolt balloon pulled through. And I'm going to show you a case tomorrow in my complications talk where a very experienced endoscopist perforated the duodenum by pulling the scope back for stones rather than this. Pull close, hold the scope in your left hand, the balloon in your left hand, twist and push in. And that way you push the scope in. Then instead of the scope going through the back wall, see, that's wide open. I don't need to dilate that. Okay, let's exchange.
See,
Actually, I think I'm ready for the spy.
so you don't, okay.
I'm ready for the spy scope. So let's hook up the spy scope and then I'll show you my favorite device here. I can't see the video, but tricks. I put little lube on the spy scope. Is there lube on that? Jelly?
Jelly.
Yes.
So Professor, till you are preparing yourself, we go to the room number 1 with the ESD esophageal.
Yeah, well, let me know. I'll put the spy scope in and then you let me know when you're ready. I'll wait to do the electrohydraulic lift.
Okay, let you start with the spy scope and then.
Rajesh, Dr. Umesh Alial here. Rajesh, can you hear?
Yeah, we can hear you.
Can we just get a little more clarity on what we are trying to do for this patient? I think what we heard was this patient is a case of CCP, undergone ESWL. I think you are trying to achieve PD clearance, right?
Okay.
Yes.
Okay, we are planning to use laser lithotripsy.
No,
The reason is that patient underwent ESWL twice. There is a single stone in the tail which has not break. Patient has a recurrent pain. As there was a single stone, we thought let's try with the EHL.
Look,
Okay.
The stone in the head was cleared. There's a single stone in
Okay.
the tail of the pancreas and 2 sessions of the ESWL done.
Yeah.
And you see there is no space to remove
Rajesh,
the balloon or.
Rajesh, I have one question. Suppose you don't have ESWL, laser lithotripsy. Can you just leave this stone or because if you see it's in the tail and there is no duct after that stone.
Dr. Nilay, absolutely right, but the patient has a recurrent pain in the left hypochondrium.
Okay.
And that was the reason this patient underwent ESWL and the failure of ESWL.
They need
irrigation.
Bring into the
irrigation. Is it connected? Can I have the water pump?
Okay, so we need to flush it first.
Yeah. Or I can just give you saline syringe. Saline, is there saline?
But it's easier with their
Yeah,
power.
but while he's doing it, I'll just flush it.
Because this will put air, we don't want air in there.
Yeah.
So Dr. Rajiv, can we go to other
We'll take
room?
this one. We'll take this one.
I'm gonna have to tell him I don't. we
No,
don't
this
want
is connected
the
here.
cell anymore.
So Dr. Jubi,
There is your
till
water pump.
Martin Freeman is ready with the EHL. We go to the room number 4 with the ESD esophageal.
Muddy, I'll have to give you mechanical.
We are back with the ESD, sir.
Yeah, are we on? See, can you see it? We have done an almost circumferential dissection here. Now what we are doing is just showing you, just deflate the stomach a little so that the patient becomes a little comfortable. We are using CO2, so it's not a problem, but we don't like the ET CO2 to shoot up too much, even if it is not in a tunnel. So I'm just sucking out. Gaurav, can you make some comments?
Dr. Pankaj?
Yes.
Varun here.
Yeah, Varun.
Dr. Pankaj, the most difficult step in this particular situation would be to remove that mucosal flap which is hanging. Any particular tips for that?
Yeah, we can either use a snare or we can use a IT knife for that at the end.
Wasn't it a good idea that if you had created the tunnel and not cut both the sides and you would have gone from proximal to distal into the stomach and then cut both the sides?
This was, see, Nilay, this is not a very huge lesion. It's a small lesion, and therefore
This is because then you could have prevented this hanging thing.
Yeah, no, it is okay. But that was practically what we did was dissected from both the sides, and it was a sort of short tunnel that we created actually. And then I released on the right side, and then now on the left side. Now this is a small area, but I think we will remove it.
Yes,
we are
yes.
just trying to get our orientation back because some inject, please. Yeah.
because sometimes what happens is when you are trying to show things, you lose the orientation. So it's very imperative that you get your bearings back and inject a little. A little overshooting is not a problem, but little. And when you know it's only the mucosa, I think we can just use a IT knife and get it. Even with this, I think we are going to do it. Probably we'll finish it off with this knife itself.
So I think Jahir is ready at the G junction, very tight G junction. So we are going to that room for 5 minutes. Jubin, can you shift to the Jahir room?
Yes, sir. We are shifting to the poem case.
Jahir, you are online.
For whenever they're ready, we're ready.
Okay, do you want to go live?
Flush,
yeah, flushing.
Okay, who's standing?
I'm sitting on you.
Dr.
You're
Jubin,
standing on
Yeah,
top.
do you want to take it?
I think we are in a different room. Dr. Jubin? Yeah.
Now we are on Dr. Jair.
Yeah. So just to show you what we have done till now, this is what you see. Is I think we are very close to G junction, or we are at G junction. It's very tight because during endoscopy we could not cross it. We didn't force it too much. The reason being the mucosal aberrations which appear due to like forceful cross of scope across the junction is not that something which I require, because it may lead to full thickness mucosal injury as well. So this is aberrant longitudinal that appears in say 70% of cases around near G junction. So this is the tunnel all that we have done.
Very long.
We are making a long tunnel. The reason being it's a type 3 eclasia, and we have to see that all the spastic segments are included. So this is the G junction that we guess that this is probably the G junction. We are injecting again and again, and this is the most crucial part, because if the G junction is spared, then this is something that is not warranted in cases where G junction is involved. So we have seen one marker as of now, which suggests that we are at we are close to G junction, which is the aberrant longitudinal, and this is also used as a guide that probably we are somewhere near to G junction. You can see that I have shifted to spray coax just to speed up my procedure. I was using precise sec. Now there is a significant difference between these two modes regarding the volts, the duty cycle, and everything. For example, spray coax is probably the current with highest volts. It's around 3000 to 4000 volts. In contrast, precise sec, that is now becoming a favored mode for ESB as well as poem procedure. It's a smart mode basically. So the current curves will change according to the tissue impedance. For example, if the tissue impedance is high, the current curve will become such that it effectively dissects the tissue. So it's a smart AI-based mode, and it's also said to be quite useful for coagulation or hemostasis. So this is in contrast, this is a spray mode. You have to be very cautious if you are using spray mode, because this is the mode which is used by endoscopists, and which has the highest power among all the modes, among all the coax modes. For example, force coax, swift coax. If you compare these three modes, force, spray, and swift, this is the mode which has the max coagulation power, the max voltages.
So Jahir, we are coming back to you in 2 minutes. Dr. Martin Freeman is ready.
Sure.
Focus on the pancreatic stone. So you can wait for 5 minutes. We are coming back.
Sure.
So we are going to Martin Freeman, where he's ready with the laser fiber of the pancreatic stone.
OT2.
Live?
Just coming. Let me know when we're live.
Somebody you live.
Okay.
Dr. Freeman, you are online.
All right. So we had a perfect view of the stone, and of course, okay, there we go. Hit power.
That's you.
Blast. Okay, you do it. Or
Oh, here, play. You're good. Got it.
Okay,
That's
there we
yours.
go. Okay, so we're doing maximum power, aspirate, suction.
Yep.
Irrigate.
Yep.
Stand on the irrigation, and we're doing maximum power, and we just keep going till it's broken up. And the main thing with electrohydraulic lithotripsy is stay off the wall. As long as you don't hit the wall, it's very safe. And even if you do, it just bleeds. It doesn't perforate. I prefer it to laser, except for the most difficult stones. My magic scope holder here lets me do no hands. Okay, power.
Power
Okay,
zone.
all right. I'm doing it.
Sure.
Okay, and you're irrigating.
I'm irrigating and
So
sectioning it.
we're just going to break this up, and then this is, by the way, why we don't bother with S-wall anymore, unless it's a really difficult to reach or refractory stone, because you can clear the entire duct in one session with, and you can go up a chain of stones, which you can't, at least our S-wall people can't do. They kind of target one stone. Okay, keep going.
Yep, it's on. So Marty, quick question. So the guidelines or the recommendations by the manufacturer are that you should start with a lower power and lower pulse, and then ramp up.
It depends how much time you got, how much time you want to spend. When you get really great visualization like this, okay, I'm just blasting.
Yep.
Then I'd use maximum power. It's because otherwise it just takes longer. As long as you have a good central visualization like this. And then once this is broken up into pieces, we're going to get all the pieces out, which I think we're almost done with fragmentation here. And then we can get all these out with a basket and a balloon. We keep irrigating?
Yep.
And I'm going to pull back a
I
little.
see you also like place a stent parallel to this sometimes.
Well, yeah, if it's not a wide open egress, I put a 3 French stent as a guide and as also a vent, because even with chronic pancreatitis, you can, especially with laser, you can cause pancreatitis. We've done 55 patients by EHL now, Guru Trikanathan and my partner and me, and the only pancreatises we've caused have been lasered. I think it's, so that's my bias, is to use EHL. I just think it's easier and safer. Can't quite hear if they're talking. So I think we're almost done with this, and then we'll get the fragments out with balloon and basket. But
So thank you, Professor, and thank you for the nice demonstration.
Good.
And I think Pankaj is
Yes, we'll just go
completely
to
ready.
we'll just go to OT4 once.
They're doing EST now. Okay, good. Do you want to present more or no?
No, I think we're good. I think we'll get these out.
Pankaj, you are online.
Have completed our dissection, and I will just show you what we have achieved. This is the lesion which I am seeing in retroflexion. This is the end result. We have the mucosa, only the SM3 layer is just remaining, so that we have not disturbed any muscle or not done any dissection on the muscle. This is the lesion which I can show you here. This is not a small lesion. It's almost a circumferential, almost 3 centimeters width, and a circumferential lesion which we have dissected out. And in forward wing, you can see all this vessels which are in the deep submucosa. These are the palisade vessels at the G junction, and this is the muscle architecture which is intact. So it's almost a 3 to 4 centimeter lesion here, and we have completed our job. Now what we would just like to do is remove this specimen. We can either use a snare, and I'll just try to suck out the lesion.
Pankaj, what are the chances of stricture? This is
there will be a stricture. There will be a stricture.
Are you going to put steroids right now, or you are just
there is a possibility that we can inject a little Canacot in this submucosa, loose submucosa, and that is shown to have some beneficial effect for the stricture. But otherwise, it will require 3 to 4 dilatations probably, and the patient should be all right. As such, the patient has a reflux, and probably this would additionally mean it would help the patient, because this is almost like an ARMA which has been performed. Nilay.
Pankaj,
Yes.
Umesh here.
Yeah,
I think when you started, I think carcinoma in situ, I think a nodular lesion was there at 11, 12 o'clock position.
Yeah.
And at 3 o'clock, it was more like inflammatory. But I
That's
think
right.
you ended up doing a nice circumferential resection. As it's been pointed out, this patient is likely to develop a stricture. When do you expect the likely timing of the stricture?
4 to 6 weeks. 4 to 6 weeks. Once everything has healed, probably we'll have a look after 6 weeks. That is what we would follow.
Dr.
I don't think
Pankaj,
there is any vessel which is remaining, so I don't need to coagulate unnecessarily to cause some secondary coagulation, necrosis, and delayed perforation. So we
thank you,
just
Dr.
observe the
Pankaj.
patient. Yeah.
Thank you. Any questions to Dr.
Dr. Pankaj, I am Dr. Charanpreet. I would like to ask, in such a lesion which is at the G junction, what are the other strategies to, could you do some kind of ablation before?
When it is malignancy, no. When it is high-grade dysplasia, I don't think ablation is the answer. We always tend to resect them, and this would probably be a diagnostic resection. If it comes out to be adenocarcinoma at some place, then probably
So you'll want to first check
please.
with 2 pathologists at least to make sure this is not adenocarcinoma. And if it is adenocarcinoma, you'll want to see whether it's invaded the submucosa, or it is purely intramucosal. In the latter case, if it is intramucosal adenocarcinoma, I think this is enough for this patient. The patient goes on a lifelong surveillance. However, if this is a submucosal invasive tumor, then you would consider additional therapy along with the one which we did today.
So thank you, Gaurav. Thank you.
I have one small question. Do you plan a relook endoscopy routinely or just wait for the symptoms or anything else?
No, we will do a relook after 6 weeks.
So thank you. And we go to Dr. Lamba, where he's ready with the obese patient to put the balloon. I request Dr. Jubindev Sharma to present the history.
Yes, so this case is 16-year-old Maine young boy who is morbidly obese, previously had a Sparks balloon, and his BMI improved from 43 to 38. He doesn't want to undergo any irreversible surgery. So the plan is to redo a Sparks balloon for him. So over to OT1 for that.
Hello, everybody. Am I audible? Dr. Puri, are we live?
Yes, Dr. Lamba, you are audible.
Okay.
We can see
As
you.
you've heard the history, this is a young male who had a Sparks balloon previously in, and he lost some weight, and now he's going again for a balloon implantation. So what we have chosen today is the Sparks 3 balloon. As for those who are not familiar with this balloon, this is a adjustable kind of balloon. It's a fluid-filled balloon, and it's an adjustable balloon. Adjustable means that you can change the volume, and the fundamental behind it is that after a certain time, when the weight loss plateaus, then you add another volume to the balloon so that the further weight loss occurs. And initially, there is the tolerance is better if the balloon low volume is injected. So this pass balloon, for people who are not familiar with it, it has got various parts. We have this balloon with this flexible, catheter with it. It comes locked in these, there's a locking mechanism when it is fresh. We have opened it. And then we have this connecting cap, which we will show how to use it later on. Then we have this very interesting thing, which is known as introduction facilitator. This helps us to put the balloon in. We have the connecting cannula. And then we have this 500 ml of saline, and we have mixed a little bit of methylene blue in it. And this methylene blue is basically injected that's if in under event when the balloon ruptures spontaneously, then patient will come to know probably that balloon has ruptured if he passes some bluish green urine. So the most important thing now is to how to fix this assembly to the scope, and there are various steps in it. And I have with me Mr. Bhagwan, who's a very excellent technician, and he'll now show you how to fix up this Sparks balloon onto the scope. So once you have opened the seal, the next step is to put in this facilitator. And if you can see, Bhagwan, will you hold this here? You have to just put it here and then roll it like this. Okay. Just roll it on the scope, and then on the left side of this, you have to introduce this balloon. Yeah. हाँ, बंद कर दीजिए। So what we are doing is we are fixing this facilitator onto the scope.
Dr. Lamba, Dr. Varun here.
Yeah, Varun.
Would you intubate this patient to facilitate your entry, or would you do
Generally,
conscious
intubation is not
sedation?
required. Most of the time, we do it in slightly deep sedation or at the most propofol. Intubation generally is not required because these balloons are pretty smooth and they, there's a very easy passage to them. So intubation is avoided. But yes, if there's a very apprehensive patient, you can always intubate. Okay. So once we have now fixed this balloon onto the scope, the next step is to connect it to the connecting cannula. And jelly, please. And we have to lubricate it well. And this will help in introduction of this into. Oh, इसको tight कर दे, थोड़ा और नीचे कर दे.
Dr. Lamba, he is a young patient, and what kind of investigations would you like to do before?
He's already attending the bariatric clinic of Medicity, Vedanta Hospital, and he's been worked up for various hormonal disorders. He has been worked up for that, but he does not seem to have any hormonal disorders. He does not have any. I was looking. His hemoglobin A1C is normal. He doesn't have diabetes. So there are no other comorbidities. But he is definitely quite obese with a BMI now of, I think, about 36, 37. He has the BMI. So otherwise, in a routine patient, you have to, yes, pre-procedure assessment for all kinds of hormonal disorders, comorbidities like diabetes, lipid profile, all thyroid, all these things need to be done.
And will you screen for liver disease as well?
Yes, definitely. Definitely. We've already done a screening endoscopy also, which is a very important step. And this is one thing I think is very necessary according to me. And we now have balloons which are implanted without the requirement of endoscopy. But I think a pre-endoscopy is a must because many times, we have been taken for surprise when we found varices or some other contraindications like a leiomyoma, sometimes gastric varices. These things, they take you, sorry, these are contraindications when you should not be putting balloon. So you should always do a screening endoscopy before you start the procedure, which you've already done.
Dr. Lamba, this patient already had a balloon previously.
Yeah.
So why are we again going for a balloon? Why not some other endoscopic or any other?
This is actually more on the patient's choice because he doesn't want to go for any surgical procedure or any other endoscopic intervention. So he was pretty happy with the balloon and he's lost weight also. His BMI has come down and he wants the reimplantation.
And we offer them the option of surgery as well as ESG. The family is not willing, says that 16-year-old boy, he has lost, I think, 16 kg of the weight. And just for the maintenance of the weight loss, we are again putting the balloon.
So I think now you see very easily the balloon because of this introducer has gone inside the stomach. And now Dr. Monica has just retroverted it. This is a very important step which she is demonstrating because we have to be very sure that the balloon, the whole of the balloon is inside the stomach and none of it is above the GE junction. So as you can see in this retroverted view, the whole of the balloon is inside and the connecting cannula is, inside the esophagus.
So Dr. Lamba, till you are filling the balloon, we will come back once you completely inflate.
Yes,
and we are going to Jahi room where he is ready with the myotomy.
Okay. So we are now inflating the balloon. Yeah. We are now inflating the balloon.
Dr. Jubin? Dr. Jahir room, we can go.
Yes, we are shifting to Dr. Zahid, sir.
Hi, so this is the end of the tunnel, and this is an important question which is often asked, that how do you determine that when to stop? So can you see these two penetrating vessels? This is called the two penetrating vessel sign, one vessel on the top of the other. Now these penetrating vessels, I can see Rakesh smiling. Hi, Dr. Rakesh. So if you see here, this vessel is constant in 99% of the cases. If you can excavate this vessel out, you can see that towards the left of this vessel are sling fibers, and towards the right are circular or class fibers. Can you make this distinction? And this is perfectly bounded by this penetrating vessel. These are called the first penetrating vessel and the second penetrating vessel. When you reach this vessel, this is the end point. That means that you have crossed into the G junction at least 2 to 3 centimeters. So many authors say that if you preserve sling fibers, it will reduce GERD. I found quite the opposite result. We did not find a reduction in GERD, whether you preserve these sling fibers or you don't. Sling fibers, theoretically, yes, they have a natural anti-reflex function, but the problem is these sling fibers cross from left to right, right? And so as we go down, if I make a longer tunnel, as I go down, these sling fibers are going to cross from left to right. So if you are doing a 3 to 4 centimeter long gastric myotomy, whatever you do, the incidence of reflux is not going to come down. So if you want to prevent reflux, you have to do a short myotomy in addition to preservation of sling fibers. If you are doing a standard gastric myotomy, which is around 3.5 centimeter, your incidence of GERD is not going to come down. So just to show you that this is the G junction, and still you can see that I'm finding it a bit tough. I'm worried I have not applied a tape over the cap. This is we are coming up, and you can also see the spindle vessels, which is again a marker of gastric.
Widening we are not able to see.
Jair, just one question. Are you planning any anti-reflex procedure for this?
No. So the only anti-reflux procedure that we are going to do is not extending the gastric myotomy beyond 2.5 centimeters. If we extend the gastric myotomy beyond that side, I think that's the most robust way to prevent reflux as of now. There is no other robust technique to prevent reflux after POEM. There have been series, case series, retrospective reviews, prospective series, but no conclusive evidence that there is a definite way to prevent reflux after POEM. So what we are doing as of now is we are doing a short myotomy in addition to preserving the sling fibers. So just to show you, this is all what we have done. This is our site of incision. I go to a centimeter below it, suck some fluid, and now we start our myotomy.
Dr. Jahir, you are bound to be done a long myotomy in this case.
Yes.
After long myotomy, we are getting some incidence of BOM. So what is your take of how we can prevent this blowout myotomy, which we are more recognizing these days?
Yes. So I think blown out myotomy has been blown out of the proportion. There is, if you prospectively see your cases, to some or the greater extent, you'll find that bomb or blown out myotomy is a very frequent feature. Now, is blown out myotomy worrisome in case the gastric myotomy is inadequate? It's less than 1.5 centimeter. Definitely, it's going to be a problem. But in case your gastric myotomy is adequate and the patient is not symptomatic, bomb does not require any additional treatment. So bomb, because it's a new term, right? So it's very frequently talked about now in forums, in groups, that this patient has bomb, what to do. Nothing to do if the patient is asymptomatic.
What about symptomatic patient?
Symptomatic patient, you see the stasis, you see, and usually it happens if your myotomy or your POEM is little more lateral as compared to the standard 2 o'clock or 5 o'clock position. The lateral wall of the esophageal wall is supposed to be the weakest wall, and so the mucosa tends to pop out. I will just clear the knife. The mucosa tends to pop out from that. So if you see majority of the cases with bomb, you have a lateral pouch that you see at the lower end of the esophagus. Now, some of these are due to a hypertrophic muscle at near LES or at LES. So if that is the case, you can always reduce the pressure, the front pressure, the pressure below that outpouching of mucosa, and that will help if the patient is really symptomatic. But I have seen majority of the patients with adequately done gastric myotomy, even if they have bomb, they are asymptomatic. So those cases, we don't do anything. If there is a significant stresses along with symptoms, then we plan whether to do a short myotomy with extension at least 2 to 3 centimeter across the junction. Otherwise, nothing.
Now you're doing partial. Now you start doing full thickness.
So I'm because it's a long myotomy, and what I'm going to do is preserve the longitudinal muscle. There is no science behind it. I just don't want to see the mediastinal strictures straight away.
Vegas. Sometimes you see Vegas.
So I try to identify if I'm seeing a Vegas or not, and I don't know whether touching or like burning it will definitely show you some twitching or this activation of different muscles. But I have never tried to like poke and see vagus nerve from the vagus nerve is quite deep. It's the most superficial, close to G junction, and unfortunately or fortunately, I never tried to see where is the vagus.
Dr. Zahid, have you seen incidence of Boerhaave syndrome in especially post-myotomy where the lateral wall is weak?
Yet to see. I think I haven't seen so far.
Dr. Jahir,
yes.
till you are completing myotomy, we are going to the balloon last part. And Dr. Jubin, we can go to the SPADS balloon. Dr. Monica and Dr. Lamba is waiting.
Yes, we are going to the OT1, sir.
So in the meantime, we have filled around 700 ml of fluid in this balloon. Now you can see the fully inflated balloon inside the fundus of stomach. The important part here, when we take out the scope, we need to suck it out the air, and we have to hold this catheter. We keep the scope inside the esophagus and take out the catheter. This last step is very important.
I think you can focus here.
Focus here.
Yeah, as you can see, this is the connecting cannula, which we now have to remove. Always remember that this balloon connecting catheter is very slippery. It's full of saliva. You have to hold it very carefully. Bhagwan, can you just focus on the...
Dr. Lamba, please? Can you take the hand figure? We remove the endoscopic view, come to the hand view. Yes.
So now we will disconnect this, and then we will put this cap, which we had in our kit. This has got this loop so that later on the manipulations and pulling out can be easy. So we will be connecting this to this, and this cap should be very secure and tightly fitted onto this. So once it has been done, then we hold this cap with the loop, and gradually, because there's a lot of recoil there, gradually we push it down the pharynx of the patient and then release it, right? And then obviously we need to recheck and push the cap inside the stomach if it's still in the esophagus. So I think this essentially completes the procedure. What we need to now do is just push the cap inside the stomach, and the procedure is almost done.
Endo view?
Yeah.
Dr. Lamba, most of the patients would have vomitings after that, maybe 3 to 4 days.
Yes.
Maybe 7 days. What do you advise for those patients?
We generally, first of all, is counseling of the patient. He needs to be told pre-hand. You know, patients who have been pre-hand, you have counseled them that they will have some vomiting, nausea, they tolerate it well. Otherwise, for all patients, we start PPIs and antiemetics about 48 hours before the procedure. And continue them for pretty long.
Dr. Lamba, just a question. Is it wiser to inject first 500 ml and then upgrade it to 700 ml just to improve the tolerance?
Yeah. That is definitely the usual story. We inject about 400 to 500 in the first go and then upgrade. This patient, particularly because he had a SPARTS implanted before and his tolerability was very good. So Dr. Puri requested us to put slightly greater volume because he already had a balloon inside and he was tolerating it well.
So you're going to keep it for 1 year?
Yeah. Now the plan is to keep it for 1 year and then follow him up.
Yeah. May not be in this patient. In adult patients, just want to ask you, what is your protocol? Do you give, in addition to the balloon placement, GLP analogs?
Yes, the
And
pharmacotherapy.
timing, if so.
Not to every patient. This is not recommended that we should be given. In fact, most of them have probably tried pharmacotherapy with not much benefit. Only then they come for endoscopic therapy. But as far as routine medication is concerned, PPIs we continue till the time balloon is in, because they have shown to actually reduce the incidence of erosions and ulcers which may occur because of friction. So those are continued. Antiemetics for first 2-3 weeks, yes, and then once the patient tolerates, then we stop the antiemetics.
There should be
Dr.
no
Lamba.
hiatus hernia in the patient. Hiatus hernia should always be ruled out before putting a balloon, because the balloon can come in esophagus and can cause catastrophe.
Dr. Lamba, Dr. Thorat here. If there is no weight loss in this patient after 3 months,
Dr.
what are you
Lamba.
going to do?
Thank you, Dr. Lamba.
Okay.
Are you going to remove?
Yeah, it was an excellent demonstration, Dr. Lamba, Dr.
Thank you,
Monica.
Dr. Lamba.
Okay.
And we go
Thank
to
you.
Jahir rooms now for the
Thank you.
poem procedure.
Hi, welcome everybody. So I have with me Dr. Kapil and Dr. Vikas, who are who are better than me in poem procedures, and they are guiding me throughout the procedure.
Good
job.
Dr. Zahir, you are using a hybrid knife.
Yes.
Any change in the cartridge settings if you are using another knife, for example, a TTJ?
Yes, definitely. And this is in fact a very important.
So for the beginners, we need to tell that.
So if I'm using a TT, for example, this I'm using Bio 3. Bio 3, the system settings are entirely different. So Bio 3, the settings are precise set 5.5 for tunneling and initial part of myotomy. The endocut setting for mucosal incision or for myotomy remain the same. That is affect duration and interval of 2, 3, and 3. If I'm using a triangular tip knife, I'm going to keep a setting of 4, 5 in precise set mode. In fact, that is the setting also recommended by the company. Now let's talk about 300D. If I'm using 300D, the settings are again different for hybrid I-type knife, hybrid D-type knife, and triangular tip knife. So the settings always need to be interpreted in terms of the device or accessory that you are using. It's very important and very valid question that you ask.
Jackie, the patient has quite thick muscle. Is it unique to type 3 or in type 1 and 2 you can also see this thick muscle?
You can see in type 1 and 2 as well, but I think if the proportion of patients with these spastic motility disorders, they have the chances of this muscle being thick are higher. But I think still we cannot differentiate these disorders based on the muscle thickness. These type of thick muscles we have seen in type 1 and 2 achalasia as well, but less common in type 1 because that is usually a big bag, big atonic bag. So the muscle is usually, not invariably, but usually not as thick as we see here.
Hey,
And
Michelle, can you hear us? Michelle, can you hear us?
Dr. Zahir, when we are doing a myotomy, most
Michelle,
of the
can
time
you hear
the
us?
knife has a tendency to swing towards the mucosa and possibly cause some mucosal
Michelle,
injury
can you hear
because
us?
once you're coming from the muscle, how do you prevent that? What are the tips for that?
So that's the reason the world shifted towards posterior poem, because you see the accessory is coming right from 6 to 7 o'clock position. If the accessory is coming out from this position, the chances of flinging towards the mucosa are lower. They are not absent but lower.
Hey, Michelle.
The second is as I move towards up, as I move towards up, I slow down and I draw the knife.
Hey, Michelle.
That's one technique. But if you are doing an anterior poem, the chances are much higher as compared to posterior poem. Because during anterior poem, you see, you have to completely put your big wheel down and then reach the anterior surface. So from here, your scope is in a strained position. The moment you release wheel, it comes and hit down here. The moment you release wheel, the knife tends to hit down at the mucosa level. But this is less so of a problem when you are doing posterior poem.
Jahir, other issue is the length of myotomy. In type 3 achalasia, how do you decide the upper extent of myotomy?
So I always go through the manometry film, not the report. The film, I see where is the black segment extending. The black portion of that film is the most high pressure zones. So if it is in this patient, for example, it was extending till 25 centimeters. So we decided that we have to do a myotomy which is at least 15 to 16 centimeter in length.
But sometimes on film you don't have mark of centimeter. Then you have to go to real-time manometry,
Yes.
and then you have to see.
Yes, it's very important, very important. In fact, the entire logic of doing poem in
Hey,
type
can you confirm you're able to hear me,
that
please?
you are able to
I'm
do
speaking
long
to the
myotomies,
microphone.
which are essential. And if you are not able to
Hey, Chris, good morning.
give the length of myotomy, I think that's not. Having said that, if you ask me what is the evidence, if you
Vishal
don't
and Chris, are you able to hear me?
do long myotomies in type 3 achalasia, I think
Perfect. All right.
we-
They're wrapping up this
nobody's going
session and
to-
I'll call you again.
Nobody is going to do that trial by doing a short myotomy versus long myotomy in type 3.
Dr. Zahir, what's your experience regarding the sling fiber versus clasp fiber myotomy regarding the reflux?
So my experience was, unfortunately, there was no difference. And this is what happens when you do a randomized trial. I always believed in preserving sling fibers. And our trial showed quite the contrary results. And then the reason why there were contradictory results to what was expected is that the length of gastric myotomy has to be restricted. If you don't restrict the length of gastric myotomy, you are ultimately going to injure the sling fibers, because the sling fibers cross from the left to the right at somewhere around 4 centimeters below the junction. So if you want to really use preservation of sling fibers for prevention of GERD, you have to do a short gastric myotomy also.
You almost preserve the longitudinal fiber.
Yes, sir. So in the beginning, there is no science behind it. If I don't preserve it, what will happen? Nothing will happen, because the role of longitudinal muscle fiber
insufflation related will be much lower.
Yeah. And moreover, I don't get to see anything beating the other side. Because that makes your heart beat faster than the patient's own heart. So this is a mixture of what I am using right now is a mixture of both the cutting current as well as the coagulation current. What I do is, to start with, I use the coagulation current. So it takes care of all the vessels which are going to be there at the junction of longitudinal and circular muscle fibers, where majority of the vessels lie. And then ultimately I cut so that the charring is reduced. I again come to the junction of this fibers. You see, it's a long myotomy, so we are taking our time, because ultimate aim is that the patient should get relief. So fiber by fiber we are dissecting, and very soon we are seeing that the G junction is very close now, and after a couple of centimeters we'll be doing full thickness myotomy.
Most of the time, this circular muscle fiber is spastic. Have you ever seen the longitudinal spastic muscle creating the shortening of the esophagus?
I have seen thicker longitudinal fibers as well. I think longitudinal muscle fibers do have some role which we don't know as of now. They have a role if they contract, they lead to shortening of the esophagus, which has been linked to chest pain in the patients with gastroesophageal reflux. Some experts believe that may have something to do with pain in patients with achalasia. Now, having said that, is there a big evidence? No. If you want to know more about the role of longitudinal muscle fibers in health and disease, I think there are multiple articles from Dr. R.K. Mittal, which we need to see in detail, because what he has pioneering work, he has done a lot of pioneering work regarding the role of longitudinal muscle fibers. But as of now, we don't have a way to gauge the function of longitudinal muscle fibers. Whatever we see on manometry, I think it's only the circular muscle fibers. What is the contribution of longitudinal muscle fibers in the generation of symptoms and all, we don't know as of now.
Jahir, what is the risk of bleeding during myotomy, and which part is most prone to bleed during myotomy?
So again, it's the D junction. After 3 centimeter of myotomy, I often see a big vessel popping around, right? Probably a branch of left gastric artery, which is like a big popping vessel, which I often feel that if it bleeds, I won't be able to control that bleed with my traditional
Jahid, the branches of left gastric artery will more see in the anterior poem rather than the posterior poem. What do you think?
We do see some. We do see some. And this is what because when I was going through literature, what is the most prone site of bleeding and which is the vessel which is giving that branch. So the Japanese they tell that you should be extremely cautious at about 3 centimeters beyond the junction because there is a big branch of left gastric
Zahir
artery.
sir, sorry, we just have to shift to OT1 for our last case quickly. Sure, thank you. So 62-year-old male who had jaundice and there's an indeterminate biliary strictures. Previously, we have done a cholangio, we have taken biopsies, we have done an EUS and PET, but there's no diagnosis. So the plan is to repeat a cholangioscopy on him and see what kind of stricture is this. Dr. Anthony Thew will demonstrate. So we are going to OT1 for the last case, Dr. Anthony, sir. Sir, you work live for you.
Hello. So we have just removed the plastic stent for this patient. I think the plan is to perform a repeat cholangioscopy for this patient. I think he already had 2 previous spyglass done. Okay. Should we do a cholangiogram first? Just use a spyglass? Okay, no problem. So in the interest of time, we'll do a cholangiogram through the spine. That's one of the options. Yeah, yeah. Easier. Okay, so we'll lock everything. Pull back. Cannulate with spy. Okay, so the spy has gone in. I'm gonna relax the scope a little bit. Okay, can we flush the water?
Is there a imaging available? MRCP done? What is the level of the stricture?
The level of stricture is in the CHD. Okay. Can we do a cholangiogram first, actually? Okay. Can we have the fluoro, please?
Tony, how do you interpret your images once you just pulled out a stent? There would be a lot of trauma, there'd be inflammation.
Yeah. Well, I think first of all, I'm gonna do. Can you inject some contrast and show the cholangiogram for us, and see where the stricture is because right now we don't know what the stricture looks like. Fluoro, thank you. Okay. So looks like there's no stricture. All right, I'm gonna insert the spy a bit deeper because does anyone see a stricture? Maybe higher up, right there?
Do you have a resistance to push the scope in?
Yeah, I'm pushing the spy up to the stricture site. All right, okay, great. Okay, no need contrast. I think we can suck out some contrast And then right here, we're at the stricture almost. So I'm going to push it in a bit more, the spy. So actually right now, everyone here can help me and give me some hints as to what you think. Because right now I don't, for me, the blood vessels, vasculature don't look so bad. Can we suck out the contrast? And I've already passed the stricture. Okay, can we have fluoro? So I'm beyond the stricture. All right, can we suck out the contrast? There's too much contrast. Suction, suck out. And then let's suck all the contrast out and then inject saline instead. Okay, great. Okay, now inject saline. All right, so this is beyond the stricture. I'm going to pull back my spyglass a little bit. Let you see the mucosal patterns. I'm going to pull back a bit more. Thank you. I'm going to pull back a bit more. So here is almost at the stricture site.
Can you show the fluoro again?
Fluoro, please.
It appears to be a very short segment, single
Oh,
stricture.
segment stricture, exactly. And then the blood vessels.
Appears to be more of inflammatory rather than.
They don't look too bad, is it? I don't see any mass, any
Yes.
growth.
Yeah. Not much of blood vessels, inflammation, ulceration.
Yeah.
It's more of a fibrotic.
Yeah. More like fibrosis, right? So, I mean, he had 2 previous negative biopsies already. And after a prolonged period of stenting, I think whatever inflammation was there actually now has subsided. So I am actually leaning towards just a benign stricture, I think. What do you guys think?
Here it looks little suspicious. Okay.
Oh, I can't get a good view here. I'm gonna push.
Disease?
Yeah, post-stenting.
Could it be IgG related disease?
Of course, we can do more biopsies and then check the IgG4 levels, but honestly, I don't think the stricture is so tight because my spy just goes through super easily without any cannulation, any guide wire. So does this patient still need stenting, or should we just add 2 plastic stents, 3 plastic stents, and see if the stricture improves?
I think we can increase the
We'll
plastic
just do
stents.
a quick biopsy. Make sure.
Would you go for a fully covered sense in this kind of a stricture?
Fully covered stent. Yeah, we can of course go for it. There are pros and cons. Pros is you can just place a fully covered stent and place it for 6 months or 1 year and reassess. Of course, the stent has chance of migration, so and it's more expensive. So,
Sir, we'll just go to Zahir sir for 1 minute and then we have to end the live here because we have another live coming from the International Center.
okay, thank you.
Yeah. So Zahir sir, for 1 minute only we are coming to you and then we're cutting off from here.
Right. Please let me know the minute it starts. My minute when it starts. Started? Yeah. So here we are finishing the myotomy. You can see that this is the last part of myotomy. It was really a very tight tunnel. The G junction was very tight. So
we have not so far coagulated this vessel, and you can see one big vessel running here. This is the same vessel. So we don't intend to touch it. This vessel so far has not disturbed us, so we won't disturb. And so we just go by the side of this vessel, and so I think this is just to show you the fat that you can see here. This is again a marker that you have reached, you have crossed, and because this fat is very prominent when you extend your myotomy into the stomach. So this is again one of the markers that definitely you have crossed the D junction. This is all the myotomy. This is a long.
Golden fate.
Long myotomy and very thick muscle. So hope this patient gets some relief. I think the D junction must have relaxed by now. And before we could not cross, but now
It's widely open.
It's widely open.
Very.
Thank you. Thank
Very
you.
well done.
Excellent demonstration.
Thank you so much, sir. Thank you so much. I
Myotomy.
think we will cut for Hall A from now, and we will go to the live international center, and you can proceed from there.
I thank the moderators and chairpersons for this session. For our next session, that is the live procedures from International Center, I would like to call the moderators, Dr. S.K. Sinha, Dr. Varun Gupta, Dr. Narayan Agarwal, and Dr. Karamveer Chakravarti. And I'd like to call the chairpersons, Dr. Kapil Jamwal, Dr. Manish Tiwari, Dr. Amitabh Jarat, and Dr. Rajiv Shandal. I would like to invite Dr. Professor Nalini Gudar to introduce the faculty performing the procedures from the international centers once we are live.
Good evening, everyone. So I'd like to thank all of you for being here. There are a couple of international sessions that will be streamed. I'm going to take a minute to introduce them, and then I'm going to hand over the podium to the moderators. First, I would like to thank Dr. Christopher Thompson, who's a professor of medicine at Harvard Medical School, and he's at Brigham. He's one of the pioneers of bariatric endoscopy. This was a last-minute request from me to Chris, and Chris is obliged. Chris and his team are ready and waiting to show an endobariatric procedure. I think he's going to, Chris, are you able to, are you audible? Am I audible to you, Chris? Yes. Okay, Chris, I'll hand it to you. All right, it's bright and early, looks like you had a lot of coffee, and we can hear you loud and clear. So I'm gonna hand it over to the rest of the team. We can see you, Chris, here.
Oh, there you go.
All right.
All right. Thanks so much. We really appreciate the invitation. We're here in Boston with our team. See Sherry next to me, who's our therapeutic nurse. We have, I'd say, we might not camera, but you probably see her coming in and out to our guest fellow, looking for a job. We have Susan, anesthesia, and we have Sam, who's our coordinator who allows that for and a sports team here actually as well. So with that, we're ready to get started. Wishing you could be there with me in person. Love that conference. That's my best. You can tell the cops about it. And Yala is actually quite proud of it. So she is gaining more weight. She had this procedure back in 2011, and she lost 100 pounds or so. And then unfortunately kind of came back on. Right now, her BMI is really going to be 51. It's going to be pretty loud. So she needs to proceed to help her. So what we're going to do is a course. We're going to go out of production. We started this procedure way back in 2003, so not interesting. And it's about overtime, and we will talk about that. So first, we're going to start with turkey hydrometer, and we're going to inject fluid. We're going to do the PSC all around the solid to expose the muscle. This works a lot better when you third phase in these procedures, whether it's a PSC primary procedure or it's the margin, the gastric, and small bowel margin right here. So we start on the gastric side, and we start on the button right here. We generally have a pressure of about 30 bar. You see, we're seeing a lift going here. It's very scarred down. That's okay. This device can really open this stuff up for us. Then we're going to start cutting into it. Turn up to speed. You kind of see what we're aiming to do here in a minute. It's sitting all the way around. It's bleeding a little over here, so you don't expect that. It's very scarred when around soft. Perfect. Yeah. And we'll keep going. And then conventional injection of that fluid, so you can try to control where it's lifting. You can put a look at that reading source. You might be going from that around the side of the later. Well, this is really important to provide third stage bariatrics, in my opinion, to get much better long-term results. It does help.
Excuse me.
It goes a little bit longer, but
Could we have some clarification? I mean, could we have some clarification what's happening, what we are trying to do?
yes, absolutely. So what we're trying to do is we want this person to lose weight. And there's several studies that have shown, here, let's this out. Several studies that have shown that the main reason for weight gain after you have to bypass, provided that you don't have a medical reason like, hypothyroidism or something like that, is dilated gastrointestinal acidosis. And the bigger the acidosis is, the more weight they gain. This person is gaining 100 pounds, and we know that cutting this out of that back, make this out a little bit more snug. There'll be more resistance to the food, and food stay in the stomach longer, and the person will lose weight, right? So the idea is to do a gastrointestinal anastomotic reduction here, or a 4% transdermal outlet reduction. That's the name of this procedure. So it had been the number one surgical procedure for the economic device for a long time. This is the one procedure in the U.S. the insurance coverage for. So we also have a lot of patients that have bypasses around the ED procedures. There have been studies that compare this to surgery. You get much weight loss as you do with surgery, but the complication rate is much lower. Main thing is, you can't just put a couple of antibiotic sticks in the body. It's not going to work. They'll lose weight for about 6 weeks, put it right back on. You need to do two things. Number one, prepare your tissue off. And that's why we're doing this ESP. And the other thing you have to do is you need to put a portion of suture all the way around. And that's pretty critical. So we're in the first stage of this, which is the ESP, the circumferential ESP around this outlet. And then we'll show you the second stage, which is going to be first and suture. They have to be circumferential. It's not that hard to do once you kind of mix it. You got to mix it. All the way around. So it does require it's probably a little more experience. If you're starting off with you probably want to start with a simulator. And then eventually, after a couple of weeks playing on the simulator, that's what our fellows do. You're going to have them move over to doing the actual procedure. And generally, after they work on the simulator, you're able to do these fairly quickly. little scar. And so it's kind of popping out right there, what we're trying to do. And we're okay. What we can do in this situation, we can increase the pressure. I don't want to do that necessarily. So this is actually a pretty good way to learn ESP as well. It's very safe. You're also there generally incorporate through the small valves. You don't generally get incorporated in this procedure. And the way we do our ESPs now are proper procedures. By the way, the first application in the world was done at Endocon when it was in Calcutta. And we did that in 2012, live broadcast, first case. So kind of exciting. I've been working on it for a long time, animal models. But we did the first ever cases there. I don't know if any of you were there for that. It was kind of fun. But now we've actually modified that. So we actually can do third space elements ESG as well. So we try to do a myotomy with ESG to really help with the ESG acting. Also, all the way around here, it's got to come back into that spot. Yeah, so then we'll start doing our suture. All right. So there's a differential exposure right there. Now we're going to go around and make sure we don't have anything still bleeding. We're going to switch over to suture. You can tell we're circumferential and muscles exposed all the way around. We're going to be able to do purging now. We'll talk, we're doing that purging about why it's important and the kind of principles behind why it's better to think about procedures. But in general, mucosa doesn't want to stick to itself. Its main job is to not stick to itself, otherwise you have leakage, right? So it's really hard when you're doing suturing inside the body to get it to be permanent. And the best way to do this is to remove the mucosa. You see a staple right there. I'm not seeing any big vessels to worry about. So, trying to almost make it bleed with this water cut, so I get rid of any of the bigger vessels. Right here, we got something over here. A little bit about ready for these. It's really, there's no real ongoing bleeding here. So then what we do is after we expose that muscle circumference, we use an APC probe, and we will ablate the inner ring mucosa. And then we'll do the first ring. So we read APC, we do high power APC. This is going to be force APC, 70 watts. On a really high this intervening mucosa here across.
Chris, looks like you're having fun. Looks like Star Wars from here.
I have a question.
Looks like there's a question from the audience.
Why are we using the forced APC on the edge so that we can suture it better to get a hold of the suture?
So, Chris, the question is that why are you doing forced APC around the cut margins? Is it to scar, or is it to make sure that the suturing gets better with the fibrosis?
The two reasons why I like using the APC. One reason is that it will kill off that 13 mucosa, so that it's not going to grow back in the issue for us. That's number one. Number two, you want to reduce the scarring. There's a study out of Brazil that shows that APC alone can lead to weight loss in these patients, which is pretty good. And then the third reason is it does seal some of those vessels. So if any of the vessels in there, you kind of miss, it'll seal them up. So that's the end of tissue preparation. It looks like a really good target we have. But we're going to go back down to the suture now. So I'm going to change over to suture device.
So, Chris, I have a question while you're getting ready for suturing. So you had trouble with the scar tissue, and what if you cannot get all the way 360 degrees? Can you just, come to the area where there's dense scar and cut the rest of the things?
You could. I have to say we've done about 1,000 of these, and we always get it all the way around with the exception of when there's a hernia. And it's a very small pouch. So if the pouch is like a centimeter and we have a hernia and a diaphragm right there, then we can't go all the way around. We do a little press incision. And we will actually only suture where we have exposed submucosal canal. So we won't suture in the mucosa. This is going to loosen up and fall out anyway. So we can't expose it, we don't suture there. Now, if you try the ability to do yes, on the outlet, you can just do APC before. It doesn't work as well, but it is something that you can do.
So, Chris, I was in Calcutta when you did the first ESG. That was the year when rectal indomethacin came into play. So,
that was really fun. I remember doing that myself, Rob Hodge, Filipino, there's medical student over projects. It was a lot of fun, and looking forward to coming back and doing this year in the future.
so for the sake of audience, do you put an overtube in these situations, or you just intubate without an overtube?
I use an overtube, but honestly, a lot of friction that is generated between the overtube and so it tends to move around a bunch, and I stopped doing it some time ago. I'm just trying to think out where I can see there as well. And I found that, it's better. The only thing you have to worry about is you bend the needle. And when I go over to see go back into, you can have a real problem getting this thing out. And you can get a staple or many other things about that problem happen. So we're just very careful. When we follow startups, we always have to use an overtube. So we're not in position now. And what you're going to see is that we're going to go inside and out. We're going to use, we always have a recipient device in the exposed muscle submucosa right here. And we're going to go around kind of clockwise. So we're going to start off at 5 o'clock. Very good to start at 5 o'clock. Later, we're going to stitch this. We're going to put a balloon down beside it. It's like a surgeon who is over a roof. And we want people to see what we're doing. So before to start at 5 o'clock, otherwise you won't be able to see. Now, this is a good example of what I don't want to do. If I can just stitch like this, I would lock that structure itself. That's bad. Because you're going to have too much tension and not be able to close it. So what you want to make sure you do is do an unlocked, simple running suture, right? This way, it's not going on, you have to be very careful for every suture, whether you're going to ESG or whatever you do. You see that needle go on the needle driver right there. Okay? So I'm trying to demonstrate that you've got to really pay attention to that. There it is, it's on. Then I go to do what? I don't look at this. Now it's
do you recommend going about a centimeter or half a centimeter away from where you have cauterized so that the tissue is healthy to take a bite?
So, positioning is not great. So yeah, I like to go right to the muscle. So I'm kind of like, the deeper the better, in the sense that it pulls up anyway. Just going right out to the muscle there. And as long as it's comfortable that muscle, I'm pretty happy. There's one issue sometimes you get into this advice now, it does a lot of load, and I don't know if you can tell, it's like, not quite loading properly. But it's going to slow us down commercially. If we could really move quickly, it just wasn't being a problem. But here it is. It's rare that that happens, honestly, but it's okay, it's going to show it. So you see the needle comes through right down there, boom. You kind of see it. You pick it up, and then we're going to reload again. So the idea is, and there we go, one on nice. The idea is rotating all the way around the table here. I want to be careful of that. Now, I didn't expose this area. Let me see that table. So, now this is going to need to find a suture. You can't avoid that. So, let's see this one out, please. That's what I want. Again, you want to be sure to pick up on the point. It's whatever direction you're going, you want to pick up and go. But moving, well, turning around.
So it does, what is, so Chris, does not matter whether you go clockwise or counterclockwise, whatever is easy and convenient?
Well, we're trying to do some benefit of having fellows over the last several years to develop this. We made it as easy as possible now because the fellows would struggle and kind of back to the procedure to make it easier. I want to be able to see what I'm doing and teach the way it's kind of frustrating, but I'm pretty sure that's not. Here we go. So you want to see that needle replace it. But what we found was regarding the question, it seems as though it's easier to go counterclockwise. Because when we're doing it clockwise, the fellows are struggling more. And now when we shift over to counterclockwise, about 15 years ago, we do it a long time. About 15 years ago, the fellows had much easier time with it. So that's kind of what we're doing that. So when we get halfway around, we generally look at the device. We're not there yet. One more stitch. That just makes it easier because you're not putting yourself to a press to do this. So you kind of see how I'm really lifting after I pick up the needle and go in and do that. That's how halfway around it. So at that point, you put the device this direction. It's a little bit easier to do. We're almost all the way around. Then we're going to try to get in 10 or 12, 14 stitches. The suture devices are amazing and able to so many other procedures, right?
Nalini, so while taking the stitch, do you apply a light suction so that you get more mucosa inside, or what is the technique?
Sure. Chris, the question is when you're suturing it, do you apply some gentle suction to oppose the two cut surfaces on either side of the mucosa, or what's your technique to bring them together?
I am actually suctioning. That's a good observation. I'm suctioning basically to hold it in place, though. So I want to make sure that the stitch is exactly where I'm trying to put it, and I think that it helps to anchor it in place. So we're all the way around now. You can tell. So I'm going to do one more stitch on the left and then cross over. So the last stitch on the left. You guys see it's always coming out right down there, right through the muscles, what you want. And then I pick it up on the right, this is the kind of the last stitch right here. And we cross under that first stitch. We get all the way around. Okay. Now we're going to drop that and then size it over the balloon. we're putting a CR balloon down this dump channel silk, right? So we're putting the CR balloon down the smaller channel on the left. We're going to size this out over the balloon.
So is the CRE balloon for you to size, Chris, about how much lumen you're leaving? Is that why you're doing it? Or just to make sure you're not closing it shut? Would you?
First rate, we had a very high stenosis rate. About 25% of people got very stenosis. And instead of coming up with a balloon dilatation, we need to actually extend a lot of time. This is problematic. So you don't want to go too tight. Or what happens is too tight early on, and they vomit the air resistance before it goes. And then you have nothing, and you gain all, it'll lose weight.
So do you dilate after cinching or prior to? Because I see your cinch device out.
So what I'm going to do here is I'm going to size it right around this balloon. So we basically are going to set that at about 7.5 feet from the end. And then we're going to put our cinching catheter out. And we're going to, I think you should have set it out. Jerry's going to hold that. And then we're going to pour on this and go down around the balloon. See how that goes around the balloon? So now we know where's the correct size. And this is really the most predictable way to do it in our experience.
So did you say 7.5, 8, or the CRE balloon that you used is what, 10 to 12?
Yeah, so that's a 7.5 to 8. We're going in what PSI we're putting in. Good. Yeah, so 8 PSI. So we're estimating about 7.5 when we did it that way. For that, so keeping the actor down is a little bit more portable move that. And it's a little bit of a back and forth dance that we do here. You get it just perfect. And now that it's securely around the balloon, you better take that. There's some sinking, nice. The balloon's gonna go down. I noticed the not going to be illustrating that. As our final outlet, it's a lot smaller than it was. This is how you get surgical quality results in an endoscopy. When I hear surgery, for instance, good tissue preparation, a good suture pattern, and then you just execute. So this is a beautiful looking outlet. We're very happy with that. Of course, we're going to lose a lot of weight. Probably lose 15% of their normal weight, which is great. As I said in our comparative studies, they lose as much weight as they would with surgery with far fewer complications.
Great job, Chris.
Now generally is, I do a reinforcing suture, you know, a squares, I generally do a reinforcing suture next to this.
Chris, great job. Before I let you go, I just need to know what the post-op care is. Unfortunately, the moderators here are unable to communicate with you, so I'm looking at their eyes and reading the questions. So what kind of a post-op care do these patients need? Do they get observed overnight? Do they get discharged, clear liquids, regular diet, PPI therapy?
Yeah, great questions. So generally what we end up doing is we will keep them overnight to bring them. However, in other settings, so I also have a practice that I work in. In the practice, we send them home. So it kind of depends. I like to keep them overnight because you can get them out of the fluid, different launches, and you can kind of get nice chemistry, and I find it works well. The reason being is that insurance companies, really, when we're doing insurance, they request them to keep them overnight. But when patients are paying for it out of pocket, it's kind of expensive to do that. So we've had success in both ways. But I'm going to interrupt the to reinforce this. As far as their diet goes, they are a 6-week liquid diet. So, plenty foods up, protein shakes, etc. And the reason we do that is It takes 6 weeks for most people to heal compared to their most things survive in about 6 weeks. And these people, they don't feel like they want to go to them anyway. This is very small. And so to give them a little medicine talk, we have them sit very carefully starting tomorrow. And you know they're right. They'll start sitting very carefully tomorrow. And the range is being specified.
So, I have a question, Chris. 6 weeks of liquid, I presume you'll tell them not to stop at McDonald's and buy a big milkshake.
Thank you. Good point. Yeah, we want to make sure that they're adhering to certain caloric requirements. So you can see this at the end of the procedure here. That's the outlet, that's the course. You got a nice little pile. Yeah, so we want to make sure they have high protein and low carbohydrate and enough food. The main thing is constipation, honestly. She's not even going to pain. She's going to wake up, maybe feel some nausea. That's about it. But the constipation can come up. So a lot of times we'll go out prep the night before, which is the first we have. Clean out most of the stool, and then we put them on Miralax. And kind of try to liquid thing. Especially because of the safety itself and constipation. So that's pretty much the goal there. And also the other important thing is we want to get exercise. If you need to do resistance training, you don't have to run a marathon. Right? You need to have them doing resistance training from day 2. Because if you're losing weight, it's like you're downsizing from a big house to a little apartment. You're going to probably stuff you don't use, right? The body does the same thing. And it's going from a big body to a small body, and throwing out the stuff to do. If you're not doing the muscle, you're going to lose that muscle, and it's set up for weight gain later. This is an advantage, not scheduled surgery. They can start exercising literally the next day, maintain that muscle mass, and that's why we have such good long-term results.
Any questions from the audience before I let Chris go, please? Thank you, Chris. I know you were not supposed to be at Brigham today. Thanks for coming in extra to do this. The audience here appreciates that you're here to do this procedure for us early in the morning. Thanks to your team.
Yeah, thanks very much.
We have one. All right, thanks, Chris. So we'll sign off, and I will. We have one more session. Dr. Barham Abudai will be joining us from Mayo Clinic at Rochester. He wanted to show some new technologies. Unfortunately, there he is. Hi, Barham. Are you able to see us? We can see you.
Yeah, I can see you.
Yeah. So Barham is going to show some of the new technologies in metabolic endoscopy that will be coming out soon. So he'll be demonstrating. Barham, there's a little bit of a audio issue for the moderators here. We have 3 moderators, so I'll be standing by in case there's anything. Over to you.
Thank you. Can you hear me okay?
Yeah, we can hear you fine.
Well, good evening, colleagues. It's always a pleasure to be with India, my colleagues in India. We are here from Rochester, Minnesota. It's about 7:37 in the morning here. And the thought in this session is to show you what you would like to see in practice in the next 2 to 5 years horizon. There's a lot of innovation happening in our field. And we thought we would showcase a few of the devices which we gathered for you to demonstrate. And then to show you a couple of cases where we use these devices, mostly in the setting of clinical trials at this point and early device release. But you will get the point of the clinical utility of these innovations that will continue to reshape the future of our field and the emergence of the new field called surgical endoscopy that includes the bullet and the electric endoscopy as part of it. So we'll start by showcasing the technology themselves. So I'm going to go on the other side of the camera here. We will demonstrate 4 devices here, and then I'll show you 2 cases where we use these devices after that.
The first technology that we're going to demonstrate is a new suturing platform, which is an evolution of the different iteration of the Apollo overstitch. I saw that Dr. Thompson demonstrated the Gen 2 of that device that requires double channel spool to do suturing. The next version of this, there is after the Gen 2 of the Apollo overstitch, there has been the single channel called the overstitch SX. And now the third iteration, actually the fourth iteration of the technology, is the overstitch NXT. And the overstitch NXT has multiple advantages, including it being single channel platform, number one. Number two, it allows retroflexion and suturing and retroflex position, which is a very nice and unique feature. And third, it allows full precision control of the helical retractor. So the physician controlling all parts of the equation, and those who do suturing realize that the helical retractor is an important part of this procedure, but also a liability if you don't do it well. Therefore, now we're going to show the setup of the NXT device. We're going to demonstrate its features, then we will keep going with this technology showcase. So I'm going to flip here. I have my colleague Jim, say hi here, who is going to demonstrate the setup of the NXT device. And we just want to show you that now this is enabled by any single channel gastroscope. And eventually even fluoroscope down the line. So here is adding the handle of the NXT device. And then this is an 190 HQ series Olympus gastroscope. We're now aligning the sutured arm to the side of the endoscope. And now we're anchoring the suture device itself using this strong paint material. And we're anchoring it throughout the shaft of the gastroscope. So you can see there's the suture device. It is nicely paralyzed. So you can see in a very short period of time, we took the device and we set it up on the single channel platform. So now I'm going to show you some of the features of this device. The first feature is the different channels of this device. There is the channel that allow you, there's three different channels now, which have, that gives us an extra channel because it's a standard device. One channel right here takes the suture and the needle driver. The second channel takes the helical retractor, and that channel is now open to allow suction and good clearance of the field while we're doing these procedures. And as you realize, sometimes these procedures could get blood. So here we're going to take that needle driver and we're going to load it into one of the channels of the device where the suture is coming. And now I'm going to turn also the light of the scope so you can see what's happening on the scope on the monitor as well. And here is that needle driver coming out. And now we're going to take that needle driver and we're going to transfer it to the device itself. And now it's locked and loaded to proceed with the suture. The new feature here is the helical retractor. It used to be the helical retractor is an assistant doing the helix management for the doctor. Now the helical retractor has changed, and now you put it in the second channel. And you can see now on the monitor the lyrics is coming in fast to the sutured arm in the same frame. And now the physician themselves is able to manage the lyrics by retracting and pulling on tissue. Now, the most important feature and the change in this device comes from this retroflexion capability. I will demonstrate here. You can see that there is clutch mechanism right here, and that clutch mechanism allows you to retroflex and bend the angles of the suture in angles that are not possible with standard gastroscope or standard endoscopy. So I'm going to further demonstrate standard movements without the clutch device, and then show you the difference that the clutch device will make in getting to articulate, especially as we do suture and retroflections for nerve indications or other indications down the line. So here initially I was going to do the standard maneuver with the big wheel, and you can see that the angle that we can get to at best is this 90-degree angle. Alright, I'm going to lock it here and show you that that's the best that we can do with the gastroscope is a 90-degree angle bend radius for suture. Now I'm going to stabilize this, and now I'm going to use this clutch, which is what it's a pulley system on the suture device itself. And now if you focus on the tip of the bending angle of the gastroscope, and now what you can see is with pulling on this, I'm taking this into a full artistic cavity orientation. I will lock it here, and now I'm able to open and close, push the index, retract, and suture in a full retroflex position that is not possible with the standard gastroscope wheels to get there. So that is the features that NXT is having. It's a single channel platform, 3 different channels, allow you to assume this retroflex suture position, so you can do the suture in any angle within the GI tract, and there's a case that we're going to demonstrate the utility of this functionality of that device. Now we will I'll show you the next technology here, and then we'll go to do some cases with them. This technology is called electroporation or pulse electrical field. It's a technology that's called reset technology, which is recellularization of the GI tract of the duodenum using athermal, so the no heat generated pulse electrical field to regenerate both the mucosa and the submucosa where the nerves are in the duodenum for the management of type 2 diabetes. Now this is a platform technology. That means this energy modality is new to GI. The ability to not lose heat and regenerate even in the deeper layers of the gastrointestinal tract is a new disruptive technology in GI. And the way that we do this is we use pulse electrical field. What does that mean? You're emitting high voltage electrical field, but only for fractions of a second, or nanosecond pulsing. And this is enough to disrupt the cellular membrane of any living cell while preserving the extracellular matrix and preserving the vasculature within the system. So you can regenerate nerves, you can regenerate mucosa, you can regenerate cell mucosa, but you're not going to affect the extracellular matrix or the blood vessel, so you can do it with high safety. You do not need to worry about lifting anything because there is no heat being generated, so there is no spot formation, and this is becoming a very cool modality that will produce many possibilities in treating multiple diseases in the GI tract. But the focus of this catheter is to regenerate the duodenum for the management of type 2 diabetes, and that's what we're going to demonstrate in that case as well. So the concept here is we administer the electrical field, and the ability to administer the electrical field is happening at the level of the electrical circuit. So there's a catheter, and there's a generator that allows you to do this. expand, once you get the target, you're expanding into the duodenum and you're exposing multiple flexible circuits. You can see there's four flexible circuits in the circumference of the scapular. Now, this cuts the duodenum. You can see these holes in these flexible circuits. This will apply gentle vacuum. So now that the duodenum is hugging the structure, you do not need to lift the submucosa in the process. And then you just stick it on a pedal, and that emits the electrical field. And this generates this mucosa and submucosa where the nerves are of the duodenum in order to manage type 2 diabetes. Once you're done with the first treatment, you just constrain the flexible circuits and advance a few more centimeters, open it up, and what you're going to do is you can do 6 treatments along the length of the duodenum, which end up being about 12 to 14 centimeter segments of that duodenum in that process. So we will demonstrate cases for both of these, and we will take questions while we're demonstrating some of these cases when we do that. But before I go there, this was going to be a showcase of what's in the pipeline, what's available, what's coming soon. We're going to have newer platforms to allow you to locate the GI tract. This is the deciduous operating platform that allow you to have multi-access to the GI tract, and you can now lock the shape of what you're trying to do and introduce locations in the GI tract. And this is a cool technology that allows you to do bariatrics, and in the future, called the reflux and other surgical endoscopy type of procedure, given its shape lock mechanism and the multi-pronged approach. And those who have not seen this before, this is the esophagus technology that allows you to do a quantification, and in this quantification in the GI tract for reflux. And the principle of that is it's a tissue mold, that the tissue mold is once verteflex in this position,
Suraj,
allowing you to
माइक पे आओ
create a wrap
सूरज
the stomach and the
चला गया
esophagus in
अभी मेरा आ रहा है
270
मेरा आ रहा है
degree
ये हॉल ए वाले पे आ रहा है ना
for management of
उस पर
reflux.
टेप
Some
लगा
of
के
you
हॉल
have
ए
seen
लिखो
this technology.
और हॉल बी
I'm
वाले
going
पे
to
जो
look
वो
at
लाइव चल रहा है वो आ रहा है है ना
show you some cases in the NXT and the research procedure, and with that, we will switch
ठीक है
for
उसको हॉल बी वाले को कम रखना
which we
ऑफ
have
करना उस
on
चैनल को
WhatsApp, and we will end from here.
ये चैनल को ऑफ करो हॉल बी
Wrap up here.
अब मुझे एक चीज बताना इंटरव्यू वाले रूम से हमने आउट लिया हुआ है
Barham, looks like you're making the scopes bigger and bigger. On that, you had like 4 channels going out when you attached. How big
क्या
is
आउट
it?
किया जा रहा है वहां से जो यहाँ आ रहा है वो आउट
Bigger
क्या
than
है एसटी
2T
है
scope from here with four different accessory
एसटी है ना
channels going down. I can't hear you. You're muted. Barham, you're muted.
That's right. With the two
तो
accessory
जो
channels,
हॉल एसटी
about
अगर है
6
वो
millimeters. So
तो जो हॉल
this
भी
will
है ना
allow us to put a lot of equipment and a lot of
सूरज
innovations coming, but it's
हॉल
going
बी
to
का जो है एसटी ऑफ है
allow us to do
हॉल ए
surgical
का
endoscopy like procedures. So now, in the last few minutes,
ठीक
it's
है
going to show you these innovations in action. And
ठीक
we're
है
gonna go and do that. I'm gonna put my slides here. Let me know if you see my slides.
Yeah, we can see it. Endoscopic innovation.
All right, excellent. So the first one we talked about is this overstitch NXT, and again, just to highlight the features, it's 3 channels. Now, the decision to control the reflex, and that's today coming factor or having a so no longer that system is controlled the reflex, and the reflex is coming in the same suture plane as the suture parts. And then there's a feature of doing this inverse flexion, and this is allowed by this clutch mechanism of this platform that now suture in inverse flexion. So how is this useful? against the limitations in the United States, but already we found it to be very helpful for our patients, and I illustrate in case that this is a big obstructive fibrovascular polyp in the esophagus. 8 centimeters occluding the esophagus, and the patient is having severe dysphagia and not tolerating feel. It's got on ultrasound, there's a big feeding vessel to the celiac, and the feeding vessel is coming to the G junction with the calculated blood supply. Now, this is not going to be fun because you're not going to get that big vessel. So here we see the bodies, the AXP bodies. Now, the important question is called counting in the G junction. I used to summit, and now I am lucky the big vessel of the calculated portion of this large fibrovascular problem before resecting it, because otherwise you will have significant bleeding if you do not control the blood supply, and the hemoglobins themselves are not enough to do this ligation. And the standard surgery device is not capable of making it to the circumflex angle in order to allow you to ligate the blood supply of this region. And here now we're creating a figure of 8 suture. We're using the inner retractor and we deploy 2 sutures at the calculated portion. We are releasing the T-tag in the process. And now we're going to stitch the figure of 8 suture at the calculated portion of that polyp. And now this is ligated, and you can see there's not control of the calculated portion of it. And now starts the hard work of trying to remove this. Obviously, there's no snare that can fit into an 8 centimeter polyp. So we resected the part of it, and we continue to resect it in different increments. You can see we resected half of it in the first snare cuts. We're using a tube for this with a large snare. And now we're resecting the other portion all the way to this way, but you can see the bleeding is well controlled because it's being ligated. The big bleeding vessels demonstrated on ultrasound of this lesion. Here you see the blood energy that it takes to get this, and you're not able to get it over one piece. So finally, we cut the bigger portion here. You can see some bleeding, but bleeding is mostly controlled because of the ligation of these vessels. And now we're removing this the portions of the ligated.
Your screen is frozen, Barham.
Can you see now?
I can see the screen, but now it's moving, yes.
And now you can see the entire column is removed. And all the way to the osteochondrites. And where that goes in the speaker, but you can see that there's no bleeding in removing this fibrovascular polyp because we ligated the vessels at the initiation of this procedure, and the patient did well and was discharged safely from the endoscopy unit with no issues after removal of this 8 centimeter fibrovascular polyp from the esophagus.
So, Barham, I have a question. If it's a fibrovascular polyp and you've already gone and ligated the vessels that supply it, could you just leave it at that point and let it shrink? Because in the old days, when you had a big polyp, they would just inject epi so it would shrink. But here you cut off the blood supply, just like the IR people would do for a tumor, which I think was very nifty. Can you just stop at that stage, or do you still need to go and resect and risk the bleeding and other complications?
Given that it's fibrovascular, that means it's a lot of scar tissue, it's unlikely that it will just swell by itself being that size of about 8 centimeters. And the patient was quite symptomatic, so we felt that we need to deal with it immediately and remove it. Ligating it alone could have they most of the base of the lesion and around the bone, but given its large stock here and size, we do not think that this is the right scenario for this case.
All right, great.
So now we're going to demonstrate the second technology, which is the reset procedure for type 2 diabetes, which is the non-thermal regeneration of the duodenum for management of type 2 diabetes. And again, here is demonstrating some of the unique features that differentiate the duodenum from rest of energy.
So, Barham, when you showed it, you said you get pulse electrical fields, but don't you worry about the duodenum and the circular muscle folds and the contraction? How do you then achieve a complete 360-degree electroporation over 12 centimeters? So, would it be okay with some skipped areas then?
Yes, absolutely. I'm not getting negotiated in the case. The flexible circuit is designed to allow the European to happen around the catheter, so you can do a functional electrification without worrying about utility. But here we're demonstrating the difference between electrification and thermal therapy. Thermal therapy can begin clogging the glucose. With electrification, you get degeneration by these spores in the phospholipid membrane of the cell to regenerate the structure. So let's go over the case here and we will demonstrate that concept momentarily. So again, this is the thermal injury comparison with pulse electrical field. You can see that there is regeneration without clotted necrosis versus clotted necrosis that you can see with thermal-based lesions, and you can see this is thermal-based injury. You can see the regeneration cascade go from posting of these cells to the mucosa, submucosa, both logical regeneration of the GI tract. And now we have to demonstrate a actual case in the products for this pulse electrical field. This is the catheter, and basically you're advancing the catheter to the small intestines. You do not need any lifting agents because there's no heat generated. You just need a catheter. This is a clinical level. You open flexible circuits, as you see here, and you push the button, and that button emits these electrical pulses. It regenerates the mucosa and submucosa without affecting the extracellular matrix of the organ. And so it becomes safe and becomes feasible technology as the patient progresses in their treatment course. So here's the actual case.
So I presume you use fluoroscopy just here for demonstration, and you normally you do not
So
need
here
fluoroscopy.
is we're placing the catheter in the first portion of the duodenum. You're opening the blood circuits, and you're seeing the blood circuits being overlapped.